He is going to present role of magnesium sulfate injection in acute severe bronchiolitis, a randomized control trial. Over to you.
Good morning, respected teachers, seniors and colleagues. I am Dr. Abhijit Roy, second year resident, Medical College, Kolkata. I am going to present a study on role of magnesium sulfate injection in acute severe bronchiolitis done in our tertiary care hospital. Acute bronchiolitis is marked by acute inflammatory changes in small airways, leading to excessive production of mucus accompanied by bronchospasm. Unfortunately, acute bronchiolitis does not have an effective drug treatment apart from supportive care like oxygen inhalation and hydration. Now, is bronchiolitis just inflammation or inflammation plus bronchoconstriction? Magnesium sulfate, being a smooth muscle relaxant with anti-inflammatory effects, offers good results in relieving symptoms in acute exacerbation of asthma. Various studies have shown that magnesium is a relaxing factor of airway smooth muscle. Nebulized magnesium sulfate is widely studied. Nebulized magnesium sulfate is widely studied in bronchiolitis, where it has shown that it modulates the muscular excitability and influx of calcium across cellular membrane, causing bronchodilation. Magnesium sulfate also decreases release of histamine and acetylcholine, resulting in bronchodilation. Another potential mechanism by which magnesium presents its anti-inflammatory role is by dampening the neutrophilic burst associated with asthma, leading to an improvement in signs and symptoms. Now, there are many studies showing that bronchiolitis and asthmas are interlinked. Respiratory viral infections play a major role in both their pathophysiology. RSV is a major causative agent of bronchiolitis in young infant, whereas rhinovirus is an important trigger for asthma exacerbation. So from this we can say that these viral infection increases the airway hyperreactivity. There are extensive trials showing bronchiolitis in infancy is a risk factor for preschool asthma. Acute bronchiolitis may be the initial presentation for pediatric asthma. Many of the preschool wheezers present as acute bronchiolitis who are forerunner of asthma. There are many studies regarding use of injection Maxulf in pediatric asthma and use of nebulized Maxulf in acute bronchiolitis, but studies regarding its IV use in acute severe bronchiolitis is lacking. Viral infection causes immune and neurogenic inflammation, leading to bronchial hyperreactivity and airway shrinkage, thus production of wheeze. Some individuals are genetically predisposed for causing wheeze. By atopy, bronchial reactivity increases and airway shrinkage occurs, thus wheeze may occur. Now in asthma, it has been studied that IV magnesium sulfate is better than nebulized magnesium sulfate. So can this be extrapolated in our study? But IV Maxulf has not been explored in bronchiolitis, which could be a treatment modality in ICU. The primary aim of our study was to compare magnesium sulfate versus standard therapy on improvement of clinical disease severity score of acute severe bronchiolitis. The secondary aims were assessment of reduction in need of mechanical ventilation, duration of ICU stay, readmission rate, and decreasing mortality with injection magnesium sulfate. It was a randomized single center unblinded pilot study approved by the Institutional Ethical Committee for Human Research. Informed consent was obtained from the parents and the study period was of 5 months. Children of age 28 days to 24 months with acute severe bronchiolitis were included. GCS less than 10, severe metabolic acidosis, chronic lung disease, cough or gag reflex impairment, upper airway obstruction, end organ morbidity and hemodynamic instability were excluded. We included patients of acute severe bronchiolitis. Severe bronchiolitis being defined by inspiratory and expiratory wheeze, not interested in feeding, requiring oxygen, severe chest indrawing with nasal flaring, irritable or lethargic. They were subjected to inclusion and exclusion criteria, and randomization was done on computer site generated table and divided into two groups. One received standard treatment and other received standard treatment with injection magnesium sulfate. Serum magnesium levels were checked at 24 and 48 hours and the two groups were assessed. The morbidity and mortality parameters were assessed by escalation of respiratory support, inotrope requirement, and duration of PICU stay. And clinical assessment was done by modified respiratory distress assessment index. These parameters were checked at 2 hour, 6 hour, 12, 24, 48 and 72 hours. The outcomes assessed, the primary outcome assessed was RDI score at the predefined intervals. Secondary outcome assessed were escalation of respiratory support, length of PICU stay and mortality. The statistical analysis has been carried out via SPSS version 29 and sample size was 31. This is the respiratory distress assessment index instrument where the two variables are wheezing and retraction. These were the baseline characteristics which showed that there were no difference, so the two groups were comparable. Results: out of the 31 patients who fulfilled the inclusion and exclusion criteria were randomized, 16 received standard treatment and 15 standard treatment with injection magnesium sulfate. There was no loss to follow-up or discontinuation. Of the standard treatment group, 6 children required escalation and 5 children required de-escalation of respiratory support. And of the standard treatment with injection Maxal group, 4 children required escalation and 6 de-escalation of respiratory support. They were analyzed and the improvement of RDI score was better in the Maxal group, which is proven by the p-values. These are the comparison of the group A and the group B. Group B being the patient receiving magnesium sulfate who have surpassed group A in all the predefined intervals in terms of RDAI scores. In duration of treatment, duration of ICU stay, escalation of respiratory support and number of patients requiring hospital readmission were all less in the Maxalf group. The average highest serum magnesium level was 2.5 mg per dl and no patient got above the acceptable higher limit. Thus there were no side effects. This is the graphical representation of the RDAI score at the predefined interval, which shows that the RDAI scores are declining in both the groups. But the red one, that is Maxal group, had the decline was rapid, which is proven by the slope of the graphs. There was rapid reduction in RDAI score at the intervals. Similar result was found in study conducted by Dr. Ara and Dr. Farooq Ikram. But this study was done on acute bronchiolitis, not severe. There was reduction in ICU stay, hospital stay and rest requirement to escalate the respiratory support, which was also seen in magnesium sulfate nebulization study. But this was a nebulization study. Our study was compared to 3 studies, 3 multicentric study. The patient pool of our study was severe bronchiolitis in ICU setting. In Dr. Sudha Chandelia's study was all bronchiolitic patient in ward and ICU setting. And Dr. Alansari's study's patient pool was severe bronchiolitis patient in ward and ICU setting. It is clearly visible that our study and Dr. Sudha Chandelia's study, there was clear-cut benefit of magnesium sulfate. However, role of IV Maxalf in bronchiolitis has not been studied extensively. In fact, there has been only 3 studies so far evaluating the efficacy of injection magnesium sulfate. Dr. Alansari evaluated the role of IV Maxalf in a cohort of 162 children and concluded that it did not provide any benefit. This is a picture of study showed that there is no benefit. This is the strength and limitation of our study, that it was a randomized study done in homogeneous population. Thank you.
Thank you. You did a very good study, and just I want to ask one question. Is there any associated side effect in that magnesium sulfate intravenous group in comparison to the children who are treated by standard protocol?
If the serum magnesium level goes greater than 9 mg per dl, there are many side effects like respiratory muscle weakness.
No, in your study,
there was no. If we are checking the levels at 24 and 48 hours, and the serum magnesium level was not gone upper than 2.5 mg per dl, so there was no side effects.
Acha, is there any facility for this checking magnesium, serum magnesium very repeatedly in your setup?
No, we were checking so 24 hours and 48 hours.
24 hours and 48 hours. And that is from the outside. It's
Central
not
lab,
in-house
our lab
investigation. So that will be little expensive for the patient.
From our lab, so it is done in our hospital.
I have 3 questions for you. The first one, both the groups receive standard treatment, right? And what is the severity in the both the groups? Both the groups, because in your graph you never show, you did show how the severity decreased, but at admission were they both equal in severity, or how was the selection in both the
Both
groups?
the groups were severe.
But you never showed anywhere the admission criteria where the
So baseline characteristics were shown.
Sure, okay. That is one thing. The third thing is, when you have a standard treatment in both the groups, only magnesium sulfate in this group, out of all the standard treatment, which is the only treatment which works? When you said standard treatment for bronchiolitis, what is that works in bronchiolitis? What is proven to be worked in bronchiolitis till now?
Oxygen inhalation and hydration.
It's only humidified oxygen. Nothing else works, is what Cochrane study has said that. So, in fact, magnesium sulfate has been looked into as one of the key factors, looking at seeing that, but you cannot compare magnesium sulfate in bronchiolitis versus magnesium sulfate in asthma, because in bronchiolitis the children are infant, whereas in asthma it's above the infancy age, when the smooth muscles are not so well developed. So how?
School wizards,
Go ahead.
They will become asthma in ongoing days.
No, they can't go on to become asthma, because bronchiolitis is a viral infection, it's not asthma. So how comparable? When you look into your studies, you have quoted most of the studies as asthma. So do you have to say anything about it?
The initial presentation of asthma may be bronchiolitis.
Yeah, in few, not in all.
There has been studies have found that there are link, and so if they can be cured by asthma, can be cured by Maxell, so bronchiolitis Maxell can be tried.
Okay.
So you compare bronchiolitis and bronchial asthma. So do you think that anatomical location of bronchial asthma and bronchiolitis is the same?
Both
So
occurs in the smaller airways in the expiratory part during expiration.
Okay. So in your study, do you find anything like the oxygenation? That's what is the treatment for bronchiolitis. Do you feel any difference? Do you see any difference between the Maxell group and the non-Maxell group regarding this oxygenation?
There was no difference.
But your study is not showing that only the RDI index you have shown.
Thank you so much. Now we'd like to call upon Dr. Sarwar Hussain for the next presentation.
We request to end your presentation within 7 minutes, and also request the judges to restrict within 3 minutes of question and answer.
Okay, so we'll try. Okay, very good morning everyone, and very good morning to the judges. Myself, Dr. Sarwar. I'm going to present a study on diaphragm and lung ultrasound indices in prediction of outcome of weaning from mechanical ventilation in a pediatric intensive care unit in a tertiary care hospital. As we all know, the weaning a mechanical ventilated patient in pediatric intensive care unit is a very challenging task for any kind of pediatric intensivist or a pediatrician. And most patients are weaned based on clinical assessment by the intensivist, and this often can lead to misjudgment. And this transition from mechanical ventilation to the weaning is very critical, and it needs accurate, intense, confident decision based on trusted, validated clinical, radiological, and laboratory parameter to avoid the risk of weaning failure. And one such popular bedside parameter in adult, and also in some pediatric studies, it shows that RSBI index is a very good, very popular parameter. And this early termination may lead to unnecessary negative consequences such as VAP, ventilator-induced diaphragmatic atrophy, weaning-induced pulmonary edema, and resumption of mechanical ventilation therapy. Next, as we all know, the diaphragm is the principal muscle in respiration, and mechanical ventilation for prolonged period may lead to its atrophy and subsequent impairment. And as the role of focus is increasing also in our country, the role of bedside ultrasound in assessment of diaphragmatic function has been conducted in many studies where two parameters, one is the diaphragmatic thickness fraction and one parameter is diaphragmatic excursion, has been extensively evaluated to measure whether we can wean the patient or not. And next another parameter is the lung ultrasound score, where we can see the condition of the lung, and it can give us an idea about aeration, and we can expect if the respiratory distress will occur after weaning or not. Objective. The main objective of my study is to predict the values of the diaphragmatic and the lung ultrasound indices in anticipation of the outcome of mechanical ventilation weaning of pediatric patient in an intensive care unit. It's a prospective observational study, hospital-based study in a period of 15 months conducted at PICU of Calcutta National Medical College, and study population is the all mechanical ventilated patient admitted at our PICU. And the inclusion criteria: age group 2 to 12 years, duration of mechanical ventilation more than 24 hours, and when there is a signs of reversal of main principal cause of ventilation, PO2 more than or equal to 60 millimeter of Hg, and PCO2 is less than or equal to 45 millimeter Hg, and the child should not receive any kind of sedative or neuromuscular blocking drugs, and there should be adequate conscious level GCS more than 8, and there should be no fever in last 24 hours, absence of hemorrhage or anemia, hemoglobin levels should be more than 7.5 gram per DL, and hemodynamics should be stable, and informed consent from the legal guardian. And the exclusion criteria are patients having congenital lung and pleural malformation, chronic neuromuscular disorder, and absence of diaphragmatic mobility on lung ultrasound, patients having pneumothorax, pre-existing diaphragmatic palsy, and patients who have undergone diaphragmatic manipulation during thoracic or esophageal surgery, and patients having major cardiac and abdominal surgery. Now, all the patients meeting the inclusion-exclusion criteria were submitted to spontaneous breathing trial for 2 hours, and the patients were monitored closely for this period of 120 minutes to assess the eligibility for weaning, where we will see if there is any increase or of breathing, and there should be no agitation, diaphoresis, and no increase or decrease in the vital more than 20% from the baseline. And RSBI index was calculated at the 0 minute of SBT, 60 minute, and 120 minute of SBT. And in this period, we will calculate the diaphragmatic and the lung ultrasound scores. Now, diaphragmatic ultrasound indices. We will use the 3.5 MHz convex probe and 9 to 11 MHz linear probe for the patient's examination. And in case of to detect the DTF, the patient should lie in semi-recumbent position, and we will place the probe in between the 8th and 9th intercostal space, and we will see the diaphragm is a 3-layer structure in between the pleura and the peritoneum as an hyperechoic line, and the diaphragm is an hypoechoic line. And we will place the M mode to detect the diaphragmatic thickness at end expiration, and at end inspiration we will calculate the DTF according to this formula. Next, we will measure the diaphragmatic excursion using the convex probe, and it was measured placing the probe in the subcostal region. And at first the P mode we will localize the diaphragm, then by M mode we will measure the diaphragmatic movement in exhalation and in inhalation. And we will measure this parameter as diaphragmatic excursion. And similarly, we will measure the lung ultrasound scores. Next, by result. These are the demographic result. This is the graphical representation of duration of mechanical ventilation, and the main result is my 3 parameter: diaphragmatic excursion, diaphragmatic thickness fraction, and lung ultrasound score. In case of successful winning group, we will find the mean of diaphragmatic excursion is 11.77 with median 11.7 and standard deviation 2.1. In case of DTF, it is 24.3.8, 23.38, and median is 24.3, and standard with standard deviation 1.63. And in case of lung ultrasound score, the mean is 10.37 with median 10 and standard deviation 2.92. And in case of failure group, we can see the values are much less. In case of D, it is 7.35 with standard deviation 1.80. In case of DTF, it is 16.3 with median 16.32 and median 16.3 with standard deviation 1.62. And in case of lung ultrasound score, it is 26 with 26.07 mean, median 26, and standard deviation 3.82. As we can see, all of these are with p-value less than 0.01 and statistically significant. And next, this is an ROC curve to predict the failure using the RSBI index. And next, this is the ROC curve to detect the values of the DE and DTF. As we can see, the cutoff value for D is 9.25 with sensitivity 88.37 and specificity 92.86. And in case of DTF, it is 21, cutoff is 21 with sensitivity 90.68 and specificity 96.72. As we can see, the area under the curve, in case of DTF, it is 0.98, and in case of D, it is 0.92. All of them are statistically came out to be statistically significant. With DTF values, as the area under the curve value of DTF is more, it correlates more with the winning parameter. Next, this is the outcome of our patients from mechanical ventilation according to age, sex, and duration of mechanical ventilation. And discussion. Current medical and the laboratory parameter for assessing the readiness to wean from mechanical ventilation are easy to use but lack specificity and sensitivity. The study examined whether adding diaphragmatic and the lung ultrasound improve the prediction of weaning in pediatric patients or not. It involved 71 children of various age group ready for weaning based on a spontaneous breathing trial. The study found significant correlation between weaning outcome and diaphragmatic thickness fraction, diaphragmatic excursion, and lung ultrasound scores. And previous studies confirmed that diaphragmatic excursion is a reliable indicator. The MICE study reported a diaphragmatic excursion cutoff of 9.25 mm with 88.37 sensitivity and 92.86 specificity, aligning with other studies. And for DTF, a cutoff value of 21.1%, showing 90.68 sensitivity and 96.72 specificity. And lung ultrasound score also proved to be an effective tool. And conclusive diaphragmatic and lung ultrasound score add a quick and non-harmful technique for prediction of weaning success with highly accurate results. So they can be added to conventional parameter for accurate prediction of weaning outcome. My limitation is there is a relatively small sample size. It is a single center study, and more multi-center studies are needed. And another limitation factor is there is no reference value of this parameter in Indian children. There is no there is no definite study on Indian children. And this is an operator-dependent study. As we all know, the USG machine is operator-dependent, and special training is needed to determine this parameter. Thank you.
Hello. Very well done study. Congratulations. Just a comment. If I ask you, not a comment, I'll ask you the question itself. If I ask you one modality by which you can use, instead of ultrasound, for better weaning, the newer modality in ventilation, which one will it be? Where the same principle holds, looks at how the diaphragmatic movement is monitored. Are you aware of that?
No, sir.
It's NAVA. It's neurally assisted ventilator assist. So NAVA is now coming big time in the thing where you put the probe into the esophagus, monitor for the diaphragmatic exertions, and that will give you the pressure support on the ventilator. So that's much easier. This is a very good.
I will study about it.
Okay. So this is a very good modality by which lower income hospitals and smaller hospitals can easily look at diaphragmatic exertion. Thank you.
Thank you, sir.
Sarovar, I think it's a good study and new opening. But my question is that in cases of difficult to weaning, usually we think of something like acute diaphragmatic palsy or diaphragmatic weakness. But here you are not showing us that idea that it's for all the patients who is having difficulty in weaning, like weaning failure. So do you think that that's where the diaphragmatic palsy or diaphragmatic excursion values, those values are actually helpful?
I don't think so, because in all studies I have studies, the inclusive, they have included in inclusive criteria any kind of diaphragmatic palsy, any kind of diaphragmatic manipulation, or there is a loss of any kind of diaphragmatic movement on ultrasound. So these patients are excluded from all of the studies, and also from my study.
Okay, thank you. Very good study. But I have only one question. Did you face any problem during this diaphragmatic, this ultrasound, to know that when to wean, how to wean, and
yes, initially
what problem you have faced?
Actually, sir, we are not a trained radiologist. So when we are going to initiate the study, we have called a ma'am from radiology department to train us, and also there is our guide, Dr. Rupa Biswas, who is also trained in radiology. So under ma'am guidance, we have performed this study.
Now you are trained?
Yes, sir. Not confident in the process.
Thank you.
Thank you so much for sticking to time. Next we have Dr. Sara Yasmin to present.
Good morning, faculties and respected colleagues. I am going to present a study regarding the clinico-epidemiological profile of patients requiring high-frequency oscillatory ventilation, a single-center prospective study. So, a little about HFOV. It is basically a mechanical ventilation using supraphysiological respiratory rates and very low tidal volumes, about 0.5 to 2 ml per kg. Unlike conventional ventilation, ventilation here is independent of oxygenation. So the differences with conventional mechanical ventilation with HFOV are, here expiration is active, ventilation is independent of oxygenation, and mitigation of pressure swings as air flows through the tracheobronchial tree. So this is basically a graphical representation of the benefits of HFOV. So there is a zone of volute trauma above the upper inflection point, and there is the zone of atelectotrauma below the lower inflection point. So HFOV basically ventilates the lung in the safe zone, and hence it prevents volute trauma. Dampening of pressure prevents barotrauma, and it doesn't go below the zone of lower inflection point, so that basically prevents atelectotrauma. What are the usual indications of HFOV? It is used as a rescue therapy in refractory hypercarbia and hypoxemia respiratory failure, in pediatric acute respiratory distress syndrome. We can upgrade to HFOV in case the child is already on high or injurious ventilatory settings like FiO2 more than 60% and plateau pressure of more than 25 to 28 centimeters of water. Salvage therapy in refractory hypoxemic failure where ECMO is not available. So objective of our study is to study the clinico-epidemiological pattern of patients on HFOV in pediatric critical care setup in a tertiary care center in eastern India. The study period was from Jan 23 to May 24. Place of study was Pediatric Intensive Care Unit in Institute of Child Health, Kolkata. Study population was patients aged 2 months to 18 years requiring HFOV support. And the ventilators we used were SensorMedic 3100A and SLE 6000. So these are the findings of our study. The main indications for which we put our patients on HFOV were pneumonia, ARDS, pulmonary hemorrhage, refractory hypercarbia. Out of 11 ventilated patients for CO2 washout, 7 responded very well and survived, out of which 1 patient even required ECOR. Mortality in pneumonia group was almost 63%, and there was only 1 patient who was ventilated for alveolar hemorrhage, and sadly the patient couldn't be salvaged. There is no well-defined cutoff defined for early HFOV. In our study, we took an arbitrary cutoff of 6 hours for the patients who required HFOV, and 66.6% patients survived on this support. So what were the main causes for delay? Since ours is a resource-limited setting, we only had 1 machine of SensorMedic, and due to preoccupation or the machine under maintenance, we couldn't provide the earliest support. So here we see a whooping 92% mortality on the patients who had delayed the support. So the patients, there were many patients who had ECMO and ECOR requirements, mainly who had oxygenation index more than 40, PF ratio less than 80, MAP more than 20 on conventional and more than 30 on HFOV. So out of this, even 1 patient had ECOR requirement. Out of this, 4 patients had survived on HFOV. This substantiates the fact that in a resource-limited setting like ours, HFOV can prove to be a salvage therapy. The total survival and mortality on the study, we had 7 patients who had survived on HFOV and 15 succumbed either to primary disease or secondary sepsis. What are the sedations used? We mainly used sedations like dexmedetomidine, clonidine, ketamine, along with the routine midazolam. And we had to use neuromuscular blockade. Almost 81 patients required additional neuromuscular blockade along with routine sedatives. And this is in concordance with the findings in the OSCILLATE and OSCAR trial. We didn't find any significant complications with HFOV. Only 1 patient had a pneumothorax, and that was too attributable to the pre-existing lung disease. What are the usual potential complications we can face on HFOV? They are hyperinflation and barotrauma, pooling of secretions, hypotension. So conclusions from my study, early HFOV initiation in patients with refractory hypoxemia can have promising results. HFOV can be reliable rescue therapy in patients who require ECMO and ECOR in a resource-limited setting like ours. For proper ventilation and HFO, we need to add neuromuscular blockade along with routine sedation. If appropriately administered, then the rate of complications on HFOV are minimal. So these are the 2 heroes of our HFOV. The right one is the SLE 3100, and the right one is the SLE, and the left one is the SensorMedic 3100. Thank you, sir.
Thank you. Dr. Sara, just one question I have. You have used 2 different machines. One
Yes.
is HFOV, which is an oscillator. The other one is a SLE interrupter. It's not an actual oscillator. Do you know the difference between both of them?
Yes, sir. In SLE, the expiration is not active, and it basically works on the principle of flow interruption.
Full flow interruption. So you cannot conclude saying that HFOV actually. Hello. You cannot conclude saying that HFOV helped, because if you are looking at pure HFOV, it has to be an oscillator. It cannot be an interrupter. Though some physiology of interrupter does work. Some physiology of oscillators are present in interrupter, but it's not a pure oscillator. That's one. Secondly, what is your inclusion criteria you said for putting on HFOV?
Sir, usually where the oxygenation index exceeds 16, we think of putting on HFOV.
HFOV plus the MAP going
MAP is,
above.
our average MAP was 22.
22. Going above 15, anything you think of HFOV.
Yes.
But oxygenation index, I didn't see, did
Yes,
you
sir.
mention that?
No, I didn't.
You didn't mention. Okay, thank you.
Sarah, I think it's an just observational study. So, and whatever is your observation, when you are talking about early support of HFOB, what do you mean by early support?
So there is no strict cutoff mentioned anywhere. We have taken an arbitrary cutoff of 6 hours. Like the patients who require HFOB, if we are able to provide them the machine within 6 hours, we have considered those as early HFOB.
No, do you consider the different values like this oxygenation index and all this to take your decision of early exposure to HFOB, or you are just pointing out that within 6 hours?
No, sir. The patients who are having those values, like suppose a patient is having an OI of more than 16, so but I'm not being able to provide that patient with the machine because probably it is preoccupied with some other patient. So yes, we considered that, but that is the thing that if I'm not being able to provide, I put it in the delay group.
But ARDS itself is a dynamic process, and then if you are waiting for 6 hours, it is already almost delayed. So if you have to put it in the point go rather than waiting for 6 hours, right?
Yes. Actually, sir, the thing is, our limitation was that we had only one machine. So even if the patient is meeting indication, if the machine is not available, that is the reason for the delay.
Okay, I got your point.
Which group of patient, as per your inclusion criteria, benefited maximally by this method of ventilation?
Sir, the patients who had refractory hypercarbia, they benefited maximum. Thank you, sir.
Thank you so much. Next we have Dr. Ritika Bhakat. Over to you, Ritika.
Good morning, myself Dr. Ritika, resident from Medical College, Kolkata. I'm honored to present my research study on coronary artery involvement in children with prolonged fever admitted in PICU at Medical College, Kolkata, a prospective observational study. Coronary artery abnormalities in febrile children often seen in Kawasaki disease is a leading cause of heart disease in developed countries. Coronary artery involvement is a criteria for immunoglobulins and other immunosuppressants, but there is paucity of literature about fever caused by illness other than KD leading to coronary dilatation. This study aims to understand the prevalence, risk factor, severity, treatment and outcome in this group. Dysregulation of immune system and production of pro-inflammatory cytokines are important cause of coronary artery involvement as seen in Kawasaki disease. However, the association of hyperinflammatory state in other febrile illnesses with coronary artery is not clearly known. Studies showing coronary artery involvement in other febrile illness presenting with one or more organ dysfunction is lacking. So our objective is to estimate abnormality of coronary artery in children with prolonged fever with one or more organ dysfunction, to assess coronary artery involvement according to the etiology, to compare the inflammatory markers between coronary artery involved and not involved group, and to assess treatment modalities and outcome in this group. Children with fever more than or equal to 101.3 degree Fahrenheit for 5 days or more, age group 1 month to 12 years was admitted in PICU and Medical College Kolkata was taken as the population. Diagnostic measures like serological investigation, scrub, malaria, dengue, leptospira was sent. Relevant radiological investigations was done and echocardiography was done to divide it into two groups, coronary artery involved and not involved, to know how coronary artery involved in children with prolonged fever. It is a prospective observational single center pilot study approved by ethical committee. Informed consent was taken. The study period was in between January to June 2024. A sample size of 50 was calculated from a prevalence rate 24% of a study CA dilatation in exanthematous fever. This sample excludes congenital cardiac diseases and fever due to malignancies. Echo was done on day 1 of admission or on day 5 of fever to divide it into coronary artery involved group and not involved group. The coronary artery involved group was categorized according to the etiology. The severity grading according to the Z score, mild was defined as more than 2, less than is equal to 2.5, moderate as more than 2.5, and less than is equal to 5, severe as more than 5 to less than is equal to 10, and very severe as more than 10. Other echo findings like perivascular hyperintensities, loss of tapering, pericardial effusion, ejection fraction was also assessed along with the treatment modalities and outcome. Comparison of inflammatory markers was done in between these coronary artery involved and coronary artery not involved group also. Appropriate statistical methods were used to get the analysis and result. Among 50 febrile patients, 36% patient had coronary artery in a sex ratio male is to female 2:1. Most commonly involved age group was in between 1 to 6 years. The most commonly involved group was the pneumonia followed by AES and then scrub. Most commonly involved coronary artery was seen to be the LMCA, LAD and then RCA. Severity assessment data showed that among 18 patients, 10 had mild, 6 had moderate, 1 had severe and 1 in very severe group. Mean Z-score was significantly higher in case of KD patient than non-KD patient with a p-value of 0.02, 0.03, 0.01 for LMCA, LAD, RCA respectively. Among the inflammatory markers, NT-proBNP, ESR and low hemoglobin was significantly associated with the coronary artery involved group, and thrombocytosis was seen significantly increased in case of Kawasaki patient comparing to the non-Kawasaki patient. Among 18 patients, 12 patients responded to the first dose of IVIG only. Only 6 patients required IVIG and steroid. Among them 3 patients, 1 DCM and 2 cases of MAS required other immunosuppressant. On follow-up echo, there was seen that there was significantly reduction in mean coronary artery after the treatment, and except DCM, all of them showed normalization of coronary artery. Now coming to the discussion part, our study showed that coronary involvement can be seen in other febrile illnesses as well, and coronary artery involvement was most commonly seen in pneumonia followed by AES and scrub. The inflammatory markers ESR, NT-proBNP and low hemoglobin was significantly associated with coronary artery involved group, and most of the patients, the 12 patients responded to IVIG only. Only 6 patients required other immunosuppressants. Comparing with other study by Muniz et al., who showed that 2 out of 43 febrile children with a sex ratio of 1:1 showed coronary artery involvement. He also showed that the mean age group was 4 years, and inflammatory markers, ESR, total leukocyte count, thrombocytosis was also significantly increased in Kawasaki patient, and all of them responded to IVIG only. So we can conclude that children with prolonged fever without any explanation should undergo echocardiographic assessment, especially when there is high inflammatory markers, and early treatment with IVIG can improve outcome in most of the patients. Limitations: it is a pilot study, single center based, small population, unable to compare the effects of different types of infection on coronary artery size, and multiple sonographers and cardiologists were involved. It is a strength, new structured prospective data in non-Kawasaki patients done in homogeneous population. Follow-up has been done to see the treatment response. These are my references. Thank you.
So it's a very nice study and very important also. So you have just generalized that pneumonia. Those pneumonia cases you found with a coronary involvement more than 5 days of high fever. So what is this group of pneumonia? Is it viral pneumonia? We got a lot of this patient adenovirus pneumonia, adenovirus infection with the involvement. Sclot typhus is known to cause. So is it viral pneumonia or even chronic infections? Whereas a prolonged fever more than 5 days, like tuberculosis, there is also possibility of arteritis and artery involvement. So is there any clue to your study that what group of organism is associated with this?
No sir, actually the pneumonia we did not categorize them into virus and bacterial. We take the pneumonia who created presented with multi-organ dysfunction, and the coronary artery was involved.
Hello. Your study is really important because what it shows is children with fever we need to evaluate, especially prolonged fever. But if you look at the Kawasaki diagnosis, it's purely clinical. It's never with investigation. None of your slides which you showed compared the clinical features of children with prolonged fever which are not Kawasaki with Kawasaki, because Kawasaki comes with a constellation of signs and symptoms, especially symptoms. They have red eye, they have strawberry tongue, they have peeling of skin. how many of those features were present in these children, or they didn't have any features? They just had fever as one of the diagnoses.
Sir,
Because that is not shown on your slide, so you might be knowing the intricate data which.
Sir, actually the classical diagnosis of KD defines fever along with 4 other criteria. So in this study we divided earlier who presented all the 4 criteria and who did not present the criteria. So we divided as KD and non-KD group. And among KD we showed that according to etiology how coronary artery was involved. So the non-KD group actually did not fulfill all the criteria, but 1 or 2 criteria was seen, but that was seen during the examination part, but it is not.
Because that becomes very important when you sit in a OPD. You have a child coming with 5 days fever and he's got strawberry tongue, or say he's just got peeling of skin all over. Then it will immediately strike to me. You ran very fast. Any of these children, all of these children, did they have thrombocytosis?
No, not all of them had thrombocytosis.
Because that is also very important. That's one feature which we actually look for. When you have infection and you see high platelet count just rising, that will trigger you to think that it's Kawasaki and
So
not.
thrombocytosis was mainly significantly increased in the Kawasaki group in my study.
But what I'm asking is, you went very fast in the slide, I couldn't see that. Whether the other group with fever, did they have thrombocytosis?
So most of them had, but not everyone.
Okay.
So regarding the Kawasaki disease, the diagnosis is still enigma, and lots of infections are also associated with Kawasaki disease, just like scalp typhus or adeno. So in your presentation, when you were talking about Kawasaki disease as a diagnosis, you always talked about that incomplete Kawasaki disease, particularly when you are not fulfilling the criteria of Kawasaki disease?
No, sir. I showed in my slide that among the 6 Kawasaki patients, only 2 had typical features. And 1 was presented with KD shock syndrome, 1 was atypical KD, and 2 was resistant KD. But this resistant KD showed all the features of Kawasaki, classical Kawasaki.
Thank you, everybody. Now we move on to the next session, What's New in Sepsis? We have with us Dr. Minal Kanti Das to chair this session. I would like to request you, sir, to kindly come up on the dais and take a seat. Sir is the professor and head of the department, Pediatrics, IPGMER, SSKM Hospital, Kolkata. I'd like to request the moderator for this session, Dr. Ognishekar Shah, sir, to kindly come up on the dais. We have with us as panelists for this session, Dr. Shottobroto Roy Choudhury, Dr. Madhiya Zainab, Dr. Mrityunjoy Pao, and Dr. Krishna Mohan Gulla. I'd like to hand over the session to our moderator, and he will introduce the panelists. Over to you, sir. Yes, sir.
Hello. Good morning, everybody. Thanks to the organizers for having us. As I already mentioned, that's the topic of today's discussion, what's new in sepsis. My panelists are Dr. Gulla, Dr. Madhiya, Dr. Pao, and Dr. Roy Choudhury. All relatively young people. So without wasting much time, let's just move on. So what will be the plan of the talk? We could possibly end the whole session in one sentence, and that's there's nothing much new in sepsis. That's the bottom line. There is nothing much new in sepsis. But we have been allocated 40 minutes, so we'll talk a little bit. In terms of new, absolutely new developments, the frontier level research almost always happens in adult medicine. It's there where the breakthroughs happen, and in pediatric things percolate. And if you look into this space, the sepsis literature, the last drama, big drama, happened early part of this millennium with the reverse EGDT trial, which showed a 15% almost 15% mortality benefit, and then subsequently that study was refuted in somewhere around 2015. And since then, even in adults, nothing new has happened. But a lot of active research is going on, which are yet to come in bedside, right? And I think if we go too much into those things, it will be quite boring for you, because they are not applicable right now. So we'll talk a little bit about those things, but for mostly, we'll discuss the latest surviving sepsis guideline on pediatrics, which is also not new now. It was published in 2000, so it's about 4 years old now. But we'll mostly talk about that guideline, focusing on where this guideline, the latest guideline, differs from the previous avatar of the guideline. And then in the end, I will possibly talk a little bit about what are the ongoing research which can affect sepsis care in future. So that's the plan of the talk. Surviving sepsis guideline for children 2020, that's the latest one. First question to Dr. Gula. What are the components of the initial resuscitation? This it is not really much different from the previous avatar, but that is something which forms the cornerstone of the therapy. So let's have a look at them. Dr. Gula, please.
Thank you, sir. As we all know that, as sir had already told, there is no much change in the resuscitation program guidelines from previous guidelines. So first of all, before resuscitation, what I wanted to tell you that every unit or every emergency should have a screening tool for sepsis that is suitable for their region, which are the common infections that are common in that area. So you need to have a screen. So once if a patient becomes sick in ward or in emergency, you should have a screening. With that screen, you identify that the patient is probably having sepsis, and then you will start your next plan of action. If he is in septic shock, within 1 hour, you need to take all the following 6 steps that was shown. That is, one, you need to put an IV or IO access and take blood cultures, and then give first dose of broad-spectrum antibiotics depending upon the infection you are suspecting and the focus of infection that the patient is having. And then you measure the lactates because it has the therapeutic as well as the prognostic meaning. And then if the patient is in shock, you will start aggressively. Within 1 hour, you need to complete all these steps, giving fluid resuscitation and as well as inotropic support. And if patient not in shock, you have some liberty of 2 to 3 hours, but which I say that it is again all in guidelines, but you need to act as early as possible, depending upon your resources, what you have.
Thank you. So 6 things. You need to get an access fairly soon. You need to take the blood culture, which is still not done in some places. That's that's sad. And then you need to start some antibiotics. We'll talk more about all of these points a bit later. Lactate they have mentioned, although lactate is not available to in some in many centers possibly. And in adults, they have actually divided the cohort on lactate. In pediatrics, that's not done. And then give a bit of fluid and start inotrop. This we should be able to do in almost all centers. That's the expectation. Right. So antibiotics are one of the cornerstone of therapy. So is there any change in the guideline regarding starting antibiotics? Dr. Madiha, please.
Thank you, sir. So sepsis is still the most leading cause of mortality in our country, and antibiotics is the cornerstone of treatment along with initial fluid resuscitation and other supportive measures. So as we saw in the initial resuscitation algorithm, so in children with septic shock, antimicrobials should be started within first hour of recognition. So studies have shown that initiation within first hour reduces the mortality, it reduces the organ dysfunction and also the length of stay. Regarding patients who are not in septic shock, okay, with organ dysfunction, in those cases, antibiotics can be started within 3 hours, as early as possible, but still you have the liberty of at least 3 hours. And obviously, ideally, we should send a blood culture before starting of antibiotics if possible. Now, regarding what antibiotics to use. So, we have seen we should start with empirical broad spectrum antibiotic. In those children who are immunocompromised, high risk conditions, we should cover the antibiotics covering the MDR organisms because the incidence is very high. This is done to expand the coverage and to evade resistance and also to achieve synergy. Now, how long to give? So once we have started on antibiotics, the patients should be monitored, and as soon as possible, once we get the organisms, once we get the culture sensitivity report, we should try for de-escalation of antibiotics and narrowing the spectrum of antibiotics so that to evade the resistance pattern to that. Yeah, that's it.
Right. So what's new is this 3-hour thing. Okay. This was not there in the previous hours. In the previous that if you were in shock, you still give it in 1 hour. But if you're not in shock, but you seem to be septic, then 3 hours is allowed. Why 3 hours? Why? Where from this 3 came? 2 reasons. One is, a lot of kids who are coming with who looks like septic, they might not be septic. So if you can expedite some initial investigations, at least something like a blood count and a CRP, and you can get that result within 3 hours, then maybe you can avoid giving antibiotics to some of these kids who are not really septic. So these 3 hours should be coupled with expedited investigations and get some investigations, the initial investigations reports within 3 hours. That way you may avoid unnecessary use of antibiotics in some patients. That's one of the things. And the other thing, it came from basically combination of 2 big pediatric studies, relatively big pediatric studies. And when they did the study, the calculation, within 1 hour if they take, it did not quite reach statistical significance, right? But when they took a group who received antibiotics within 3 hours as against after 3 hours, that is when it reached the statistical significance. That's why the 3 hour came. Otherwise, the rest of them are more or less the same. Right. So, what is a significant change in fluid therapy and why was it changed? This is possibly the most important, difference between the latest and the previous one. Possibly the most important difference. So let's talk about it. Let's listen about it from Dr. Pao.
All right. Previously, the surviving sepsis guideline, after the study by Rivers, there was goal-directed fluid therapy. The earlier concept was that when we were training, during our fellowship time, it was thought to us that you give fluid as much as you possible, give hard, give fast. So fluids were given up to 40, 60, even 100 to 200 ml per kg, which mostly led to fluid overload many times. And after the landmark study by Catherine Maitland, which was conducted in Africa, the study was feces trial. Yeah. So it caused a change in outlook of how much fluid we give. It led to changes practice in pediatrics and as well as adult studies. Although the study had some shortcomings, but it was realized that giving too much fluid to all patients is not the right thing. So now the surviving sepsis campaign recommends that you give fluid only up to 40 to 60 ml per kg. If you have a ICU backup, you can give fluid up to 60 ml per hour in a glucose of 10 to 15 ml per kg after assessing the fluid overload like crepitations or increase in the liver size. So if you have ICU, you give up to 60 ml per kg. In places where you don't have ICU, then you can give up to 40 ml per kg in a course of 10 to 15 minutes. Do not push it very fast, and you should always monitor the child. And regarding what fluid we should use always crystalloids. So commonly it is normal saline, and some people advise balanced fluids.
Right. Thank you. Yeah, very well said. So the landmark study is the Maitland's feast trial. It's very important to understand that study was done in Africa. The cohort, the kids were malnourished, very high rate of malaria, very high rate of HIV. So the cohort is very different from our cohort. But that study showed that kids who are septic but not in shock, and if you give boluses to those kids, your outcome is actually worse. So in the current guideline, they have almost divided the facilities, whether you have ICU facilities or you don't have ICU facilities. So it is sort of divided them. And if you don't have ICU facilities and you don't have shock, you should not get a bolus. That's the only strong recommendation with strong evidence in the entire guideline. The only strong recommendation with strong evidence. And if you work in a setup where you do not have ICU facility, but the kid has shock, there also you can give boluses, but previously it was said it was always 20 ml per kilo. Now they were saying 10 to 20 ml per kilo individual boluses, and there it is not up to 60 but up to 40. But standard recommendation, that is facilities where you have ICU facilities, now again the recommendation is 10 to 20 ml per kilo rather than 20 ml per kilo, up to 60. You can go up to 60. But of course you need to look for features of fluid overload. Another change they have made is, starch is out. Although we don't use starch actually, but they have said starch should not be given clearly, right? And gelofuscin, you can. And some of us do use gel, hemaxidil. So that's about fluid. And that's possibly one of the biggest changes that has happened. So the take-home message is, don't push in fluid too heroically. Be a little bit guarded. What is the change in categorizing septic shock and why was it changed? What is the suggested alternative for Dr. Shatrabrata?
So previously when we used to see septic shock, we used to divide the septic shock on the basis of the clinical scenario, like diastolic blood pressure, pulse pressure, peripheral temperature, pulse volume. On that basis, we used to divide the patient as warm shock or cold shock. The underlying thing was that warm shock should be a high cardiac output shock and cold shock is a low cardiac output shock. And on that basis, we used to determine the therapy. A warm shock patient should receive inotrope and fluid, and cold shock patients should receive inotropes. That was the idea. But when the advanced hemodynamic monitoring systems appeared in our ICUs, we find out that clinical dividing between cold and warm shock doesn't correlate with the finding that we are getting from the advanced monitoring. Nowadays we can determine cardiac indexes from our these systems, and these are not correlating. So now the Surviving Sepsis Guideline 2020 suggests that we should use this advanced monitoring to categorize these children between high cardiac output shock and low cardiac output shock. What are the things we have to use? We have to use the arterial line, that is in invasive blood pressure monitoring, SCVO2, and some cardiac output monitoring tools that can be. The most invasive one is the putting a Swan-Ganz catheter in the pulmonary artery. That we don't use. That is not feasible for all ICUs, and that is also risky procedure. So we are using some minimally invasive procedures like PICO, LITCO, that usually we do with the arterial line and a venous line. That is done by pulse contour analysis and some dilution methods. But we can use non-invasive methods that is easily available, like echocardiography. That can be transthoracic echocardiography or transesophageal echocardiography, measurement of the flow through the aorta, peak flow in the aorta usually correlates very well with the fluid responsiveness of the child. So if we do these things and categorize, we can do categorization on high cardiac output and low cardiac output, that can guide us with our fluid and inotropes. That is the current suggestions.
Fantastic. Very well explained. So just to reiterate, so basically what they're saying is previous that, cold, warm, clinical differentiation, when it is put to test, it is found that our clinical assessment is often wrong. Okay? Although it's been there for ages, but we are often wrong. And how do we know we are wrong? Basically, you need to have a technology which will give you, we always have blood pressure, right? Blood pressure, we have very good blood pressure, IBP, very gold standard. But on top of that, if you also have some technology to tell you the cardiac output, Then you can also measure peripheral resistance, because blood pressure is cardiac output into peripheral resistance. So if you know two variables, you can know, you just divide, you get your SVR. And that way you can physiologically divide them better in terms of whether it is a low SVR or high SVR, and then give your inotrope accordingly. That's what is recommended. One thing is, it sounds very scientific, but do we have any robust, solid data that if you treat patients based on this division rather than our classical division, it gives rise to good outcome? Do we have any such data? As yet now, no. We still don't have any strong, robust data saying that if you treat them according to this cardiac output monitoring data, then it will lead to improved outcome. Do we have any such strong, robust data? No, we still don't have. But it looks like this is the way to go. Okay? So, right. What is the change in recommendation regarding inotropes? Again, some changes has been made. Quite important. Dr. Gula.
Yes, as per the inotropic support is concerned, so the new guidelines say that you start in the first line as epinephrine when the patient comes septic shock, or norepinephrine. If you don't have, but the recommendation again is very weak. The strength of evidence is very weak. But and again they do not recommend using dopamine. But I could not find much literature why the dopamine has been thrown to dustbin in nowadays. Majority of times, because if you look at literature also, everybody says that the arrhythmias, they're pretty common with dopamine. If literature is same like epinephrine or so. So again, we need to be, if you don't have epinephrine or epinephrine, at least we can start with dopamine. There is no harm in that, what I feel personally. And regarding whether you want to give through the peripheral line or not, they didn't give any recommendations. But again, it is a common sense that if the patient is crashing, you have no other option, you have to put it on to the peripheral line with increased dilutions. And regarding vasopressins, they say that they had told the physician to decide whether to, as per the clinical science of the patient, whether to add vasopressin or not. And rest of all, I think what I suggest is that you need to take a call based on the patient's physiology rather than what the recommendation says. A recommendation is used for the guidance, but you need to use your own brain and go away.
Very well said. A basic feature of the latest guideline is they have played it safe. They have played it safe. Basically, what they have made sure is they do not want to make a recommendation which they have to revert in the subsequent period. That's why they have said about a lot of things. They have said, we have no recommendation. We have no recommendation. So that tells you that the evidence is still, we still maintain clinical equipoise. We still don't know. Maybe in a way it's good. It's good to say something and then revert it in your subsequent guidelines. They have made sure that they don't need to do that. So what is the difference? Previously it was said adrenaline is the first, and now realizing how iffy the evidence is, they say we don't have enough evidence to say adrenaline is the one. It can also be NORAD, and actually the latest trend is a lot of people are going for NORAD. In adults, NORAD is the one. There is nothing else but NORAD. It's only NORAD in adults. And a lot of pediatric patients are also saying possibly we also need to go towards the adult thing. So they have said that you can use either Adri or NORAD. Dopamine has been the villain, a common villain now. It's sort of, it's good to, dopamine bashing is like in fashion. And for reasons mostly like, dopamine causes a lot of arrhythmia. And in adults at least, the outcome is worse with dopamine. But they said that if you don't have, you can give dopamine only if you don't have adrenaline or noradrenaline. Regarding peripheral central, equipoise, they said no. Another thing is vasopressin is coming up in a very big way. But this guideline is still stating that it is up to the, it is not stating that, you should use vaso. They said you can either go up on your NORAD or you can go up on your NORAD up to certain level like 0.3, 0.4 and then add vaso, up to you. There are a lot of negative recommendations, like these are the things that you should not do. A lot of them, and they are possibly a bit more emphatic on those recommendations. These are the things which are out, which you should not do. Can we go through those recommendations, Madhya? What are the negative recommendations for the surviving sepsis?
Okay, sorry,
I forgot to put those. Sorry.
Yeah, so regarding the negative recommendations, some of which we have already discussed regarding the use of fluid boluses and regarding the change in the inotropes. So the previous guidelines did not mention anything regarding the use of micronutrients. The role of micronutrients like selenium, glutamine, arginine in sepsis. This survival sepsis guideline 2022, they recommend against. They do not support the use of these micronutrients in septic shock. Then another thing is the role of HAT therapy, that is hydrocortisone, ascorbic acid and thiamine. So some studies have shown its beneficial effect. However, survival sepsis guidelines does not recommend its routine use, even the use of lipid formulations. Another thing is regarding the role of transfusion of platelet and plasma transfusions. So there is routine transfusion of platelets is not recommended until unless the child is bleeding. Yes, in high-risk conditions like in leukemia patients and all this, cutoff is 10,000, less than 10,000, you can transfuse. Regarding the role of plasma transfusion also, it adds to volume overload, so until unless the child is bleeding or in DIC, it is not recommended. Another thing is the use of plasma exchange in septic shock. Some studies have shown its role because septic shock is associated with a lot of cytokine release, a lot of immunoinflammation. However, this guideline recommends against its use, even in cases, routine use of plasma exchange in septic shock. If septic shock is associated with multi-organ dysfunction like TAMOF, it can be used, however, should not be used routinely. That is the guidelines, as per the guidelines. Now, regarding initiation of feeds, early initiation of feeds in all cases of sepsis is advocated. However, there is some concerns regarding whenever the child is on inotropes not to start feed. This guidelines recommends against it. Like we should not withhold feeds even if the child is on inotropic support. So that is the thing. And others are like routine use of deep vein prophylaxis is not recommended until unless it is a high risk condition. Routine use of prokinetics, routine use of gastric ulcer protection, all those things are not recommended by these guidelines.
Thank you. This is possibly a bit controversial. Like what they have said, immunonutrition, glutamine, zinc, those are out. Should not use them. HAT therapy, where you use hydrocortisone. We use hydrocortisone anyway. We'll talk about hydrocortisone a bit later. Oh, we don't have that. Or do we? Next one. Yeah, we have. So we'll talk about hydrocortisone. But then HAT therapy, hydrocortisone, along with that, we give ascorbic acid and thiamine. And some studies have shown some benefit. Subsequent studies, all of them has failed. So they said HAT is out. And special lipid formulation means omega-3 basically, not the standard TPN lipid, but the omega-3 is out. I don't quite agree with this prophylactic platelet and plasma. So what they are saying that whatever is your count, is your platelet count in a septic patient, you don't give platelet just because of the count, you give it only if they bleed. I personally, in a septic patient, don't agree with this. I will give. Especially, I will give, I will still give. And again, even if your PTA-PTT is very high, you don't give FFP in a septic patient. In a non-septic patient, I can understand. In a septic patient, I will possibly still give. And then plasma exchange, they have not said routine. They have said plasma exchange is not to be done. It is not routine use. They are saying plasma exchange is not to be done unless, especially if you do not have TAMOF. And remember, TAMOF is not just multi-organ failure. TAMOF has got a very specific criteria. And even in TAMOF, even if you have TAMOF, they said you can or cannot use. Whereas the accepted therapy of TAMOF is exchange, is plasma exchange. So maybe there are a bit too, and a lot of people are now using extracorporeal removals, things like, cytosorb, those sort of things. They're also saying, no, you should not use them. You should not use them. It is not just you should not routinely use them. They're saying you should not use them. Feeds, again, important. If you are on escalating dose of inotrop or your BP is still unstable, do not use feed, do not start feed. But once your inotrops are not further escalating or you have started weaning your inotrops, it doesn't matter how much inotrop you are on, you should start feeds. And that's possibly what we all do. What is the change regarding recommendation hydrocortisone? Dr. Pao.
First of all, how did hydrocortisone come into the treatment of sepsis? It was initially thought that it was seen that after giving antibiotics, there was a deterioration in the status of the children. So the symptoms become severe. It was thought that due to the initiation of antibiotics, there was a release of cytokines and inflammation. So hydrocortisone was started to control the inflammation. But after multiple studies, it was seen that it does not do that. All patients do not respond to hydrocortisone. So the surviving sepsis guidelines recommends that you give hydrocortisone only when you have given initial resuscitation, the patient is anatropes and maybe a NORAD of or adrenal 0.2, then you may start hydrocortisone. Generally, it is a practice in many centers. And if you are known to have steroid deficiency in certain clinical conditions, or you are on oral steroids like nephrotic syndrome. In these patients, there is clinical indication of giving hydrocortisone. Saying that in many error studies, it was seen the research is on genetic profiling of the patients. Some patients with certain genetic changes will not respond to corticosteroids. In fact, the studies were shown that in these patients, the patients will deteriorate after corticosteroids. So the field is open. We do not give hydrocortisone in all patients. Currently, a study is undergoing international studies. It's called the SIPS trial. There is a stress hydrocortisone in pediatric septic shock. It is underway. The results will come out next year maybe, and then we will have a clear-cut idea. The protocol they have used is 10 milligram per kg of hydrocortisone as a bolus dose, and a maximum of 100 milligrams, and maintenance of 2 milligram per kg, maximum of 50 milligrams. So that's about steroids.
Fantastic. Yeah. So what is the change? In the previous edition, it was stated that you should give hydrocortisone once they are fluid and inotrope resistant. So you should give fluid inotrope, and they are still not getting better. You should give hydrocortisone. And in this guideline, they are maintaining clinical equipoise. So they are saying you may or may not use. And what does that represent? Again, that represents the confusion which is there in the literature. That in some cases, in some cohorts, it has worked well. In some cohorts, it has not worked well. And that is what is the truth. So the guideline is saying it's up to you, because we don't know. All right. What newer microbiological diagnostic tools are available, and how do they help? Now we are leaving the sepsis, surviving sepsis, and we are coming to what we are doing right now in Kolkata. And this is what new microbiological diagnostic tools are available now, and that is significantly changing our practice. Shothabrata.
So until few years ago, we were completely dependent on blood culture for septic diagnosis of organism in sepsis. But as in few years, lots of things are coming up. We are introduced to multiplex PCR methods, and that are very good for identifying organism for different body fluids. We can detect organism from our throat swabs, from our bowel fluid, from stools, and even we can detect organism from blood. At present in our town, we can do it after incubating the blood in the blood culture bottle, and when the organism Vitek signs are showing that organism growth is up to optimum, then we can take a sample and subject it to the multiplex PCR method, and it can identify. The problem was with blood culture that it was taking at least 3 to 5 days time to get that growth is present or not, then culture sensitivity report. So it was a time-taking process. And another important thing was that the yield was not very good. Some studies have shown 40%, some have shown 60%, and the reason was that patients were getting some sort of antibiotic, sometimes they are oral, and that was hampering the growth in the blood culture. But these newer methods have higher sensitivity than blood culture. They have almost, studies have shown near 80% sensitivity for these spaces. And one thing for blood, nowadays we are gradually shifting to this method, but till date, for culture sensitivity, we have to depend on blood culture. But these newer methods can pick up some genes that can indicate resistance. Like for Streptococcus, they can detect the methicillin resistance gene. For micrococcus, they can detect the vancomycin resistance gene. For enterobacter bacteria and pseudomonas, they can detect the carbapenem resistance genes. And I think in future we will get more of these things, and this will be the future of microbiology.
Absolutely, absolutely. And I think that is a change that we all have felt. Like, even 6-7 years ago, virus was a, all virus, one blob. And we didn't know you can have viral sepsis. Now we all can identify viruses, and now we know many of the virus infection, those kids can be really, really unwell. Right? We know, we all have seen that. So virus identification is something that has happened, and that is happening every day now. So that's a new change, definitely. And the game changer is the technology of multiplex PCR. All of them are basically multiplex PCR. What is good about it? Number one, your turnaround time is about 1.5 to 3 hours for all of them. So your turnaround time is very small. They claim a sensitivity and specificity, everything in 90s, especially specificity, about 98% for all of them, right? We cannot do PCR directly on the blood, on uncultured blood. So for blood, actually people are trying to develop technology where you can go for PCR directly from blood, but it's still not available in this part of the world, definitely. But even for blood, you have to go for standard culture. But even culture, nowadays you are all are doing Vitek culture, and they're much better compared to what we used to do previously. And even for blood, you have to put it in a Vitek, and the Vitek has to signal positive. So it has to be positive. But once you have got that, from that point to get the species and the resistance in standard, the time lag is at least 24 hours, often more than that. You will get flag koreche, organism ki jani na, resistance ki jani na. Porer din jante parle, we are very happy. Often you do not know it even the next day. Here, once the positivity comes, you can identify the species within hours. And most importantly, you can also identify many resistance genes, whether it is OXA, whether it's NDM. So you can also have a very good idea about the resistance. And another new thing is, of course, the upcoming MDR organisms. Of course, MDR has increased significantly over the last 10 years. That's it. We've got 5 minutes left, and I'll spend these 5 minutes to talk to you regarding the ongoing researches. The basic one is, the mortality in sepsis in adults is very high. In kids, it has always been low. In adult septic shock patients, mortality often is more than 40%. That surprises us because we don't see that, but that's the reality in adults. And it has not budged over the last three decades. In the last 30 years, it has not improved a bit. That's the reality. So we don't have any breakthrough. And why this is so? It looks like, although we treat sepsis like a single disease, it becomes apparent that it is not. It is a heterogeneous group. People with sepsis, they differ in many ways. But we treat them in the same way. Our treatment guideline is same for all of them. And possibly that is where the next breakthrough lies, that you need to identify the subgroups of patients who have special characteristics and tailor your therapy accordingly to get better outcome from this point. That is the overall understanding, that is the overall approach. Oh, sorry, I have not changed the, right, yeah. And we'll talk about 2 or 3 approaches, and the very brief mention. One is the immune, dysregulated immune response is a hallmark of sepsis. What does it mean? In sepsis, standard sepsis, what happens? Initially, you get a hyperimmune response that kills the bugs, and then from day 5 to 7 onwards, you get a bit of immunosuppression. The bugs are killed. Now you need a bit of healing, so you get a bit of immunosuppression, and then the immunosuppression also goes, and you go to your baseline immunity. That's the good response. And kids or patients having this sort of response, they do well. But kids or patients may have different response. What are the differences? Number one, some patients will have a hyperimmune response. So their hyperimmunity continues unabated. And that's the so-called cytokine storm. So in those patients, possibly we need to do some sort of immunosuppression. And we are already doing it, giving hydrocortisone, giving IVIG, removing cytokines by things like cytosorb. They all are basically that effect, that trial. What are the other dysregulated response? Some kids, and these two are more prevalent in adults, that they don't mount the immune response at all. So they go to immunosuppression straight away. And there is another third group who will have the immunosuppression on day 5 to day 7, but that immunosuppression will continue. And these patients will die later due to secondary infections. And these two patterns are more common in adults. Some research is going on to better identify the immune mechanism and then identify what could be done to, so far, this steroid, removal of cytokine, IVIG has not helped much. And in order to boost the immunity, what can you do? You can use things like GM-CSF, you can give things like leukocyte transfusion. But again, they have not given much benefit. But people think that once you can divide them and treat them accordingly, that can lead to one mode. Another thing is omic studies. What is a omic? Omic means in totality. Like gene, one single gene. Genome is your entire genome. So similarly, like on genomic studies, on all your metabolites that are associated with inflammation, so metabolomic studies, all your RNAs, all RNAs present in a cell, so that's called a transcriptomic studies, cytomic studies, all immune cells, you study all the immune cells, T cell, B cell, NK cells, everything. So that's called cytomic studies. So we are having all these things, and what are they trying to do? They are trying to basically categorize patients according to these specific patterns and then figure out what could be the therapy. These studies generate an enormous amount of data, often running into terabytes. And we did not have the computational power also to do these researches up till some time. But now we have the computational power, and a lot of these, almost all these researches are actually based on data science, based on artificial intelligence, mostly machine learning. So, and we have those tools, so those researches are being done now. Last point, nanotechnology. Nanosensors are coming, and nanosensors can revolutionize how we diagnose. You need very little sample, and you can get very quick results. Nanoparticles are being used to deliver drugs in distant, and that is something which is already there, nanoparticle drug delivery systems. I'll take possibly another 1 minute. So that's one. So those are the three areas where a lot of research is ongoing. The thing is, how long will that take to come to bedside? Years, maybe even a decade. Okay, so it will take a long time to come, and remember, all the research that is going now, 99% of them will fail. 99% of them will not lead to a change in clinical practice. So do we need to know them in detail as a practicing intensivist? No. We don't really need to know them in detail because they will never come to your bedside. They will never affect your clinical practice. But possibly it is a good idea to track them, maybe just to keep life interesting. That's it. Thank you.
Good morning. I think all of you have enjoyed the session. I must thank the panelists, and I must congratulate Dr. Ognishekhar Saha, who is famous intensivist working, I think, since 2006 continuously. 2006 continuously, a famous intensivist, pediatric intensivist, and he is now attached in ICH and multi-specialty Apollo Hospital. And I must congratulate again Dr. Saha for his excellent role as moderator in this session. We have learned many things, particularly new things, and we should try to apply all those things, and particularly
I think the pre-conference workshops will help the juniors to deal the patients of sepsis, particularly in critical care setup. Thank you.
Thank you, everybody. Thank you to my panel members. Yeah.
Thank you so much. I'd like to request the moderator, chairperson sir, and the panelists to kindly proceed to the felicitation area and collect the memento. Now, without losing time, we proceed to our next session. It's on dengue shock management, discussing the myths and the facts. We have with us Dr. Shubhashish Bhattacharya, Head of the Department and Professor, Pediatrics, Chittaranjan Shishu College of Obstetrics and Gynecology. I'd like to request you, sir, to kindly come up on the stage and take a seat. And I'd like to request, sir, to kindly introduce and welcome Dr. Eber Jacob James, sir. I'd like to request, sir, to please come up on the dais.
Good morning, and a very important session as we are approaching to the another dengue season, and probably we'll be experiencing more such cases, and we know that the dengue shock syndrome is one of the important cause of mortality the children infected with dengue. But there are many myths and misconceptions about the how to treat this condition. We know that the fluid is the only management. Fluid is the only thing is very important, but this fluid is also dangerous in managing the dengue shock syndrome. So it is a double-edged sword. So what is the recent recommendation of managing dengue shock syndrome? And that is the topic of this session. And the expert will be Professor Jacob James of Christian Medical College, Vellore. Is a head of the pediatric critical care unit there. He is associated with pediatric critical care with the Indian Academy of Pediatrics, IMA, or many other organizations. He have many paper, nearly 40 paper on pediatric intensive care. I think I am hand over the mic to Dr. Jacob. Please deliberate your topic on.
Thank you.
Dengue shock.
Thank you, sir, for your kind words. And good morning, everyone. And I thank the organizers for inviting me for this East Zone Pedicriticon. Sure. And I bring greetings from Christian Medical College, Vellore. And then on behalf of the IAP Intensive Care Chapter College, I extend a warm greetings and best wishes for this conference. So the topic given to me was about dengue shock, and sir has already introduced the topic, and he given the answer also. The treatment is mainly about the fluid therapy and how we do that. That's what I'm going to discuss. So when we talk about septic shock, the last 1 hour we had a great discussion led by Agni and his team. So wonderful to hear. There were some concepts has come new. So when we come into dengue, the next maybe 20 minutes I will be discussing about what is the management, what we do, and is there any pitfalls and how can we solve that. That's what I'm going to do. And as we know, dengue has a big burden, global burden. It's about half of the world population is getting infected, it seems, they say. In the year 2023, there were 7 million cases, that is reported cases of dengue. That's 70 lakhs all over the world. But you need to remember the death reported is only 7,300. The case fatality rate is less than 1%, we all know. But children, when they are affected, when they come into our acute care or HDU or ICU, we struggle. So that we will try to discuss and see how we can mitigate that. This is one 8-month-old girl is brought to emergency with fever for 4 days and vomiting, some faint rash, excessive crying. Mother says no fever that night, but is irritable, Some physician has seen and given prescription and sent home. The baby came 8 hours later, brought to home, with, like you can see that capillary refill time is prolonged and then some signs of low perfusion, and got admitted. We know that's most probably a tropical fever and dengue. So the point here I'm going to make, one is the delayed diagnosis and failure to recognize the temporal sequence of the events happen in dengue fever. We know WHO in 2009 has classified like this. After this, there's nothing has come. 2009 has classified as dengue fever with warning signs. Clearly they have put what are that. And severe dengue, when there is a severe capillary leakage with shock, severe organ involvement and severe bleeding. That's what we still follow. What about some rashes also is very important in this. That's what I put this picture. The picture on this side is what? What is this rash? This is that. This is, already 3 minutes. This is the erythematous rash which is seen in the febrile phase. These islets of white in a sea of red is seen when there is a convalescence or recovery. Okay, the temporal sequence, when I mean, this is the course of illness. We know there is a febrile phase, a critical phase, and a recovery phase. Usually it is predictable. Sometimes it cannot be as well. So what happens in a febrile phase? It's about a week. It can overlap. The critical phase is about 24 to not 48 hours. It can go beyond that. If it involves organ involvement, it may predict more than a week also. And recovery phase, usually 48 to 77 hours. All together in a 10 days time. But what happens in a critical phase? There are a lot of capillary leakage. Patient is in shock, require volume replacement therapy. And when they get better, during the recovery phase, all the fluid goes back into. That's the natural course of the dengue fever and dengue warning signs or severe dengue. This temporal sequence we need to know, and we need to act according to the time of the illness. That's what I mean. When we are missing that point, there can be a delayed diagnosis. In that 8 hours, is it significant? 8 hours is really significant for an infant. That infant can go into a severe shock, replenishing fluid, and then we will be struggling with overload and other things as well. So the first point is how we can avoid this delayed dynamics. We need to know the temporal sequence. It is dynamic, it changes. Sometimes it's unpredictable also, we need to remember that. So the danger signs requiring urgent hospitalization is all these things. But want of time, I'm not explaining that. You all know poor perfusion, not only looking at the blood pressure. Please remember, NIBP, when you are checking in a critically ill child, when there is perfusion is poor, it's not about that. It's all about the perfusion of the child. So that's what one of my senior professors used to say. So you touch the feet of the child. That means touching what? Dorsalis pedis. You touch the peripheries, or how is that? Touch the dorsalis pedis, how is it? That tells you the perfusion of the baby, not the numbers of the blood pressure. So we heard all about septic shock. Is there any difference between dengue and septic shock? In that, what is the type of shock is dengue? We all know it's a hypovolemic shock, but with a difference. Hypovolemic shock, what? Hemorrhagic shock or acute diarrheal dehydration. There we know we can quantify how much has gone out. Here there is no overt fluid loss, only third spacing. And it happens during the afebrile critical phase, capillary leak, and they may be looking bloated, and there is hypovolemic shock, and it cannot be measured. Features of dehydration may be there, but cannot be measured. That's what the volume replacement therapy we do here. And one important thing is the narrow pulse pressure. That might give us a clue, right? Which is like in cardiogenic, you may say, right? In hypovolemic, in this figure, in a wide pulse pressure, you see in septic shock. And always we know relative bradycardia also happen in dengue, like in enteric fever and in other tropical fever like things, right? So these are the unique features of dengue shock, which we may have to pick up to little subtly differentiate from septic shock, because the management makes a big difference, as we discussed in the first session, right? So here we have to give fluid, but it has to be in a phased manner. That's what we call it as volume replacement therapy. Otherwise, we'll end up in fluid overload. Yes? comes here. As sir said, the mainstay of treatment is fluids, fluids, fluids. Fluids is important, there is no doubt. What is this picture, anyone can say? This is something called, in the endothelium, we have something called as glycocalyx, which is the gatekeeper of the endothelium. It's cement together. In septic shock also it has a problem. That's what all the capillary leakages happen. Here it is profound. That's what they all fluid all go into the interstitium and third space. So in critical phase, that's what we are interested in, right? Where the patient becomes sick. 3 priorities is important. We know capillary leakage, fluid is, plasma is going out. We have to replace it. That's what WHO has come out with, a beautiful replacement therapy for warning signs, compensated shock and hypotensive shock. We all follow that. So we need to recognize that. Also early recognition and treatment of bleeding prot. The third is how we can prevent the fluid wound. It is a balance. You need to give fluids, is important. It saves. The same time, it can kill also by making a fluid overload. It is a difficult task unless we are very carefully monitoring. Okay, so the early recognition of fluid therapy, the aim is minimal acceptable circulatory volume. How do we know that? We can't aim for a normal blood pressure and normal urine output of 2 to 3 ml per kg. No, this is the target we mentioned here. I'm not explaining that. The point here I want to make is, do not chase numbers, not to have a normal blood pressure, please. Perfusion, is it improving? That's it. Urine output, we don't want 1 to 2 ml per kg. That tells you is an earliest indicator of fluid overload. Just 0.5 to 1 ml per kg per hour, fine. Just tide over the critical phase. Do not too much. Yes, fluid is important. We need to give as per the, that's what if you read carefully, WHO fluid therapy warning signs they gave, give fluid for 1-2 hours, stop it. They say stop. Check the hematography. That's what they, sometimes it's not feasible, but they say 2 hours, check the hematography, stop the fluid. So we need to know as well when they are in critical phase in our ICU or HDU, when to stop or just put on maintenance fluid. Okay, how do we manage? I have just already told about all these algorithms, you know. WHO, the same algorithm, incremental or decremental. Decremental, if there is a hypotensive shock, you will start with high fluid and come down, or otherwise you may step up, right? That and all, you know, it's given. The challenge is how to give this fluid therapy or volume replacement therapy, minimizing the fluid overload. There may be fluid overload, doesn't going into ventilation and causing the whole sort of a conundrum, what we call dengue shock syndrome, it's a vicious cycle. That's what children die after that, right? So the urine output, as I told you, if it is more than 1 to 2 ml per kg, be cautious. We don't want that. We may have to cut down the fluid. It's a hypovolemic shock. We may not require vasopressors, but if in some time, if you need, you give that and take it off quickly. Which fluid should be given? So when we talk about fluid, you talk that, right, all the time in septic shock also. We have crystalloids, balanced crystalloids and colloids. So we know physiologically, if you give hypotonic fluid, what happens? It seeps out. It goes to the interstitium, right? That's what, yeah. If you give crystalloids, it comes out to some extent. If you give colloids, it may stay there. That's what physiologically and rationalizing we talk. We know that. That's true as well. But when it comes to clinical picture in bedside, it's not making a big difference whether you crystalloids or colloids. Even in dengue, the second study is fully in dengue shock syndromes, they didn't make a big difference, either crystalloids or colloids. Having said that, practically if they fail, even your WHO certain articles they say, if it is failing with your crystalloids, you may consider colloids, but not necessary to give colloids early itself. So crystalloids are equally effective, adequate. Normal saline, ringer lactate. But if you have a liver dysfunction, better to avoid ringer lactate. Colloids in severe dengue, individualized, depend on your experience. Maybe second or third time you may give that. Using albumin, we have to be careful. Here also there will be capillary leak. As I told you, there is a big capillary leakage happens in dengue. So definitely it will go. It will cause compartment syndrome. It can cause pleural effusion. So monitoring is very, very important. So the end point is not only for colloid, the fluid, end point is improved perfusion and urine output. So then you come down on the fluid rate. You monitor the urine output is very important. 0.5 to 1 ml, not more than that. Widening of the pulse pressure. Another important clue for you to tell child is getting better, which was a narrow pulse pressure, now it's better. Then we do the laboratory, decrease hematocrit. And also remember, look for worsening features of respiratory pattern. Because if it's fluid overload, they may go with respiratory distress. This is one paper published in 2018 by Dr. Suchitra and team in Indian Journal of Critical Care Medicine. They found standard therapy is crystalloids, here is albumin group. They found the positive fluid balance in the albumin group is less. That means they are able to, the infusion rate is less. Probably that's what we said, second, third time if you have to give in a critical child, albumin may be better. But remember, the point which I am here making is fluid is important. Avoid that slippery slope to go into a fluid overload. How we can do that? Close monitoring, urine output, widening pulse pressure, all these subtle things you have to monitor and stop or come down on the infusion rate. So these are the challenges we do come across, but the detailed flow chart looking at vital signs, fluid balance, hematocrit, by teaching our nursing colleagues that they themselves will tell us this is what, then we can really reduce the mortality. Ultrasound, yes, it might be helpful with expert hands, but it has its caveats in dengue because abdomen is looking big, bloated. How do we look at the IVC and all? There are a lot of challenges more than septic, but it has its clinical applicability. Okay, coming to our child, they initially responded to fluid. Now is going, pulses are hard to feel and perfusion is poor. Now you have options of whether to give more fluid, add albumin, or can we add inotropes, what else? But looking at the child, the abdomen looks a little bigger. Anything coming into your mind? Always in dengue management, when you are giving fluid, you need to think about compartment syndrome. Yes. So the mixing abdominal compartment syndrome, that's all the third spacing, right? Like pleural effusion, it goes into the abdomen and becomes tight, causing pressure over the liver as well as kidneys, causing acute kidney injury, shock, the venous return is hampered. So it's very important to look at the compartment syndrome. So you have to measure the intra-abdominal pressure through Foley's catheter. Now they say for children more than 10 to 12 is significant. If there is evidence of creatinine or urine output coming down, creatinine going up, it's called abdominal compartment syndrome. You have to relieve that fluid. How can we do that? So there is, people do pigtail catheters. We don't do that. Sometimes we may do like a peritoneal dialysis if necessary. We will start if they have AKI. But some units regularly they practice that. Early put a pigtail catheter and remove this fluid. We have to be careful when doing it because bleedings. So considering the abdominal compartment syndrome is very, very important. So want of time, I'll just go to the next scenario. So here there is a child who has come with some signs of dengue, warning signs probably, and is been on, blood pressure is okay, perfusion looks okay. He's on peripheral intravenous, one line is there. You want another line or do you put central line if any patient comes to your ICU? Here it's very important in most early inactivity is necessary in dengue. Okay, so when you are using invasive lines so this, it can be a double-edged sword like this, even putting procedures. It can cause bleed. So big risk of bleeding and hemorrhage if you do something, nasogastric tube. Provide orogastric, that's best. So avoid the central lines unnecessarily. I'm not saying that's what they put the word. The central line must be earned. If it is necessary only, you have to. Otherwise, please avoid that. So just another case scenario, I'm not fully detailing about, there is bleeding here. Fully oronasal bleeding and cold peripheries. Perfusion is poor. So can we, the platelets are low, 10,000. So can we give fluid, the blood products, and how do we stop the bleeding? Here the important point which I want to make is, Hemostasis is important. That's what we don't want unnecessary procedure. If there is a bleeding profuse from epistaxis, you have to pack it. That's what is equated. Hemostasis in dengue is important as a source control in sepsis. It's very important. It's not only just giving the blood products. You need to stop. If you have put a central line, you have to suture it properly. That has to be stopped. Too many blood products, we should avoid that. WHO says whole blood is the best thing, right? Whole blood is the giving blood products is not great. You may give FFP, platelets, before giving platelets you have to give FFP, then you give packed cells. Whole blood is the best, but nowadays is very difficult to get. That's true. Okay, so in hemorrhagic shock, we have to stop the bleed. Yes, we may have to judicious use of blood products is important. So this is very commonly seen chart in WHO also is there. So you go not only by the hematocrit, look at the hemodynamics. Whether you want fluids or stop the fluids or continue fluids slowly or you give blood. Depends on, for here, the hematocrit is normal or coming down, hemodynamics unstable. So here it is maybe a occult bleed is oozing from the tummy. So there you have to give blood. So that's what here assessment of clinical and hematocrit is very important to manage such as things. So in bleeding dengue, these are the things to remember. So remember unnecessary giving or prophylactically giving blood products. Okay. At the same time, you have to stop the bleeding. Local and hemostasis is very important. Okay. All right. So another important point I want to make here is about this lethal triad. When there is acidosis persistently, that's what prolonged shock, it's not good. If the shock is prolonged, you can pretty much make sure the child is not going to make it. Prolonged shock causes acidosis and coagulopathy and hypothermia. This triad is lethal. It's really a lethal triad. Although you may remember something called ABCS in WHO documents. Have you know? ABCS. What is that? Acidosis, bleeding, calcium, and sugar. So they say ABCS, control that. Is almost similar to that. Okay? The lethal triad, they follow this in major trauma. Acidosis, coagulopathy, and hypothermia, we have to be beware of that. It's very important. So hypothermia, as I told, is significant. So you need to warm the patient. Even you are, especially sometime when the PD or CRRT, if they are doing, they may go into hypothermia. So hypothermia should be taken care. The next, this child, I am not reading the child, the scenario. So here the child has come with distress on oxygen desaturating. So now the question is whether to intubate or not intubate. So you need to remember positive pressure, it's a problem in shock because it will cause venous return is hampered. Not only that, when we give drugs, it's all depresses respiration, just 2 minutes, just depresses the respiration, not only respiratory depression, it depresses the heart, myocardial depression. Not only that, any drug you say, it causes vasodilatation. So myocardial depression and take benzodiazepines. The best they say ketamine is best. Even it can cause, right? All these opioids, everything can lead on. So when a patient is borderline shocky, you give that, they will crash. You would have seen that, right? So that is what immediate intubation is, if it is required, yes. Otherwise avoid and put non-invasive ventilation. But closely monitor. But when we have to intubate, you may have to, so I'll just go to the next. When you have to intubate, you have to be careful choosing the drugs and be prepared to resuscitate. So when we intubate a dengue child, they call RSI, we know, rapid sequence intubation. Here is resuscitation sequence intubation. Be ready to resuscitate. Be ready to give volume, be ready to give inotropes, or you may start. So that is the catch here. We know this, you all would have been knowing, not only dengue, any patient who has got all these three things we call physiologically difficult airway, hypoxia, hypotension, metabolic acidosis. Some book says HOP triad, it's a mnemonic. HOP, H is pH. O is oxygenation problem. And, H is hypotension, O is oxygenation problem, P is pH, metabolic acidosis. Right? So this triad is lethal. So that's what they call physiological difficult airway. When you are intubating these children, it should be like resuscitation sequence. Be ready to resuscitate. So when there is a fluid overload like this, you may monitor, the child looks bloated. So what to do? Now child's shock is getting better. When to remove the fluids and how to remove it. You can even, a lot of that evidence is that how we can use diuretics to take this fluid. I told you in the recovery phase, our body itself causes the fluid goes inside normally. But if they are in very much in shocky and you've given lot of volume, you may have to help using diuretic infusions or renal replacement therapy. PD, CRRT, there is a lot of debate going on. But I am not going into that. PD, some centers follow. Our center, we do both. PD and CRRT as well. Okay? And it has its own plus points as well as pros and cons and negatives as well. The last point is the important, it's all very debatable thing, use of immunomodulation. What I mean? Steroids, IVIG, anakinra, plasma exchange, so many newer things people talk about, right? When? That is what they say, secondary HLH due to dengue. But how do we know? Is this patient? Ferritin is the only thing they say, or liver dysfunction, significant with ferritin being high, you may have to think about it. So the point and the message I am giving is, if this patient is sicker with multi-organ dysfunction, with high ferritin, maybe I would say 10,000 and above, some units follow 5,000 and above, and persistent shock, you may have to think about the cytokine storm, secondary to viral infection. Where you may have to think about the immunomodulation like IVIG, anakinra, plasmapheresis and all that, right? So that is where CRRT and plasmapheresis people they do. Finally, just I put the take-home message, what I discussed. Fluid is the mainstay, there's no doubt. But remember, the fluid overload, minimize it. You can't avoid it. There will be. But minimize the fluid overload and the problems of that. You avoid blood products unnecessarily. Hemostasis is important. Stop the bleed by means of packing and that, which is equivalent to source reduction in sepsis. Prevent hypothermia. Avoid unnecessary procedures. Respiratory support, NIV is preferred. If you have to intubate, you have to intubate. Use resuscitation, that remember the HOP word. And compartment syndrome is an important issue. It is a fact. It can cause problems, the shock worsen. And at time, the diuretics and the renal replacement has to be done. And immunomodulation in selective cases may be required, that you need to see at the bedside with the laboratory. And this picture is about who's this? A border security soldier. He doesn't act. He is not like a marine commando. He will jump and shoot everyone. No. He will be ready to shoot when there is a threat. That's what as a physician we have to do in ICU. Just watch carefully what is going on and act rather than just giving everything too much will end up in problem. Thank you very much for patient hearing. Sorry for taking 3 more minutes.
Very important aspect of dengue and also pitfall associated with the management of dengue. So most important, already he mentioned that the clinical monitoring, not chasing the particular one thing of the vitals. Any 1 or 2 questions from the audience? Okay. Thank you, Dr. Jacob.
Thank you, sir. I request you to please go to the felicitation area to collect your mementos. Now we have the next session. So the next panel discussion, let's start on that. Sedation, analgesia, withdrawal and delirium with a focus on the pandem guidelines. For this session, I would like to request our chairperson, Dr. Taroknath Ghosh, to please come up on stage. He is the professor and PICU in charge in Neurodevelopmental Clinic of Bardhaman Medical College. Thank you, sir. And our moderator for the session, Dr. Abhishek Poddar. Panelists, Dr. Shananda Mukherjee, Dr. Momita Shamanto, Dr. Nandini Singharai, and Dr. Vanashi Shanklam. Please come up on stage. Thank you, sir.
At the outset, I wish to thank the organizer for giving me the opportunity to introduce our moderator for the session of pandem guideline, which deal with the delirium, sedation, and pain management in PICU management. Now, I just introduce Dr. Abhishek Poddar. He is a consultant pediatric intensivist and Apollo Multi-Speciality Hospital, and also Secretary, West Bengal Pediatric Intensive Care Society, and he is DNB Coordinator, Apollo Multi-Speciality Hospital. Now I request Dr. Abhishek Poddar to introduce his panelists and start the session.
Yeah, our panelists are for the morning Dr. Nandini Sinarai, Dr. Shananda Mukherjee, Dr. Previous slide please. Dr. Nandini Sinarai, she is a consultant pediatrician, West Bengal Health Service, faculty in IAP, ALS, BLS for the last 10 years, and all of us know Nandini, so no new introduction for her. Dr. Shananda Mukherjee, she is MD Pediatrics and Fellowship in Pediatric Critical Care from St. John's Medical Bangalore with a Fellowship in Pediatric Critical Care from the UK. And now currently she is at Apollo Hospitals, Bhubaneswar. Our next panelist would be Dr. Momita Shamanto. She is MD MRC PH and Professor and HDU in charge, Pediatric Medicine, Medical College, Kolkata. And last but not the least is Dr. Sanglo. He's come all the way from Nagaland and Dimapur, Nagaland, and he is a fellow PICU and Pediatric Critical Care Transport, done his fellowship at Royal Manchester Children's Hospital, Manchester, UK. Now we have a very nice panel, and nice to see you all very vibrant on a bright sunny Sunday morning. And hopefully by the end of the session, though the topic is a little bit boring, but I will try to make you not sedated at the end of the session. So without too much ado, we will start the session. PICU sedation is something which is not actually discussed or not actually very important as considered by us as intensivists, because we are more into mortality, morbidity. So PICU sedation, analgesia is something we are a little bit less concerned, and I think all of us as intensivists would agree to it. But why PICU sedation and analgesia is important? Because PICU, it is a very complex clinical problem, and often we say patients are very agitated, especially children, and many of us feel that, many adults feel that, okay, children, it's a child, so he won't feel any pain, he doesn't feel much pain like an adult, but it's a completely misnomer. There are all current therapeutic approaches. Whatever we use in the PICU as sedation has side effects, and we will deal with those today. And there is a very fine balance between agitation and over-sedation, and hence PICU sedation analgesia should be protocolized. And based on the pandem guidelines of 2022, which has very recently come up, not even the last 2 years, we'll discuss today's talk, and the discussion will be based on that. So we'll start off with a case. We have a 10-year-old child with a road traffic accident brought to the emergency with a GCS of 7/15. Intubated in the emergency, CT scan was done, no evidence of intracranial hemorrhage, fracture of the atrium, right side, no flail chest or hemothorax, no other injuries, sent to the PICU after initial stabilization in the ER. Now, we'll come to our intensivist and see what happens and how to deal with this case and the other options for other patients as well. So the child has to be kept sedated with analgesia over the next 40 to 72 hours, suspecting raised intracranial pressure. Other neuroprotective measures have been ensured, not requiring any inotropes or vasopressors. So my first question to Dr. Nandini would be, why would you need sedation in the PICU, especially in such a case and other cases as well? Is it required actually in the PICU?
Yeah. First, I'd like to thank the organizers for giving me this opportunity. Now, coming to this case is already intubated and under neuroprotection. So, as a component of neuroprotection, we need to sedate this child. Apart from this, for the ease of mechanical ventilation, it's needed for allaying anxiety. Okay. Then, to take care of the pain, to take care of any procedure we are going to do that may be diagnostic or that may be therapeutic. For these cases, we need to sedate a child.
So there are multiple reasons why you should be sedating such a child, especially who is ventilated and having suspected raised intracranial pressure. So what would be a goal in such patients?
Patient's comfort is the ultimate goal, okay? So we have many guidelines, many scoring systems to assess that we regularly use in our setup, okay? So I think I have already discussed these things. So our goal are to take care of the oxygen consumption. We try to keep the oxygen consumption to be a minimum, okay? And to blunt the spikes of raised intracranial pressure. That is one of the requirements. We are talking of sedation. The sedation is not the only goal. We need to take care of sedation. We need to take care of analgesia, amnesia, and also angiolysis.
And most important, so that the patient doesn't get self-extubated, because that is one of the most important things when you don't give adequate sedation or analgesia to the child. Next one day morning, the next day morning, you come from the rounds and the resident tells you that the patient has got self-extubated. You don't want that scenario. So my next question to Dr. Shananda would be, what would be the characteristics of an ideal sedation agent which you would be using in your PICU?
So ideal sedative agent should be having adequate pain control. That is the most important property. But at the same time, it should not be having respiratory depressing and do not depress the circulation. So do not cause much hemodynamic instability or respiratory depression. Also, it should be able to take care of the anxiety in conscious or semi-conscious patients. And also it should be fast to act, rapid acting, and short half-life, so that once the agent is stopped, the effect is also weaned off quite early. And it should be available in a titratable infusion form, so that it can be titrated as per the response.
Very beautifully said, but one thing we should all remember is that majority of the sedation agents which we use in our PICU do not have much of analgesia effect, right? So we should be careful about that. Now, what are the challenges you face in your PICU with sedation?
So main challenge is to achieve a balance between under sedation and over sedation, because when a child is under sedated, then there are chances of, as you had said, inadvertent removal of devices, most importantly ET tube or any invasive lines that are there, so that might get dislodged. And again, if we overly sedate the child, then that will also prolong our duration of mechanical ventilation, prolong the ICU stay. We might have extubation failure, and also the behavioral sequelae after the child gets discharged from the PICU, that is also significant. So we have to strike a balance between these two, and that's, I think, the most important point, the assessment of how deeply the child is sedated. And that should be a regular assessment.
Right, absolutely. So my next question to Dr. Wanashi would be, what agent will you use for sedation in this case? Specifically, the child is intubated, ventilated. What would be your first sedative agent which we use?
So the first and the ideal choice would be benzodiazepine, preferably a continuous infusion of midazolam. This will provide hypnosis, anxiolysis, as well as anti-create amnesia.
So definitely we all use probably midazolam as our first sedative agent, because it is the one agent which has got minimum side effects. So we have to choose the right drug, because we have to strike a balance between sedation and analgesia. But unfortunately, benzodiazepines, as I mentioned, it can cause only amnesia, it can cause hypnosis, it can cause anxiolysis. Most of the things are covered, but it doesn't have any analgesic effect. So someone who's having pain, and especially in this case, who's a road traffic accident child, that patient should be having good amounts of analgesia, so that your levels of pain are significantly less, because benzodiazepines do not provide any. So what are the standard guidelines, referring to the Pandem guidelines as I mentioned, what do they recommend about sedation?
According to the guidelines, they recommend the use of Comfort B scale to monitor a child who is on continuous sedation. We can use other scales also, like the state behavior scale and Richmond agitation scale. But currently it is Comfort B is recommended at least 3 ICE a day we should do. It is based on 6 behavior scale. It can be done in ventilated and non-ventilated children. You need to observe the child for 2 minutes to do the scale, and based on the scale they put the child in 3 different categories, 3 different zones. Ideally, if anything beyond 17, score beyond 17, it is we don't want the child to be beyond 17. That means either child is agitated. It can be due to pain, can be due to less of sedation. So that is the time when we need to go back and look at the pain scale too. So if the pain is high, go on analgesia. If the sedation is low, go. Ideally, we keep it between 12 to 17. That is the ideal comfort piece.
So now I want a raise of hands amongst those who are here as to how many of us use analgesia or pain scales in our units. Anyone? Less than 1%. So from now on, this is as per the recommendations. We should be using pain or sedation scales in our ICU for all patients, especially who are ventilated. It can be done for non-ventilated patients as well, because the response can be seen in non-ventilated patients as well. So let's start using pain scales, because it will be comfortable for the child, both a ventilated or a non-ventilated child. So basically it indicates 6 behavioral indicators, as I mentioned in the scale, following a 2-minute observation period. It does not take any of the hemodynamic parameters into account, so that is much easier for the sisters also to participate in doing the scale. Right. So it does not take the hemodynamic parameters into account, and while minimizing the potential for adverse effects. So it can be used in any child less than 18 years of age, and obviously for children who are on neuromuscular blocking agents, we cannot use this scale, right? So you would target between 12 and 17 is what is recommended for the child to be alert, calm, and not in a either agitated state or hypersedated.
Yeah, in that state he can even trigger, he can cough, but he will be alert and responsive to the
Absolutely. So those are also important points which should be kept in mind. So I think that this comfort B, this requires a lot of parameters there. You have to calculate probably 3 times a day in each nursing shift, for that matter. You have to score. Any easier scales or any less cumbersome scales, do you know, or do you recommend any of those, Dr. Shananda?
So I would recommend the state behavioral scale score, which is very simple. So you will assess the patient's response first in response to voice, then to light touch, and then noxious stimuli like endotracheal tube suctioning or nail bed pressure, which is less than 5 seconds. So that score ranges from -3 to +3, and the more the score, the more awake is the child.
So these are less cumbersome. Any other scales for that matter?
And then we have the Richmond agitation sedation scale, so you can see the parameters, and they're also scored in a 4 to -5, +4 to -5 scale. And so the higher the score, the more awake and more combative is the child, and lesser the score, the child is more sedated.
So trying to keep the child alert and calm so that he's not agitated, he's not over-sedated, he can participate, especially in a little bit older children as well. Now the question to Dr. Wonashi, are sedation scales needed to be followed? Do they give us any advantage?
Yeah, absolutely. I mean, sedation scales, they give us an idea about whether a patient is under-sedated or optimally sedated or over-sedated. As we know that under-sedation can be detrimental. It can lead to patients pulling out tubes and lines inadvertently. And on top of that, it can give a very bad experience, ICU experience, which can have an impact later on in life. Whereas over-sedation, as we know, can cause prolonged ventilation, prolonged PICU stay, prolonged hospital stay, and it can also lead to situations like iatrogenic withdrawal syndrome and delirium and so on. So absolutely, I would recommend the use of sedation scales
But
in PICU
sedation
patients.
scales don't tell you about the anxiety or the pain which the child
Yeah,
has.
I mean,
And especially, it's difficult, especially in very
Those-
deeply sedated or paralyzed
Yeah,
patients.
in paralyzed patients, it's
And one thing we
difficult.
are all concerned in the PICU is outcome. No, it doesn't predict outcome. And one thing you continuously need to do is reassess the need for sedation. That is one thing which is very important continuously, especially in your morning rounds. And in each shift, probably it's better if you can reassess the need for sedation and gradually titrate the sedation to desired effects. Advantages are that it will decrease your use of sedatives, shorter PICU and hospital length of stay, and hence the cost, shorter stay on ventilator, less delirium, and less cognitive dysfunction. Now to question to Dr. Nondini. Now we always talk about interruption of sedation. We all have used that. What are the current recommendations on the use of these intermittent sedation, stoppage of sedation?
We have been traditionally using this interruption of sedation during the morning rounds or in the morning shifts to assess for early weaning. But as per the new guidelines, there is an update that this is not recommended because it has been shown that it has not improved the outcome. On the basis of this data evidence, it is not recommended now.
So probably we need to stop following this newer, stop following our age-old practice and start
Interruption.
following this practice.
I just want to add one thing. They said it is not necessary to do interruption provided you have assessed a sedation scale to the child.
Obviously.
And you are maintaining that.
You have to maintain the scale and keep on maintaining. You don't want the child to be over-sedated or over-agitated, right? So the question to Dr. Vanasi, is analgesia routinely recommended or is sedation good enough?
So majority of children in PICUD experience pain, and persistent pain can have physiological and psychological implications, and it can be detrimental in, especially in this case where you are neuroprotecting as well. So the answer is yes, there should be no pain. So yes, analgesia should be used, and there are various scales. Regarding to the second question, there are various scales which assesses pain, but generally speaking, like agitated child, a crying child, hypertension, tachycardia, lacrimation, and all these are general signs that the child is in pain.
Again, vague parameters, vitals are there, but these are all difficult to assess. So probably again we should move for analgesia to scales as well. So how would you assess pain in the PICU, right? And do you need to, as we mentioned, yes we need to.
Yeah,
but
we obviously
how
need
do you
to.
assess?
Now we can group them into communicating child and one who can express, and the other, everybody can express, but one can communicate well and the other were not able to communicate. So more than 6 years old, we can use the visual analog scale and the different other scales like numeric rating from 1 to 10, Ausha scale, Wong-Becker, faces pain scale. So here we can see from 0, we can ask them to point on the chart how much pain he or she feels, like 0 to no pain and 10 as the worst possible pain that that person has felt in his or her life. So this is subjective, but this helps. And this again, one if can't rate as in number, they can point to the face that how he or she feels. So from that we can assess.
Now the Western world is very intrusive about children feeling pain. So whenever we have, our hospital has a regular JCI audit. So whenever we have an audit, the inspector, whoever comes in first and sees and says, where is your pain score? Now this is something we as residents never did. So now gradually we have come up with that, and we have to follow various pain scales as Dr. Nandini specifically mentioned. The Wong-Becker faces pain scale for children specifically more than 6 years of age. FLAC scale, would you say anything about FLAC scale?
It is for the younger children on the basis of observational scale. There are certain criteria looking up the face, leg, activity, cry and consolability. For the younger children who cannot express as in numbers on pointer face, this is the observational scale that can be used.
So basically for neonates we use the NIP score. Anything above a neonatal age group till 6 years you can follow the FLAC scale. It is easy to follow and it should be documented, especially at least once a day. If better, it would be better if you can do it once in each shift. So the guidelines recommend the use of observational pain assessment tools rather than vital signs alone. So only hypertension or tachycardia may not be just reflective of your pain or level of sedation. There are other things which can go into it. So we suggest, they also have mentioned the suggestion to use observational pain scales rather than vital signs alone for the same. Now, Dr. Shananda, what are the principles of pain management which you follow in your PICU?
Yeah, so as you had already mentioned, pain in pediatrics is an understated thing. First, we have to address that the child is feeling pain, and we have to identify all the noxious stimuli or stressors that we have done while we are doing care for the child. We have to address it, assess not only vitals, but those scales that has been mentioned, we have to use and score and properly quantify the pain. And then if we give sedation, we have to reassess by doing that score whether it is improving. If not, then we have to increase our sedation or add another agent. And we have to review a number of times during the day, assess, review and document.
This is very important, this reassess and document. Whenever you are doing a pain scale or a pain score, document in your file. If the child is having a pain scale which is probably in the range of 6, 7, 8 like that, you have to give some analgesic. Again, come back 20 to 30 minutes later, document that the child's pain has come down and document in your file. That is also very important. Just the child having pain, doing a pain score is not important. Give your therapy and re-document again that your child's pain has gone down. Any non-pharmacological agent you would recommend for or can be used for pain management?
Yes. Music therapy is one. Studies have shown that the music therapy leads to decreased pain, decreased anxiety, and improved sleep quality in critically ill children. Non-nutritive sucking is another one with sucrose, which has been proven to be very effective in infants as well. And of course, there are other measures like the presence of the parent in the ICU, or if there is a fracture, splinting it, and then adjusting the position of the child, adjusting the ventilator tubing so that it does not cause traction on the endotracheal tube, which indirectly which causes pain. All these things are the non-pharmacological measures that needs to be
many of our nursing staff, I think majority of the hospitals would also, you all would also agree that many of our nursing staff usually don't prefer keeping the mothers in the PICU because they feel that the mothers are a cause of constant irritation or hindrance or care. But music therapy, alongside music therapy, maternal presence is something which is also very important and is recommended in the guidelines, which we'll come to next. So, what medications do you want to use for pain management, especially in the PICU setting?
In a ventilated child, usually the drug of choice is opioids like fentanyl, and recently now alpha-2 agonist dexmedetomidine is also used. That's a second line.
Right. So, when you are thinking about analgesia only, it is basically opioids, which are number one, and I think the guidelines also say the same, because the guidelines recommend that IV opioid should be the primary analgesic which should be used in patients having moderate to severe pain in critically ill pediatric patients. Any other agents alongside opioids you want to use?
We can use non-steroidal anti-inflammatory agents as well to improve the post-op analgesia, and also it reduces the requirement of opioids.
Right, very important. NSAIDs may be used, especially in the post-op setting, where it decreases the need for opioids, because giving opioids continuously and then the chance of withdrawal and the problems associated with withdrawal would also be there. Any specific opioid which you want? Because there are multiple opioids.
Use fentanyl, and that is more potent, less of side effects than morphine, and its half-life is also longer.
Probably all of us are using fentanyl as the primary opioid of choice in our ICUs. Now, Shananda, any other agent used for pain management?
Yes, so while opioids are very potent and first line, but they have significant side effects also. So we don't want much opioid to be given to the child, especially if the child is a long stay patient and requires analgesia for a long time. So other than non-steroidal anti-inflammatory agents like diclofenac, we can use paracetamol, acetaminophen, the usual, IV or oral. That can be used as an additive to the opioids and also to reduce the opioid requirements. Second, in case of a neonate or a younger infant, we can swaddle them and give them a dummy with sucrose, and that is quite helpful before the invasive procedure in a conscious child.
Especially not only neonates, it's basically infants. Small infants can also be tried with non-nutritive sucking and oral sucrose, because the recommendations have come related to those. Some things which are there which we use age-old wise, but probably are not into that much of vogue. Again, music therapy, as Dr. Vonashi mentioned. Music therapy is one of the therapies which is very important and should be promoted in our PICUs. I think none of our PICUs have music systems. Some have probably, but majority of us don't have, which is something should be initiated. What about propofol? Would you advocate the advantages, or are we concerned about propofol infusion syndrome, so no propofol at all?
That is the concern, but propofol is a very good sedative agent, and what the recommendation says that if we follow the dose and if we can keep it within 48 hours, then there is less risk.
Right, a lower end dose, less than 4 milligram per kg per hour, and used for less than 48 hours is what is recommended. Ketamine, a good agent.
So coming to ketamine, it's an unique agent in terms of it has all three properties that is ideal for a PICU sedative analgesic. So it is, it causes analgesia, sedation, and also it is an amnesic as well. So it acts on the NMDA receptor and also short acting. So once IV injection, it starts action by a few seconds, and termination of action once one dose is over, it's like within 20 to 30 minutes. And child fully gets awake by 1 hour. So it's very useful for all procedural sedation, but one thing is it causes excessive secretions, respiratory secretion, and especially in older children, while the child is coming out of the sedation, it can cause delirium, which is the emergence reaction. And so we have to be a little bit cautious while using it in older children. And it is a good, it causes catecholamine release. So children who are in shock, when we are trying to intubate them, we can use it. And it is also a potent bronchodilator. So in case of aero intervention in a asthmatic child, we can use it.
Very well said. There are advantages, there are disadvantages associated with ketamine. Specifically, you can use it with asthma, and it has a wonder drug, because when majority of your agents are not being effective for asthma, you can use ketamine, and it causes very, very good bronchodilation. But emergence delirium, you may feel that when the child is coming out of the sedation, the child is abusing you. You are thinking probably the child has gone into hepatic NKF. No, it's not that. It can cause emergence delirium. So better to use it with a benzodiazepine. So always remember, better to use it with a benzodiazepine. So the recommendation also is to start using adjunct sedation with ketamine patients who are otherwise not achieving optimal sedation depth. Etomidate, Dr. Vonashi, have you used it?
Personally, no, I have not used it, but we know that etomidate is a sedative hypnotic, quick onset, quick offset, and cardio-stable, just like ketamine, and is usually used as an induction agent for intubation in shock patients. However, we have to be extremely cautious about using etomidate as an induction agent, because it has been shown that even a single dose of etomidate can cause adrenal suppression, which can be transient or can be prolonged.
So what are the issues with conventional sedatives which we use routinely in our ICUs?
Right. So conventional sedatives like midazolam, you know that short-term effects, like they do cause hypotension, they do cause respiratory depression, and on a long-term basis they can cause dependence, tolerance, and delirium, as well as like iatrogenic withdrawal syndromes.
I think all of us as intensivists have used midazolam a lot, and I don't think respiratory depression or severe hypertension happens at the low doses. It just happens when you go quite high up on the doses, especially the doses which you are using for status epilepticus. So it is relatively a safe drug, but it has got its own problems with tolerance and lack of orientation, and cooperation can happen with midazolam. That is why newer agents, if there are any, let's see, we'll discuss, if there are new agents or wonder kids on the block, are there any which we can use?
Yes, that is dexmedetomidine. It's a centrally acting alpha agonist and a sympatholytic agent which has both sedative and analgesic effect, and it has less influence on the blood pressures and heart rate. It acts on the alpha agonist receptors both in the brain, spinal cord, and the peripheries. Acting in the brain, it causes sedation, anxiolysis. So acting at the spinal cord, it causes analgesia. Acting at the peripheries, it causes vasoconstriction. So it is devoid of much side effects, and it is recommended now for post-op, recommended drug for post-op cardiac patients where we are expecting early extubation. It doesn't affect the
very importantly, it does not affect the respiratory drive
even
much.
In non-intubated patients, we can use it safely.
Right.
Even in
So
a difficult bronchiolitis, etc.
It can be used as an agent where you want to use that agent for sedation, and it is specially useful for weaning as well, because that is one agent which will make the child alert and calm, especially the stage 0 of the Richmond scale, where or the RAS scale, where we can interact with an older child and ask him about his comforts and discomforts. So dexmedetomidine is one of the agents which can be used in that purpose. And recommendations, now the recommendations have come from the pandemic guidelines, is to use dexmedetomidine, especially as Dr. Momita said, especially in the pediatric post-operative cardiac surgical patients with expected early extubation. So other post-operative patients also, dexmedetomidine can be used, and it is an alpha agonist working on multiple areas, can cause both analgesia as well as sedation.
Actually, some centers use clonidine infusion also, and
Right.
which is the same mechanism of action.
Right. But dexmedetomidine is much safer, as clonidine may be used for withdrawal, and dexmedetomidine can also be used as an agent which is used for opiate withdrawal as well. So Dr. Nandini, what would be the perfect combination for the perfect balance of sedation, analgesia, whatever you want?
We need to balance with sedation and analgesia. So the best combination will be an opioid with a hypnotic agent. So as we prefer, start with fentanyl infusion and with a midazolam or propofol infusion.
But be careful, don't use the propofol for more than 48
Yeah.
hours.
So we have to keep that in mind.
So basically we want agents which will act both on your analgesia and cause analgesia, as well as have amnesia, hypnosis and anxiolysis. So primarily we can use alpha-2 agonists, as dexmedetomidine has been one of the wonder drugs which is devoid of too much of side effects, and adjunct sedation may be given with either propofol, or if you want you can give adjunct sedation with midazolam or a ketamine, and you can add adjunct analgesia if required with your opioids such as fentanyl. So using alpha agonists as the primary agent, you can titrate around your sedation or analgesia with agents like ketamine, propofol or fentanyl, depending on what you want. Now let us come to neuromuscular blockers. We all are using neuromuscular blockers in the PICU left, right and center. But what are the actual indications of neuromuscular blockers in the PICU, and what are the recommendations related to that?
So routinely we use neuromuscular blockers to facilitate intubation, and in those already on mechanical ventilation, depending on the situation or depending on the clinical condition, they have been used in situation whenever there is an increased asynchrony between the ventilator and the patients. They've been used in ARDS and in neuroprotection as well. And rarely they have also been used in situations like tetanus to reduce the muscle spasm, as well as in neuroleptic malignant syndrome as well. As far as the recommendations are concerned, as per the pandemic guideline, the lowest dose of neuromuscular blockade should be used to achieve an optimal paralysis. And to know whether a patient is optimally paralyzed, they have recommended the use of the train of 4. And then it is also.
We'll come to the train of 4. Prior to that, let's go to the dysynchrony part. Many a times, any patient who is having asynchrony on the ventilator, a resident or a fellow first goes and gives your neuromuscular blocker. This is something which should be avoided, because you have to find out the cause for dysynchrony. It may be that the child requires more analgesia. The child's level of sedation is probably not that much. So just if your child is having asynchrony or dysynchrony on the ventilator, don't just go and give your dose of atracurium or rocuronium. Wait, assess, see what is happening, and then give your dose. So, but always remember, very important, this does not have any analgesia or sedation properties. So whenever you're using, use it in good conjunction with your analgesic and sedative, because you should not be using it without the ability to establish a definitive airway. So if administering for prolonged periods, then objective monitoring system, as Dr. Vanashi was saying, to assess the degree of paralysis. So you were saying about the train of 4. So what are the recommendations about the train of 4?
That is to optimally to find out whether the patient is optimally paralyzed. They have this pandemic guideline has suggested this train of 4. It's basically an electrical stimulation of a peripheral nerve, and to find out the number of muscle twitches. So the recommendation is about 1 to 2 twitches, which is an optimal paralysis.
Any neuromuscular blockers, Dr. Shananda, which you are regularly using? Just a couple of words on each of them, the benefits, advantages, disadvantages.
Yeah. So the in the rapid sequence intubation, traditionally succinylcholine had been used, but in the PICU, we don't use it in children due to the adverse effects. So we use short-acting rocuronium or atracuronium if we are suspecting any metabolic problem in the child. So this is a zero-order elimination, do not require kidney or the liver to get eliminated from the body. So if we don't know the metabolic status of the child, I think using atracurium is safe. Otherwise, we use rocuronium. We can use vecuronium as well. And sometimes we, when we are neuroprotecting or we want to reduce the metabolic demand of the child and want to keep them paralyzed with infusion, then I think something a little bit longer acting vecuronium infusion will be better. But while using paralysis infusions, we have to be a little careful because in research it has been associated with development of more neuromyopathy. And obviously we need to do the train of 4. Like when our child is on paralysis infusion, we have to do the train of 4 every morning with the beginning of shift. And if the twitches are very much reduced, like in the last column, 0 twitches, then our child probably needs a paralysis holiday for some time.
Right. So you classify it as per the train of 4 depending on how many twitches are there. You give 4 twitches and see how many twitches are happening. So if there are 4 twitches, that means less than 75% of your receptors are blocked. So you probably need to elevate the level of your neuromuscular blockage. And if it's no twitches, or that means it's 100% is blocked, that means you need to come down. So you have to titrate this with a train of 4, which should be used probably in all our pediatric ICUs to assess the level of neuromuscular blockage. Few words on pediatric delirium, Dr. Shananda.
Pediatric delirium as well, when the child is recovering, especially if the child is long stay, an older child who has more awareness of the environment. So it is a known phenomena, and as per the pandemic guideline, it is recommended to assess pediatric delirium daily. So if the child is not much depressed as per the agitation or RAS score, if it is more than -4, then we assess the delirium. So this is a Cornell score for delirium assessment, and I think it is recommended to do.
I think we should be using these scores as well, because this Cornell score is something which we probably usually do not use. We do not assess delirium, but assessing delirium is also very important, and this is the score, especially when the child is not very significantly depressed. You can assess this score and assess the score and treat accordingly. Now we'll come to the very last part, how to optimize PICU environment and offer early mobility. Now once the child has recovered, we all want the child to go home early. For that you require some things which include early mobility and optimization of the PICU environment. What are the things which we can actually do for doing those things?
We can involve the parents, mostly mothers or even fathers, in the daily care. During minor procedures, they also get confidence in the physician about the management. Then we can reduce the background noise, silence the alarms, correct them, and maybe do some music therapy, use headphones. Then ambient light, at least simulate the night time, reduce the brightness of light during the night shifts, and make every procedure in the PICU, it should be like a routine, so that they know. The children get used to that routine. And also early mobility based on the illness he is having. If he has contractures, etc., maybe we can involve the physical medicine also, make an individualized protocol for early mobility. It will also prevent DVTs and also prevent delirium, which we see in PICU children.
So very important, one thing which all of us don't do is, whenever the monitor rings, we go and stop the monitor alarm. The sound which comes from the monitor is one of the most irritating sounds which keeps on happening, and even we see many children who, even after having improved, complain that they are hearing the alarms ringing in their ears. So this is something which should be taken care of. Again, as Dr. Momita said, very important is early mobilization, and there should be protocols for that, especially for mobilizing such a child, because involving the interdisciplinary team and early mobilization for early hospital discharge, and which will reduce our hospital burden as well as the cost burden on the child. So at the end of the session, we would go through a few take-home points, and I think these are very important points which all of us should take home at the end of today's talk. sedation, analgesia, and paralytics are not just a treatment, it is just an adjunct therapy. So give it importance. It may not be as important as your antibiotics, but these are also important. Never use paralytics without sedation and analgesia, as we discussed, because they do not have any analgesic or sedative effects. Same way, never use sedation without analgesia. Don't just say that the child is sedated, he's not having pain. No, child is maybe sedated, but you should always assess the pain as well, because that is something which will may cause a problem later on, especially may cause a post-traumatic stress disorder as well. What is the ideal combination? As from what we have discussed, probably dexmedetomidine with propofol and cisatracurium is the ideal combo, but you have to change, or you may require to change it from situation to situation. Etomidate or ketamine, maybe succinylcholine or rocuronium for shock patients. Very important, label the infusion pumps about the medicines, the dosage, the preparations, and more important is following the standard scores. From now on, if we have learned one thing, is following a few scores, especially the sedation score, and try to follow it in our ICUs for our regular practice. And ensure monitoring for delirium and promotion of early mobility for all PICU patients. So thank you for remaining sedated and not asking questions. Now you can ask questions at the end of the session. I think there are a couple of minutes. If any questions, I think if Sir allows us, if there are any questions.
Any questions from the audience? I think there is no question, all are sedated.
I think they were sedated. So I think,
so I wish to thank Dr. Poddar for nicely conducting the session and all the panelists. And I think it will be beneficial for the residents who are working in PICU setup. Thank you all.
Thank you, sir. Thank you.
Thank you, sir. I request Vishek, sir, and all the panelists to please collect your, and the chairperson, sir, to please collect your mementos from the felicitation area.
Thank you.
Thank you. So we have the next talk on brain autoregulation, bedside determinants and its applications. For this, I would like to invite our chairperson, Dr. Arijit Chattopadhyay. He is a consultant, senior consultant pediatric neurologist in Apollo Multispecialty Hospital. And Dr. Dhiren Gupta.
Thank you. Good morning, everyone. For those coming from outside, welcome to Kolkata. I would like to thank the organizers for giving me the chance of becoming the chairperson. We have a very interesting talk coming up on brain autoregulation, bedside determinants and application by no other than Dr. Dhiren Gupta. He is a consultant pediatrician and intensivist at Gangaram Hospital. He has many major achievements, as you can see. Over to Dr. Dhiren.
Thank you, sir, and good morning, friends. You know, this topic, when we talk about brain, till now we used to talk about cerebral perfusion pressure, intracranial monitoring. Later on, over the years, we shifted to, transcranial Doppler, optic nerve sheath diameter, like a non-invasive methods. Following that, what we have found, what science have found, that those patients who have got poor autoregulation, the outcome is very poor as compared to patient just having intracranial monitoring. So when Mihir asked me that what topic you would like to choose, I just told him that, okay, I want to do brain autoregulation. Till that time, even I never thought of what actually this topic is containing. Actually, if you ask me past 15 days, it is going to be a tough topic even to understand, right? There are many terminology to start with, which will help us in understanding this topic. We all know that mean arterial pressure, that is the blood pressure, right? That goes into the brain. And if your brain pressure is high, then your venous pressure, then we call it cerebral perfusion pressure. That is a MAP minus ICP. Then comes the blood flow. I used to get confused by all these terminologies. So my presentation will be a little bit slow, and I try to simplify each and every topic. Blood flow is like a blood flow, the amount of blood, the volume of blood which is reaching the brain. It is calculated like a 50 ml per 100 gram of per minute means of the brain. So something like 1 ml for 2 gram. It varies from gray matter to white matter. 80% goes to the gray matter and 20% goes to the white matter. Now comes the complicated things, which we calculated by Doppler method. That is your blood flow velocity. Blood flow velocity is actually the speed of the blood which reaches the brain. So we cannot calculate blood flow, but we can calculate blood flow velocity. We'll talk about. Then comes the blood flow volume, the actual volume which reaches the brain. That matters a lot, because slight change in volume can lead to increased ICP. Even 5 ml of blood, if in excess reaches in a brain where ICP is already high, it can cause problem. So this is known as cerebral hemodynamics. The study of all these things is known as cerebral hemodynamics. It is an adaptation of the cerebral blood flow to the metabolic demand, right? So what it has got, can I have a pointer? That green one. So it has got 3 components. One component is neurovascular coupling. It is like an adaptation. So if I am viewing some structure and my occipital lobe becomes more activated, so occipital lobe will get good blood supply. This is known as neurovascular coupling, right? Then comes cerebral autoregulation. This is all presentation about. It is the pressure change. Whenever pressure change which is going to happen in the vasculature system, and to adapt that pressure, that is low or high, to provide constant blood flow and volume to the brain is known as cerebral autoregulation. It is different from cerebral vasomotor reactivity. It is a reaction to carbon dioxide and oxygen change. So these two are different, but it overlaps. Both things overlap each other, right? So this is cerebral autoregulation. This is vasomotor reactivity to the pH and carbon dioxide. So brain tissue wants oxygen, right? So vasomotor reactivity is to provide that oxygen by constant blood flow, that is by cerebral autoregulation, and this cerebral autoregulation is compartmentalized by your neurovascular coupling. So these are 3 different things which happens in the brain, and we are going to talk about these 2, that cerebral autoregulation and reactivity. So we all know that brain autoregulation is a stable blood flow despite of varying mean arterial pressure. So we are going to talk about physiological basis, autoregulation determination, and some clinical application, right? So these are the things which we are going to talk about. We all know that mean arterial pressure between 50 to 170. What happens? Despite of so much variation, the constant blood supply, constant blood flow is maintained by vasoconstriction and vasodilatation. This is very known diagram. We all know that. This is your cerebral blood flow, this is mean arterial pressure, and this is cerebral blood volume. Look at 50 to 150, the mean arterial pressure is changing, and as you go lower down to the map, the vasodilatation happens. As you go above, then vasoconstriction happens, so that your cerebral blood flow remains constant. That is the basis of all the presentation of this presentation. How it works? There can be 3 mechanisms. It can be neurogenic, it can be metabolic that acts through vasoactive, it can be myogenic, and it's a complicated thing. And actually it happens at the arterial level, like preconstrictor level, not at the middle cerebral artery level. So there is an increase or decrease in the cerebrovascular resistance, and this leads to constant blood-brain supply. That is, the volume of blood remains constant despite your pressure vary from 50 to 150. Regarding cerebral vascular activity, this is an ability of the brain to change its character as per the metabolic demand. What those are metabolic demand can be carbon dioxide, can be PaO2, can be glucose or hematocrit. So what happens whenever there is a carbon dioxide change? Look at here. We have added this red one is a carbon dioxide. So 40 is the carbon dioxide like here, where your blood flow is constant, mean arterial pressure is constant, your blood flow is constant. But if it increases, there is a vasodilatation and the supply, the flow increases, it decreases. So as per the carbon dioxide reactivity, the brain adapts. If a carbon dioxide decreases, it leads to vasoconstriction, it decreases the blood flow, and this way we do hyperventilation and try to reduce the ICP that we know for so many years. So what are the methods to determine these two things? What we are going to talk about? Autoregulation and vasoreaction. Vasoreaction, if you increase or decrease the carbon dioxide, or you increase or decrease the mean arterial pressure and you measure the cerebral blood flow. So what is the key point in this presentation? How to measure the cerebral blood flow changing with the change in the carbon dioxide, change in the mean arterial pressure, right? So our presentation, the main aim is going to how to measure the cerebral blood flow. What are the determinants of cerebral blood flow? There are so many determinants, like there can be intravascular, like nitric oxide inhalation, nuclear medicine, CT scan, MRI, thermodilution diffusion method. But what we are going to talk about, two methods. If time permit, I will talk about NIRS, which we know that, but today we are going to talk about transcranial Doppler as a measurement of cerebral blood flow. And we are going to change the carbon dioxide and mean arterial pressure, and we'll look at what is happening inside the brain, how the blood flow is regulated. So basis is, if my mean arterial pressure changes, nothing should happen to the cerebral blood flow. Even it happens, brain should recover. That is the basis of the whole presentation, right? Everybody understood? This is a little bit complicated things, but I'll try to simplify. Something about transcranial Doppler. What we know that there is a transtemporal window. Here is a transtemporal window on the right side or the left side. That is the thinnest bone just above the zygomatic arch. You keep probe there and you try to form a window. In a window, you start with a butterfly. This is a butterfly you will be able to visualize. So this butterfly actually is the midbrain. Okay, this is the midbrain, is the thalamus, which you will be able to visualize. So your arch will be lying around this, in front of this. Circle of Willis will be lying in anterior to this, right? So this is the understanding. So this is, you can see, this is your midbrain and it present as a butterfly. In front of it, you may find a third ventricle. This is an overlapping of beautiful circle of Willis, right? So your middle cerebral artery, this is a middle cerebral artery, this is anterior cerebral artery, posterior cerebral artery, and you move your probe, you can formulate. So for today's presentation, we are only going to focus on the middle cerebral artery because that is the best artery. It doesn't changes with lot of vasoconstriction and vasodilatation. Only 2% change happens. So this is a good artery where we are going to determine what is happening to the flow velocity. And by flow velocity, we are going to determine the flow, actual blood flow. So these two are different things. There are a lot of measurements. For today's presentation, we are going to talk about mean blood flow velocity. Mean blood flow velocity, that and diastolic volume, everything is done by machine. So I'm not going to go into the detail how to calculate all these things. As I told you, what we want is a cerebral blood volume. Surrogate of that, we want to know your flow velocity, right? So because that is the only thing we calculate. So flow velocity is different from the blood flow. For an example, there is an artery where the blood is flowing. If that artery constrict, what will happen to the velocity? That will increase. Your volume may be low, but your velocity will increase. So that's why what we say that these two are related with the blood vessel diameter. Fortunately, your middle cerebral artery doesn't constrict that much. That's why we are taking as a surrogate marker of flow velocity to the blood flow. And blood flow is a surrogate marker for flow volume. Okay, these are three different issues. And what were our basic aim? If you change mean arterial pressure, nothing should happen to all these three things because of your auto-regulation. If something happens or something doesn't recover within few stipulated time, it means auto-regulation is disturbed. So I am repeating this statement which will help at a bedside. So we'll start with the measurements. To start with, we are going to check cerebrovascular reactivity to the carbon dioxide. It means we are going to employ either increasing carbon dioxide or decreasing carbon dioxide, and we look at what is happening to the blood flow. Okay? So this is known as breath holding index. I won't go to the actual number. Here what you do, you calculate the cerebral blood flow velocity for 1 minute before you do any procedure. Then you create an apnea of 30 seconds. Sometimes ventilator setting has to be changed because it goes into the apnea ventilator settings. So I am talking about ICU patients who have been intubated with increased ICP. Most of the time they are intubated. So what you do, you calculate how much flow has changed from the baseline. So what we expect? We expect if your carbon dioxide get retained, the flow should increase. So again, there is a calculation. So it all depends on how much carbon dioxide has been retained. Or you can do hyperventilation apnea test. You 30 seconds you hyperventilate, followed by you land up in apnea, and look at what changes has happened to the flow. Generally, it is around 2 to 5% change in the flow velocity per millimeter of CO2 change. So it is general accepted for any age group, right? If your brain is not reacting to decrease or increase in carbon dioxide, it means cerebrovascular reactivity is disturbed. Sometimes it can happen in traumatic brain injury that implies very poor outcome. Now we talk about cerebral autoregulation. So that was vasoreactivity, right? That is different from autoregulation, though interlinked, there is a lot of overlapping is there. So when we talk about cerebral autoregulation, always remember we are going to assess the flow velocity secondary to changes in cerebral perfusion pressure. Here we are talking about pressure change, not the carbon dioxide change. Okay, so pressure change can be induced in a given patient. How it is induced? The most common method is leg cuff deflation method. What you do, you inflate the legs by applying a lot of cuff, and you suddenly deflate it. So sudden deflation will lead to hypotension. Okay, for that hypotension, your baroreceptor will take time, around 10 seconds, to again normalize the blood pressure. So what will happen? There will be change in the arterial blood pressure. So minimum change required, induced change should be 5 millimeter. So it will take 5 to 10 seconds for the body to respond, and in those 5 to 10 seconds, you calculate the TCD, mean velocity flow. Okay, what will happen? There is a drop, both will drop, but your TCD flow will come to normal earlier than your blood pressure comes to normal. If that is not happening, it means there is a fallacy. If that is not happening, it means if your flow velocity is taking time and passively along with the flow, the mean arterial pressure, it means the auto-regulation is impaired, right? Understood? We all know that these are, person to person variation is there when we talk about ultrasonographic variables. So that is applicable to this one also. But fortunately, this method is applicable to all the ages, though method is cumbersome because you have to bring both things into one page. What is happening to blood pressure and what is happening to your mean flow velocity on the TCD monitoring system, right? Now comes a little bit better, which I have used in some of the patients, that is transient hyperemic response test. What here you do, as I told you, you try to reduce the mean arterial pressure in the brain, right? So instead of just reducing the blood pressure or increasing the blood pressure, you just compress your ipsilateral common carotid artery for 3 to 10 seconds, right? There will be sudden reduction. Look at the flow velocity. This is the TCD. The flow velocity was normal, F1, F2. Now F2 is reduced because you have compressed the ipsilateral common carotid artery. Now it is reduced, it is taking time. And what is happening? Suddenly there is a jump in the flow velocity if your autoregulation is okay. If your autoregulation is maintained, then your F3 will be higher than your F1. So what is happening? Around 30% response, if it is, you find that you have compressed it, there is a reduction, but post that there is a 30% higher flow velocity than the pre-one. It means your autoregulation is maintained. This is better practical method. Again, the beauty of this method is it is easily reproducible, simple, and lack of pharmaceutical. You don't need to push in epinephrine or norepinephrine in this type of patient. Again, in elderly, if there is a atheroma is there, that can get fractured and that can lead to problem. Otherwise, in pediatric age group, this method is doable and much more simpler than any other method. Because you can actually, it's around 30 seconds or 1 minute, you can keep your probe steadily for that time. That is the usual, I can say maximum time you can keep your probe steady there and you can measure it. So friends, it is a complicated structure. It is a complicated topic, autoregulation. And frankly speaking, I repent after committing that I am going to present this topic. It was tough and I tried to simplify as much as possible. And it is an upcoming tool. Now NIRS is coming in a beautiful way. What people say, there are two types of NIRS, qualitative and quantitative. What we have got is a qualitative NIRS. So if you use NIRS, we use NIRS very commonly in most of the patients. And if you find that your blood pressure is dropping in this patient, or CPP is reducing, or ICP is increasing, but there is no change in the NIRS, it means this patient is having good autoregulation, right? So from bedside point of view, I still feel that NIRS is a good modality. Lack of time, I didn't present it. So, but we need more information. We need more application. And this is an upcoming thing. People are trying to use more TCDs, and in this conference also I found two POCUS workshops. That is an amazing thing. Again, when we talk about autoregulation, there are many other factors which can affect. So if you are going to do procedure in a given patient, try to see that carbon dioxide should not change during that time. Or you should not give some bolus of some vasoactive or vasoreactive drug, right? So your reactivity will come into play. And if you give some bolus, there may be vasoconstriction of middle cerebral artery, and you may get falsely high increase in velocity. So friends, technology is evolving. I hope you have understood what is the concept of autoregulation, and if that is done, thank you very much.
Thank you, Dr. Dhiren, for trying to simplify a very complex topic of cerebral autoregulation. So I don't think we have any time. With this, I would like to hand you back to the organizers. Thank you very much.
Yeah.
Okay, one question.
If
allowed.
Somebody is there to
yes,
ask
I can
question.
See somebody raising their hand.
It's so complicated. Yes.
Can you give the mic, please, so that
Sorry?
everybody can hear?
Hi, sir. In case of dynamic cerebral autoregulation, why are we doing it in the leg curve? Why not the brachial curve, like the?
Because the blood volume there is significant, and so that can induce the change in mean arterial pressure. The brachial one doesn't have that much uncompressed volume or unstressed volume. Maximum unstressed volume is in the abdomen. You cannot compress that. So short of that, you have got in the lower extremities. So this is dynamic autoregulation test. I didn't talk about the static one because static used to be done pre-era, means pre-TCD era. So that those are a little bit more complicated. So all these are dynamic autoregulation tests.
With that, we come to the end of this session. Thank you very much.
Thank you, sir. I would request Arijit sir and Dhiren sir to please collect your mementos from the felicitation area.
Okay.
So we have the next panel discussion on pediatric ARDS paths, do's and don'ts based on PALIC 2. For this, I would like to invite our chairperson for the session, Dr. Subroto Chakravarti, who is the consultant pediatrician in Manipal Hospital, Salt Lake City. And moderator for the session, Dr. Shaumen Muir. Panelists for the session, Dr. Shatarupa Mukherjee, Dr. Rupa Biswas, Dr. Mukesh Kumar Jain, Dr. Niladri Shekhar Bhuiya, Yes. Yes, sir. Kindly introduce the moderator. Yes.
Good morning, everyone. This is going to be a great session on pediatric ARDS. It's a very important issue. Often, say, we face in day-to-day pediatric practice, and you're also in intensive care. So we have to be aware of it. And we have now a very dedicated intensivist, Dr. Shaumen Muir. He is also my personal friend. His present designation is Senior Consultant Pediatric Intensivist, and he is attached to Manipal Hospital, Mukundapur. And there are many publications on intensive care Shaumen has done. So Shaumen, please proceed with your session.
Thank you, sir, for the very kind introduction. I would like to introduce my faculties. Slide আছে Okay, Dr. Shatarupa Mukherjee is a pediatric intensivist currently working in Birla Heart Research Center, and she has got interest in pediatric cardiac intensive care. Next one. This is Dr. Rupa Biswas, who has been doing pediatric intensive care for quite some time. She's currently attached with the Kolkata National Medical College, and she also has got expertise in radiology. Dr. Mukesh Kumar Jain is assistant professor in the Department of Pediatrics in KIMS University in Bhubaneswar, and he has been doing pediatric intensive care for quite some time. And Dr. Niladri Shekhar Bhuiya is the associate professor and PICU in charge in AIMS Kalyani, and he has done MD Pediatrics and IDPCCM from CMC Vellore. Welcome to you all. Let's start. So, acute respiratory distress syndrome name goes back to 1987 in this landmark paper by David Ashbach, which was titled Acute Respiratory Distress in Adults. This was based on just 12 patients, 5 of them were actually children. So though it's called acute respiratory distress syndrome in adults, almost half of the patients are actually children. And it is interesting to notice that he is actually an assistant professor in surgery, nothing to do with intensive care. So he came up with the idea. So this is a clinical syndrome characterized by diffuse inflammation of the lung, results in significant hypoxemia, which is the hallmark of ARDS, and which is due to endothelial injury to the pulmonary vasculature and alveolar epithelial injury as well. And there is no definitive test or biomarker. It is a diagnosis based on oxygenation difficulty, basically. We'll discuss that in a second. So this is the timeline. Ashbach first described the condition in 1967, then there was an American European Consensus Conference in 1994, and then there was Berlin in 2012. And the first pediatric definition, pediatric separate guidance came in 2015, and it has been updated last year. So why did it need updating? There is constant change in our understanding of the pathobiology of the ARDS and lung protection strategies. New technologies are available. They have come up with the section on resource limited settings because pediatric intensive care is spreading all around the world, and we consider ourselves relatively resource limited as well. Supportive therapies are coming up. Implementation of 2015 PALIC recommendation varies among the PIs. We'll talk about this study at the end if we have time. And what's surprising is that even after the dedicated pediatric definition and guidance came up in 2015, the mortality from pediatric ARDS has not come down, and non-adherence to the recommendation is considered one of the reasons. So that's another reason of updating. So we'll start with Dr. Shatarupa about the pathobiology of ARDS briefly.
So the pathobiology of ARDS is endothelial damage to the pulmonary vasculature, as well as alveolar capillary damage to the alveolar capillaries. And so it causes fluid leakage of proteinaceous material, inflammatory cytokines, and the alveoli are filled with fluid. This causes functional surfactant loss, and finally leading to impaired gas exchange, VQ mismatch, reduced lung compliance, and pulmonary hypertension. So the emerging concept of pathobiology in ARDS is the one which is called as the ventilator-induced lung injury, which is the damage caused to the lungs by the ventilator. So, and also there is something called self-inflicted lung injury, when we allow a patient to breathe with a patient with ARDS to self-ventilate. And so these are the new emerging concepts, and the damage done to the lung by the mechanical ventilator, which is determined by the mechanical power, the shear stress and strain that the lung undergoes during the pathophysiological, during the process of ARDS.
Okay, thank you. So essentially the basic problem as we understand it now is that it is the increased permeability of the epithelial membrane and the endothelial layer, which is causing fluid accumulation. So one of the other ways of describing it is non-cardiogenic pulmonary edema, isn't it? That's what it's called as well, though that's not entirely true, but that's one way of trying to understand ARDS. Okay. So we use quite a few indices to measure the severity of ARDS, and I'll just ask Dr. Rupa to explain those. I understand there are quite a few junior doctors, PGTs here, so these terminology can be a bit confusing. So Rupa, could you please go through that?
Thank you, Shivanda. The two most important indices we are used in daily for daily purpose: the oxygenation index and the oxygen saturation index. The oxygenation index is calculated by the map into FiO2 divided by PO2, and the oxygenation saturation index is there. Instead of PO2, we use SpO2. And another two ratio, that is PF ratio, that is PO2 divided by FiO2 ratio, and the SF ratio, that is SpO2 by FiO2 ratio. And in case of calculating the oxygenation index and OSI index, we use FiO2 in the decimal, and in case of PF ratio and SF ratio, we use FiO2 in the percentage. And the PO2 value should be taken in the millimeter of mercury, and the SpO2 in the percentage. All these four indices are used for risk stratification.
Yeah, so adult intensivists almost exclusively use PF ratio for all the definitions and severity scoring. We think oxygenation index is better, but sometimes we don't have arterial line for logistic reasons, sometimes for non-availability of resources. So we may only have saturation rather than SpO2 rather than SaO2. So those two indices came up, the oxygen saturation index and SF ratio. And just to keep life interesting, we have also made some in percentage and some in decimal points. I don't know whose idea that was. So we'll come to the diagnosis and risk stratification. Dr. Mukesh.
So, like the diagnosis of ARDS is actually changing very fast. Actually, from 1967 to 2023, now this PELIC 2 have some importance change actually from PELIC 1. So, if we come to the criteria, the age, timing, origin of edema is almost same. Like we'll take the patients less than 18 years, we don't have any perinatal diseases. Timing account, all the insults should be within 7 days. So if there is hypoxemia or any radiological changes, that should be within, insults should be within 7 days of onset. And the origin of edema is non-cardiogenic. So these 3 points are almost same. In imaging, there is small change in imaging criteria. So new opacity, either it is unilateral or bilateral. Initial, if you go to the old guideline, it is bilateral thing is there, but now it may be unilateral or bilateral, and there should not be like any atelectasis or pleural effusion. It should not be there. Coming to the oxygenation criteria, so here there is a addition of NIV. So if the patient is on invasive mechanical intervention, the OI is more important as compared to our PF or SF ratio and OSI, more than 4, more than 5. Coming to the stratification, so in stratification, initially there is 3 groups, mild, moderate and severe. But here there is 2 groups only. One is mild and moderate group and another is severe group. So according to, you have to classify OI less than 16 or more than 16 and OSI less than 12 or more than 12. So according to, you have to differentiate mild, moderate and severe. So on patient on NIV, so the patient on NIV like a full mask, either CPAP or BiPAP, in that condition you have to go for NIV stratifications, and here you are using PF ratio or SF ratio, less than 100 and more than equal to 100. Less than 100 it is mild to moderate, more than 100 is severe. And coming to the special population, like initially what we know that these heart disease patients and chronic lung disease patients are not categorized in the ARDS. But now we can categorize them in ARDS if there is an acute deterioration which is not due to the primary disease. A patient, a known case of heart disease, we are not taking into consideration a diagnosis of ARDS. But now we can take consideration into ARDS if there is an acute deterioration in the hypoxemia and imaging finding which is not explained by the primary disease. And next, so there is another like possible ARDS. This is a new concept again, possible ARDS and at-risk ARDS. This is a new change in PELIC 2. Here everything is same, but only criteria is, oxygenation criteria is changed here. So if a patient is on nasal prong, nasal CPAP or HFNC, these patients are considered under possible ARDS. So there is a difference in NIV and this criteria. If NIV there is a full face mask or full CPAP, full face mask CPAP or BiPAP, that is coming under ARDS. But if the patient is on nasal CPAP or HFNC, these are categorized under possible ARDS. And if the patient require oxygen and the saturation is more than 88% but not meeting any criteria, then it is common at-risk criteria. Now this is only change in the possible ARDS and at-risk ARDS addition to PELIC 1. So what to do and what not to do is given in PELIC 2 criteria. So all age less than 18 years, that is clear. So that should be added in the criteria without any perinatal lung disease. The hypoxemia and radiographic changes should be within 7 days. Imaging findings, so there is addition in imaging findings. Suppose a patient is in peripheral setup or research limited setting where all the criteria are met with ARDS criteria, but they are not able to go for an imaging finding. These are categories under the possible ARDS group. PF ratio, SF ratio can be used in NIV categories. And that's the next slide, please. about this what not to do. So if it is more than 7 days, we cannot categorize in ARDS. And oxygenation, yeah. When you choose SpO2, you are using SF criteria. The SpO2 should be measured in a stable condition, not like when there is a transient desaturation or patient unstable. At that time, we should not measure it. And this, the last one is, suppose there is a respiratory failure due to obstruction, airway obstruction like critical asthma or bronchospasm due to any other cause, that will not coming under PARDS group. Coming to the stratification, next slide. Yeah. So you can use OI or OSI in preference to PF or SF ratio. That is more better always, because we are considering MAP in this group. And at least 4 hours should be spent before categorization. This is a new addition. 4 hour, minimum 4 hours should be spent before you categorize the patient to mild, moderate and severe group. And patient with chronic lung disease. So chronic lung disease, cyanotic heart disease, there is no categorization for that. We can include them in the group of ARDS, but we cannot categorize them whether it is mild, moderate or severe. That's all I think.
Thank you, Dr. Mukesh. I think those of us who have gone through the PARDS guidelines from PALIC 2, these first 3 slides are the most boring slide one could ever make. I mean, it's just confusing and nothing comes out of it. So essentially, it is an oxygenation difficulty, and severity and risk stratification are based on oxygenation and oxygenation only for all practical purposes. So 4 and 5 are the number, OI of 4 or OSI of 5. More than these 2 numbers, we are going into the PARDS category. And then 16 or less is mild to moderate, and more than 16 is severe, is all I can remember, and I think that's the essence of it. And this is important, that the severe risk stratification needs to be done at least 4 hours after the patient has been diagnosed, not immediately. So now we will come to the management. The role of NIV in PARDS. Niladri.
Yeah, thank you, sir. So NIV, actually, if we think it is like have lot of potential, because we think lot of complications of mechanical ventilation can be abolished if we can use early NIV. But here in the new PALIC 2 guideline, they have classified the role of NIV into 2 categories, where we are using non-invasive mask type of thing, where this is like BiPAP mask or full face mask, and another one is what sir has already told, oxygen or HFNC. So oxygen or HFNC, where we should use, where the criteria, the saturation, whatever you are achieving, that is less than 88%, you are not able to achieve more than 88% with giving enough oxygen with NRM and all. In that situation, and you are seeing the patient is having worsening respiratory failure, respiratory distress is worsening. In that, you can give time limited trial. That time limited concept is very important, that you should remember that in case of severe ARDS, you should not wait for more than 1 hour. Mild, moderate, you can wait till 6 hours. That is very important. You should not wait for long. Sometimes it might give a false impression the patient is improving, but at the end the patient might tip up and land in crash intubation. You should not do that. And few things regarding do's and don'ts in NIV. First is obviously HFNC name itself has humidification. Humidification has to be given whether you give oxygen or HFNC. Next, NIV close monitoring is the important thing. Obviously patient, they can land up in intubation later, but you should not move away from that bed. You should monitor the patient very closely, and you should train your staff also. Then optimal interface, that is very important. Sometimes we see patient is hypoxic, patient is screaming, moving mask and all. In those situations, you should not attempt NIV. Calm down the child, counsel the child. Sometimes it's used by just putting the mask on yourself and show them that this is not like a very bad thing. Like that, you should counsel them before you put the mask. Next few important thing is look for the complications. One of the very common complication is the breakage of the skin, or the patient is having injury in the eyes. That should be taken care of. Addition of respiratory supports, we usually will go for the pressure control and pressure support mode, NIPPV mode. So pressure support will obviously support when the patient is having spontaneous breathing, and pressure control when the patient is not getting spontaneous one, that will be improved. And sedation. So sometimes nowadays mild sedation in the mode of dexmedetomidine. Sometimes they can use melatonin, some analgesics round the clock. These are all things which can improve your NIV outcome. It will improve the patient tolerance.
Thank you. We'll come to Shatrupa again about safe intubation practice. If the child needs intubation, NIV is not enough, or you think the child needs intubation straight away?
So the safe intubation practices are like we have to use a cuffed ET tube and maintain an unobstructed airway. So suctioning should be done with caution, because if we allow a long time for suctioning, we'll lose the PEEP and there will be de-recruitment and the alveoli will collapse. But is there any benefit for closed versus open suction? To avoid this, whether we go in for closed suction, actually there is no recommendation. And also, but we should consider the technique of suctioning. We should be fast and fast in doing suctioning. And also whether to put saline, which is almost done by many of us, whether there is really any indication for the saline during suctioning. It's not indicated until you want to do a bronchoalveolar lavage or you suspect thick secretions. And also whether there is any role of physiotherapy or mucolytics. No, there is no role of physiotherapy and mucolytics. One more thing is that children with such amount of hypoxia, we have to suspect something which is called a physiologically difficult airway. We have come across anatomical difficult airway where you can have different anatomical abnormalities which can lead to have a difficult intubation. But we have to remember that this child can land up in having a physiological difficult airway, that is, they can collapse during intubation. So we have to be very cautious. We have to stabilize them before we intubate. So what are the reasons why we are worried? Because they are hypoxic, they are acidotic, they can have hypoxia-induced myocardial dysfunction, and they can be pulmonary hypertension with RV dysfunction. So we pre-oxygenate them, we give them apneic oxygenation, and we have to have a senior person to intubate. We don't have much time to intubate. And we have to choose the pre-anesthetic medications properly. We can't give any vasodilating agents. We have to maintain sufficient preload. We have to give fluids. We have to start inotropes and then only go ahead and intubate. So stabilize before intubation.
Yes, thank you. I'll just come back to one of the points you mentioned about the closed suctioning. I think this idea that if you're using a closed suction, you don't re-recruit can't be true. Because when you are suctioning, even if in a closed system, you are creating a negative environment. Otherwise, there would be no suction. So whatever positive pressure you are providing would be gone for that period of time you will be suctioning. So you can't maintain recruitment for that period of time. So it may help you in the way of preventing VAP, because you are not putting new catheter every time. Shubhadeep doesn't agree. I don't agree that much either. But it doesn't prevent the recruitment, definitely not. It can't. Now we'll come to the ventilation bit. Rupa, what would be the ventilation strategy, and what's a mechanical ventilation bundle?
The most important ventilator strategy we all of know, that lung protective strategy, that is the only beneficial, and there is no preferable mode of the ventilation. You can use pressure control ventilation or volume control ventilation. One thing I have to mention, that is the PRVC should not be used in the severe ARDS because it causes the flow asynchrony, and sometimes the ventilator provides low flow when the patient needed actually the higher flow. And only one recommendation that is beneficial is low tidal volume, that is 5 to 7 ml per kg, and to keep the oxygenation less than, keep the PO2 at the range of 60 to 80 millimeter of mercury, and also keep the FiO2 less than 0.6. And it also, low tidal volume, it has been shown that it also reduces the stress and strain of the alveoli. And next, the optimal PEEP, that is to keep the FiO2 less than 0.6, and the maximum PEEP is required for the until patient is hemodynamically stable. We can raise the PEEP, but always keep in mind that the FiO2 should be less than 0.6, and PO2 is maintained at the range of 60 to 80 millimeter mercury, and the patient is hemodynamically stable. And the limit, previous slide please.
Sorry.
The P-plat, the plateau pressure should be less than 28 centimeter of mercury, and it is less than 32 if it is the lung compliance is very low. And we all of know the driving pressure that is measured by the plateau pressure minus P pressure, and it should be less than 15 or equivalent to 15. And the permissive hypercapnia to maintain the pH 7.2, because the PCO2 is blunted the effect of inflammatory cascade and the higher tidal volume, harmful effect of the higher tidal volume. And the recruitment maneuver, it will be discussed later in details. The recruitment maneuver no sustained recruitment maneuver should be used, and it is applied that it is recommended that the slow incremental and decremental PEEP should be in steps, in stepwise manner. Next, what are the don'ts of in ventilation bundle? That is to avoid SpO2 less than 88% in the severe ARDS and more than more than 97% in mild to moderate ARDS. And as already told, the FiO2 should be less than 0.6. And high PCO2, if avoid high PCO2 or permissive hypercapnia if there is raised ICT, severe pulmonary hypertension, hemodynamic instability, and the ventricular dysfunction. And no routine use of bicarbonate supplementation is required. And always, and as already told by Shatarupa, their uncuffed tube should not be used.
Thank you. Though generally they are good recommendation, I would say, but I don't understand this SpO2 of less than 88 can't be used, because if I go to my rescue therapy, which would be VV ECMO, my saturation would be in low 80s. So if that's acceptable, why not here? Why would I put the child on ECMO to have a lower saturation? I couldn't quite understand that. Before we go to ECMO, any role of HFOV in PARDS? Mukesh again.
So like as per this PALIC recommendation, there is no strong recommendation for HFO. Only they are telling that if your conventional ventilation fails, at that time you can use a rescue therapy. And whenever you are using HFO, you have to monitor all these you have to decrease the MAP or increase the MAPs serially, step by step, and you have to monitor this oxygenation and PaCO2 and hemodynamic parameters. Otherwise, there is no recommendation as per the PALIC 2 guideline for HFO. In adults, there are few studies in adults they have done for HFO in adults ARDS. So the two famous trials are there, OSCAR and OSCILLATE trial. As per this OSCAR trial, there is no benefit of HFO and conventional ventilation. They have done almost a good study, and they have calculated the mortality in both the groups, and they have found there is no significant difference, almost 41.7, 41.1%. So there is no significant effect. If you see the OSCILLATE trial, what they have found that in OSCILLATE trial, this group having HFO group having more mortality as compared to the normal conventional ventilations. So both the studies are done in adults, though there is no pediatric study in HFO till now, no RCTs. So I don't know actually whether it should be used or not, but in some centers as a rescue therapy, definitely HFO is used, and there is an opinion that it will be helpful.
This is the conundrum, isn't it? I'm sure there are intensivists in this room who believe in HFOV. Is there? Yes. Quite a few. Yes, almost all of them. But it's difficult to prove that it works. I mean, there is no study. One Indian study was terminated prematurely because the mortality in the treatment arm was too high. So why do you think that does not work when we go and do a study? But we all feel we have saved children from going to ECMO or from dying by putting them on high frequency oscillation. I have got a theory. I'm just going to share that theory. I think what happens when we put them on an HFOV with such a high MAP, we actually cause their cardiac output to fall significantly, and we don't often or always compensate for that with whatever, because we are not routinely monitoring cardiac output while we do these things. And if you are using a MAP of 28-30 and pressure never comes down below that for any significant length of time, you will compromise the RV filling significantly, and that may lead to significant reduction in systemic cardiac output, and may be the reason why so many complications are happening, but nobody has ever proved it. Maybe that's a study sometime some people can think about. What sort of monitoring should they have?
Yeah. So, sir, during monitoring, like normal, any critically ill children who is admitted in PICU, like we monitor, routinely we'll monitor vitals, heart rate, respiratory rate, saturation. We have the target for mild to moderate and severe ARDS. Intermittently, in non-invasive blood pressure, and most of the time, if these children are critical, they will have arterial line, so arterial BP. Effect of breathing, like simple clinical examination, respiratory rate, distress, signs of distress. Continuous monitoring of CO2, this is very important. Why we have a target that pH has to be maintained more than 7.2, and PCO2 targets are also there. And sometimes if the patient is having significant dead space, that what sir was telling, that tidal volume dead space, that ratio also has to be maintained. Coming to the respiratory dynamics parameter, there we have the tidal volume. We have to be very sure that we are measuring only the expiratory tidal volume. So the expiratory one which is there, that has to be maintained, and you have to keep in check that the patient is not having any significant dead space there. Okay. And if the patient is having any very circuit, the circuit compliance also has to be nullified by using the ventilator. Plateau pressure, driving pressure, ma'am has already discussed, that also has to be measured. Flow time, pressure time curves, and intrinsic PEEP during the respiratory or ventilatory parameters has to be checked. Now we'll come to the fluid balance. Most of the time these children, they will be having on lot of supports, so obviously we need a negative balance so that the overall morbidity, mortality will come down. Lung imaging, chest X-ray in PALIC 2, they have given that chest X-ray is the diagnostic criteria, so it has to be done. CT scan, they have not recommended anything, but if you are suspecting the patient is having any significant problem, CT scan can be done, but obviously the problem of shifting them to CT room and all those logistic issues are there. Coming to hemodynamic monitoring, as these patients, they will have on mechanical ventilator, so the impact of mechanical ventilator on RV and LV function has to be checked by doing routine screening echo, or if sometimes patient is very sick, you need a cardiologist to do the echo. Arterial line already I have told. Next one is cardiac ultrasound in severe ARDS when you are suspecting RV or LV dysfunction by a cardiologist. So as a whole, these are all more or less like simplified way how will you monitor this child.
Thank you, Niladri. Let's talk about recruitment maneuvers and inhaled nitric oxide, to do or not to do. Shatarupa.
So recruitment maneuvers, actually, whether they are actually, what are they? They are transient sustained increase in transpulmonary pressure designed to open up the collapsed alveoli. But the PALIC 2 does not recommend the routine for or against recruitment maneuver. May be used if the patient is hypoxic by slow incremental or decremental PEEP, but sustained insufflation method is to be avoided. And what about inhaled nitric oxide? Yes, it does not also, it is also against the routine use of inhaled nitric oxide, but we can use them when we are suspecting RV dysfunction due to severe PH or as a rescue to ECMO. If used, we should be assessing them after 4 hours whether to discontinue or to continue inhaled nitric oxide.
So yes, recruitment maneuvers, I just wanted to add something that ARDS by nature is a patchy disease. It's not like a lobar pneumonia or a big effusion on one side. So it affects the whole lung. So you have got bits of relatively good lung in the middle of lots of bad lungs. Unless you can recruit all the available good lung units, what you are going to do is increase injury to whatever lung you have recruited, because you'll have to have some tidal volume to have enough gas exchange. So if you are doing even 4 to 5 mils per kg of tidal volume and your effective lung is just 1/8 of what you would normally have, that is a huge amount of strain for that bit of lung. So need to recruit as much as possible. So recruitment is extremely important to reduce the risk of ventilator associated lung injury. How you do it, but we don't really have time to discuss. And inhaled nitric oxide, obviously, if you have a problem with right ventricular function or raised pulmonary artery pressure, then only it's going to work. It can't be a blanket treatment. Not every patient with ARDS will have it. So you need to find out if there is RV dysfunction or if there is raised PA pressure. Then only you can use inhaled nitric oxide. And nitric oxide work instantly. They have said 4 hours, but it shouldn't take 4 hours actually. It will, if it works, it will work immediately. If it doesn't work immediately in 15 minutes, it's never going to work. So you might as well stop it. But they say 4 hours, so it's fine. But I think you will see the difference straight away if it's going to work. Sedation and neuromuscular blockade. We just had an excellent talk about that. We'll just briefly talk about ARDS related points.
According to PALIC 2 guideline, the sedation, it is recommended that the sedation with minimal possible dose to prevent patient asynchrony and the discomfort. As the previous session has discussed the sedation, there are different types of sedation scales. We should assessment of the everyday sedation by the sedation scale that is discussed in the previous session. Also the delirium and withdrawal and the pain assessment scale also to be monitored in daily. And the routine use of the typical and atypical antipsychotic like melatonin and other medicine to prevent delirium, that is the withdrawal symptoms, is not recommended by PALIC 2 guideline. And regarding the neuromuscular blocking agent, it is effective and used only to protect the mechanical, when the mechanical ventilation is proper oxygenation is not achieved with the only sedation and analgesia, then only use the neuromuscular blocking, and also it should be used intermittently, not continuously, and also to monitor regularly to assessment of the neuromuscular blocking, neuromuscular function, and whether there is any muscle atrophy or any bed sore or in the skin ulcer, it also be monitored daily.
I think, I think that's important that we use as less neuromuscular blockade as possible. But having said that, when you are using very high ventilatory pressures, if the child is restless on top of that, you are increasing a lot of risk. You are increasing risk of pneumothorax, you are increasing risk of CILI. So I think we need to have a balance of what we are trying to achieve and with the least amount of complications. Yes. A role of proning, any role of proning?
So like, as you know that every time we are dealing with ARDS patients, whenever we are in the highest FiO2 and high pressures, and the child is not improving, our OI or SF ratio or PF ratio is not improving, you always go for proning. And definitely I would say from our experience that proning do help in increasing the oxygenation and oxygenation part of the ARDS part. But ultimately whether it is converted to decrease in the mortality, we don't know exactly. But as per the PALIC guideline, so they are now having no strong recommendation for go for proning. But if you see other studies, there are a few studies actually have done in recent studies, a PRONET study has been done. They have seen that there is significant increase in oxygenation and significant decrease in driving pressure. So whether it is actually decreasing the mortality, that is not there, but they have found that it is definitely help in oxygenation and improving the driving pressure. Next, so this is actually latest study. What has been done here is, so in PROSERVE trial also they have seen that there is a improving 20 mortality and 90 mortality if you are using proning. So almost 16% versus 32% and 23% versus 41%. So it is definitely helpful as per the PROSERVE trial.
Unfortunately, there aren't any good-sized pediatric study on proning. And the problem now is almost impossible to design one ethically, because if your options are proning or going to ECMO, what are you going to do? Are you not going to try proning? So to do a randomized trial of proning in an effective way has become a very difficult thing to achieve these days, because we will all do proning because physiologically it makes sense. So, and if I give parents, what would you like? the child to be put upside down or put on ECMO, what would they say? Can I ethically take a consent for that? I think practically it has become impossible to do a proper study on proning anymore. So I think we'll keep using it, though there is no evidence. I don't think we'll ever produce the evidence of proning. So coming towards the end, when to consider extracorporeal life support?
So ECMO, like in last stage, these are the resources in very high resource settings, or where you have the options to send the patient to a higher center. So most important thing what you have to remember is these are cases where the cause is potentially reversible, like the patient has some corrosive ingestion. There you can obviously consider where the outcome is also good. Next, severe ARDS, where after all you have done with your lung protective ventilation and all, there is still target is not achieved, inadequate gaseous exchange is there. Next, during ECMO, obviously the patient has to be thoroughly evaluated by a ECMO team who will take over now, and serial evaluation, especially the neurological part, because the patient neurological status is very important while the patient is on ECMO. So pupillary reactions, maybe this NIRS, all those things has to be properly monitored. Next, coming to the modes, VV ECMO, venovenous ECMO is better than the veno-arterial one, where the cardiac functions are beneficial. So in short, these are the few PALIC recommendations regarding ECMO.
It's always going to be a difficult choice, isn't it? Because pediatric ECMO for pulmonary causes will have a success rate or survival rate around 50%. So recommending a therapy which has got 50% chance of success. So you need to be on a point when you think standard therapy will have a higher mortality risk, isn't it? At the same time, if you wait too long and the child develops organ dysfunction, then there is no point in doing ECMO anymore. There is a study, adult study from Australia, Australians only can do that, when they put adult patients with moderate ARDS on ECMO and had excellent outcome, 98% survival. So should we do that? No, obviously, ECMO comes with its cost, and 50% mortality is obviously too high a mortality to consider for a moderate disease which will be responsive to standard treatment. But if you are going to think about ECMO, you need to think about it relatively early, before organ dysfunction develops. So this is the slide towards the end of the PALIC guideline, and it says summary of main recommendation with quality of evidence. And you can see it's a sorry picture. There is only one moderate certainty of evidence, that is PEEP at or above low PEEP high FiO2 table. So this is the only recommendation they have put which has got some evidence behind it. So this is the low PEEP high FiO2 table from ARDSnet. But I haven't put the slide. What Purdy study showed was that most people were not following this lower PEEP high FiO2 table. So people were putting children on 100% FiO2 with PEEP of 8, 10, things like that. And that is a huge cause of mortality and morbidity all across the world, actually. It happens everywhere. You'd see child on 90% oxygen with a PEEP of 10. That is not recruiting enough lung. That's not protecting the lungs at all, and that would cause mortality as well. So remember the low PEEP high FiO2 table. Have a look at it if you're not sure. Like if you're on 70% oxygen, you need to be at least on 12 PEEP. So look at that and adjust your PEEP. We're going to skip this because we're out of time. So in summary, we can do an NIV trial which should be time bound for severe ARDS, cuffed endotracheal tube, lung protective ventilation, use at least the low PEEP table suggested by the ARDS network, P-plat is less than 28, driving pressure less than 15, and SpO2 target of 88 to 92. Thank you.
Thank you, Somen, and all the panelists for excellent deliberations. Now we can have some questions, or anybody will like to have some points.
Time.
Any questions?
So time.
Anyhow.
We can have it at the end. So we can have it at the end, in the lunch session, questions, times.
Okay.
One question, one. No interaction, it should be two-way traffic. Huh? One, at least one question.
I mean, even if you look at the peak pressures that are recommended, driving pressure of not more than 15, and you are allowed a peak pressure of 32. That itself means you are allowed a PEEP of 17 and with a delta P of 15. To, I think, all of us, that sounds bizarre, that your PEEP is more than your PC above PEEP. None of us do that. None of us do that. And we always end up having a higher driving pressure and a lower PEEP. So, I mean, isn't it?
Well, we don't have time for the full discussion, but the problem is this driving pressure doesn't mean anything, because what we'd be interested in is transpulmonary driving pressure, isn't it? And we are not measuring it in most instances. So these children are often bloated, some of them will be obese, so you don't know what the actual transpulmonary driving pressure is. That might be very low, that might be 9, 10, but your peak pressure might be 37, 38.
But when you are not doing it, because you are not doing it, I mean, the take-home message, as you have said, I mean, are we using too less PEEP even after this? We often go to 12. Not more than that. Adults go up to 20. Shall we do that?
I go up to 20.
I mean, that's possibly the question. That's possibly the question, that shall we crank it even higher?
Yes, I think we should at least do the low PEEP, high FiO2 table, not less than that.
Yeah, that's possibly the take home. Thank you.
Thank you. Thank you very much. Very interesting session. Again, thanks to panelists and so many for excellent discussion. And see, we could have more questions, but we have to stop by warning by the organizers. Anyway, thank you again. Thank you to the audience also. Thank you.
I would request the chairperson, moderator, and the panelists to please collect your memento from the Felicitation Center. So moving ahead, we have the next talk on learn to unlearn. What are the change of practices in PICU? For this, I would like to invite our chairperson, Dr. Dilip Paul. He is the former founder principal of Raiganj Government Medical College in Uttar Dinajpur, and presently he is the principal of Dr. B.C. Roy Postgraduate Institute of Pediatric Sciences in Kolkata.
Very good afternoon to all of you. I am thankful to the organizer for calling me, for inviting me for this session. And I am very lucky to introduce Dr. Binayak Patki. He is the Director, Neonatal and Pediatric Intensive Care Services and ECMO Program, and as well as Head Department of Pediatrics Neonatology, Ushakal Abhinav Institute of Medical Sciences, Maharashtra. And he has many publications. He is now the Executive Board Member of IAP 2024. He will deliver a lecture on Learn to Unlearn, the recent change in PICU practices. Okay. Okay. Yes. Start up sometime.
Good afternoon, everybody. From very much thank you for inviting me for this East Zone Pedicriticon. Without much timing, I think we are delayed by 5 or 10 minutes. So without much time, I will straight away go to my topic. The first of all, this is greetings from my institute, Ushakal Abhinav Institute of Medical Science. What I'm going to do today is take you to the journey of almost 25 years of pediatric critical care in India and around. And before that, most important thing in your life maybe is personal life or professional life or any pathology, any pathy. The only thing that is constant is the change, and that has very importantly been applicable to the so much dynamic thing of critical care. So you can learn to change the world or go on being changed by it. So we go by a phase of learning, unlearning and relearning. So we try to acquire some knowledge, new horizons, then outdated information we try to fresh it off, incorrect information, and from those unlearning we try to go on relearning. So there is a stuttering course of pediatric critical care over a period of time. So in early 90s we were very more aggressive. We were trying to see how the control is there, how to resuscitate, sedate and all that. And we were aggressive to normalize. So in that phase of more is better. That was the principle that time. In early 2010, we'll try to become a less aggressive. And we are testing the guidelines what has been published over a period of time. And their concept was less is more. Now in early 2022, now we want to have a right amount of critical care, and that means we want to protocolize, individualized approach from protocolize. So that is the right treatment for right one. This is how the things are going on. In next 30 minutes, we'll try to go these 8 main domains of critical care, and we'll just start with sepsis. So what has changed in sepsis? So way back in 1992, first sepsis guideline has come with this SIRS, then sepsis, severe sepsis and septic shock. And over a period of time, then sepsis 1 came, 2, 3, now we have come up to Phoenix. And what has changed is this important thing has changed. So we are now only 2 terminology. One is sepsis and another is septic shock. So what do you mean by sepsis? A life-threatening organ dysfunction because of dysregulated host response. And if it comes to the cardiovascular or hemodynamics, what we call as a septic shock. Then comes this P-SOFA score and other things like now it has come as a Phoenix criteria and all that. But what is the implication of changing this sepsis definition? First and foremost, improved diagnosis. It has definitely a research implications, and I'd say we are shifting from focus of just inflammation to a strategic prompt recognition and management of organ dysfunction. We are come to this stage. Next stage is come as early recognition and categorization. So we have been taught and we are discussed, and still we want to categorize this cold and warm shock, but this concept is slowly getting changed, and it has been already changed. Just feel pulse, cold, feel the temperature and all that, and then you differentiate between these 2 things. And all of our guidelines, maybe starting from maybe 2004 of ACCM guidelines till today, how we were managing is first see if it is a cold or warm, then see the blood pressure and try to manage it. Our things have changed over a period of time. So we have got lot of evidences in last 10 years. And what we find is, though we feel it is cold, if we put the invasive blood pressure monitoring and do the echo, things are actually warm, and vice versa. And this multimodal monitoring has changed our approach towards looking at cold versus warm. And what this lot of study, because of time constraints, I have included only few limited studies, and there was a very poor correlation of clinical assessment of cardiac index and SVR measured by advancing monitoring. And this demonstrates the challenge of using clinical science alone. So it took almost 6 to 8 years to come to the SCCM guidelines of 2020, and what suggests not using bedside clinical sign in isolation to categorize septic shock in warm versus cold. This is something significant has changed, and it will change more because lot of point of care ultrasound and other things are available now in tier 3, tier 2 cities. Coming to the fluid boluses, so many things have changed over a period of time. 2007 has come with 20 cc push till liver gets palpable. That was the era when we're trying to push up to 60, 80. Sometimes we have gone, you must be, those seniors also must have gone across. And then 2011 come as a feast trial. The fluid boluses has significantly increased 48 hours mortality, and then we started relooking at the evidence key, whether this thing, whatever we are doing, correct or not. 2015 has come, but that was not a significant thing. It has come, give 20 cc, wait, give 20 cc, wait. And this is how they were trying. But here they were saying, ki, go slowly, steady, and try to check on your things. Still, but all things were like looking like 2007 only. 2021 has changed significantly. So what it suggests is, they said now if you are, whether you are working in intensive care or you are working outside the intensive care, your protocol should be slightly different. You should be very slow when you are managing without intensive care unit. And abnormal perfusion without hypotension, there is no fluid bolus. So hypotensive shock fluid bolus is already out from the treatment. This is cervical sepsis guidelines 2021. Type of fluid also has changed. Over a period of time, we are trials of crystalloids, colloids, NS, RL. Now is the era has come of a balanced, crystallized, balanced solution. And what it has shown that lot of trials, just I have take 4, this is from our Zuma and Jayasri madam, this article is there. So there is lower incidence of new and progressive AKI during first 7 days of hospitalization if we use a balanced solution for resuscitation. So this is again a significant change has occurred. Coming to vasoactive agents, so this is big no for dopamine, already we are doing it. And this has come over multiple studies or multiple period of time. Our Indian contribution is also there significantly. What dopamine does increase arrhythmias, increase of mortality, increase risk of hospital-acquired infections. So they compared dopamine versus adrenaline, noradrenaline, both the things, and it come like that. So dopamine was associated with the death of odds ratio of almost 6.5 and healthcare associated infection almost of 67.7. So epinephrine has a survival odd ratio of 6.49. So if you use epinephrine, there are almost 6.49 times you are reducing the risks. Exactly same thing has been come in last 2020 guidelines, and what it says, use epinephrine and non-epinephrine rather than using dopamine if available. And most of the, yes, there's a weak recommendation and low quality evidence, but that was in 2020. Over a period of time, maybe 5-6 years down the line, it will be a standardized guideline in next coming updates of SCCM. Multimodal monitoring, this has come in a big way, and most of the things now started. Fluid status you have to see by lung ultrasound, whether it is responsive or versus fluid intolerance. Then heart, you are seeing ascertaining systolic diastolic function by echo, vascular tone by UCA DISCOM, non-invasive cardiac monitoring, and real-time intra blood pressure monitoring. So these will be our next way of managing shock, septic shock. We'll have a IVC and lung USG, we have 2D echo for cardiac, we have arterial monitoring, and that's how your focus will change you differentiating these things rather than being cold and warm, and that's why this thing has come. So this is just a diagrammatic presentation of 3 hypovolemic, cardiogenic, and obstructive. This is how things will go. And this may be the next things how we are going to ejection fraction you measure, see the IBP whether low, dampened or normal, see the pulse pressure, and accordingly try to titrate your drugs. So no business of giving this low pulse pressure and all these things has cold and warm things has been outdated, and this is how we are managing, and most of the centers are managing. Maybe figures here of ejection fraction here are there maybe of slightly different. And this how this previously CB, all this has proved that hemodynamic management of septic shock has definitely made the impact on the survival of the patient. So USG guided fluid boluses has significantly better therapy. Lot of research I have taken just recent things for time constraint. Then this concept it is not a new thing, but it is now, will be a de-resuscitation is coming up in a big way, and this is going last 4 days. You see the picture of Rose, actually it is just for understanding purposes. So we see now resuscitation phase, organization phase, and then comes your stabilization and evacuation. Always we forget the things to evacuate the fluid, and that's how this Rose concept has come. And now 4 Ds we have to answer is whether drug, dosing, duration, and de-escalation of fluids. And 4 questions you have to ask, whether to start IV, when to stop IV, when to start de-resuscitation, and when to stop the de-resuscitation. So this is coming up, and this will be the part of maybe of putting diuretics, putting on CRRT and all these things. So now just in short about septic sepsis and septic shock has come. We were fast and furious maybe in early 2000, and now we are steady slow and taking a slowly we are moving towards a very individualized manner for that things. Now coming to next, all of us, I think, so many just touched about ARD, so I will not go, almost things have been touched. So just I will see what things have changed. Same thing like sepsis, 1994 we started first definition, and we have come now to PALIC 2. So Berlin has come in 2012, then PALIC first has come, and now from this PARDI trial, what everybody was discussing, this is international observation study, this definition identified more children of PRDS than Berlin definition, and they say this is going to, stratification has improved about a mortality risk, particularly when applied after 6 hours of PRDS diagnosis. So this how the things has come, like stratification now mild or moderate and severe, and already the session has been there, so I will not take much time on this because you have already been sensitized to that. Changing management strategies, there are a lot of things have been, this is PEEP. 22 RCTs, almost 2,000 patients, so higher PEEP versus lower PEEP was compared and not associated. This I am just putting not ARDS, this is also applicable to the ARDS also. So PEEP has definitely, then recruitment manuals has been changed. Almost this was 120 ICUs from 9 countries or 7, and what they found as 20 days course of mortality was increased by high PEEP and open lung strategy. So open and big it open with big inflammation pressure has gone only, whenever is required, we want to go with only PEEP titration. APRV still we could not able to solve this issue. Few people, those who are using want to say it is, but still over 30 years we could not able to, yes, there's from studies from PGS said APRV is not a superior thing, but a stand concrete things still we are, so we may get some question over the period of time. Yes, so HFOV, we all know, Oscar and Oscillate has hit HFOV like anything in same journal, back-to-back articles in 23, and almost adults have stopped HFOV, only few neonatologists and small infants in some intensivists, pediatric intensivists. So HFOV has gone, this has big changes happened. Proning, as already the last discussion was there, proning has come in a big way, and is prolonged proning for 16 to 18 hours has proven beyond doubt of putting this patient from ARDS. Two important things, driving pressure and mechanical energy. These are coming, this is again big trial of Amato, almost more than 3,500 from 9 previously RCTs. What it says that decreased delta, that is driving pressure, is going to change a ventilator, is strongly associated with increased survival. So our things as going from different high PEEP, low PEEP type things to we may change these things to driving pressure over a period of time. Mechanical power independently has affected, and you maybe this next few years will see controlling the mechanical power. Few already ventilators have come, they measure the mechanical power, though may be different, their goals may be different, and so mechanical power also is going to get affected. Patient self-inflicted injury has come as very spark, and Gatineau et al. Has proven in the COVID era, this is something which is going on, and which if you can't control, these forces generated by increased inspiratory efforts are equally, or it is almost associated like a ventilator lung injury when you put on. So this may be a factor in few days, few years ahead. Already this slide you are been highlighted, so I will not go detail. So this is something dramatically changed related to the ARDS. Coming to the critical care nephrology, what has changed? From 2007 we have Akin guidelines, then came the KidGo, then come PREFL, and now PROC. What these guidelines over a period of time is early detection. So these guidelines said how much percentage of serum creatinine, how much percentage of your output and all these things. So we are going towards a very objective way of looking at it. We have a lot of diagnostic tools now. We have functional biomarkers, damage biomarkers, and primary pre-injury phase biomarkers. And according to that, we can say now which part of actually of glomerulosis kidneys get affected. So these four things, serum, NGL, cystatin C, creatinine, interleukin C, and urinary NGL and KIM1 has already been in our practice, and this has been validated also. So they have a good sensitivity specificity to diagnose early AKI and doing its management. So these we call as a novel biomarkers in this. Not only biomarkers, but things have improved in form of management modalities also. Biocompatible solutions have come for PD, improved ultrafiltration methods have come, high flow CKRT has come, and cytosorb and oxidase, now pediatricians and pediatric intensive specifically are increasing their use as compared to as good as adult intensivist. New machines have come, slow motion pumps, high sensitivity scales, lot of new circuits have come, and this has made the acute and chronic RRT for small infants. This was a major, you can say, logistic issue was managing this small infants. So things have changed. Coming to critical care neurology, what has changed? GCS in APU, now we have a different scale, 2021, the serial neurological assessment of what is called as SNAP scale. And over next maybe few years, we'll start using this score, and this has a very delicate things. From 0 to 5, it takes the mental status, it takes the cranial nerves, in communication, natural as well as artificial, and motor function, upper and lower extremity separately. So this score we are not accept, but now over a period of time we'll start go away from GCS, and this SNAP score will, because this is specifically designed for critically ill children. Cerebral oximetry and perfusion, yes, most of the advanced level 4 centers are using nurse, but partial pressure of brain oxygen, tissue oxygen is coming in a big way, and your targeted therapy to this for traumatic brain injury has come. Continuous EEG monitoring is at almost now level 2, 3 tier cities. I started using it for status epilepticus and other comatose patient, but amplified EEG, what you can call as, just get a strip of 24 hours EEG, and you can just correlate with your hemodynamic parameters. When are those ICP sparks, and when you are getting this seizures and all that is a big coming. But 2029, 19, this is what traumatic brain injury has come. It has given a lot of things related to the hyperosmolar therapy, sedation, analgesia, and decompressive craniotomy is the area where still we don't have any specific recommendation, but still it will come, because this is a very low high-end therapy, and people try to still avoid it. Fires and NORS is coming. We have now international consensus recommendation for these things, 2022, and it says what important thing has come in here is try to see acute diagnostic workup in 40 to 70 hours. So the timeline for investigation also has been set for fires and NORS, and what two things are methylprednisolone IV gamma within 40 to 72 hours, and plasma exchange facilities are there. This is coming, and shifting the patient to ketogenic diet in early, maybe within 7 days, this is come. And this is a guideline now. So you cannot have, we have managed it in a like personal variations. So 2023 pediatric and adult brain death guidelines have come, and we are started managing. Now I'm coming to nutrition part. So in early enteral nutrition has coming up in a big way from, we are just going away from parental nutrition. Early enteral nutrition has come 2020. This last 3-4 years has come. And what, madam, please. So acute phase, maybe acute late phase and recovery phase, early enteral nutrition is your way. Whether it is a severely malnourished child or whether it is a well-nourished child, moderately malnourished child. We want to go these children with early enteral nutrition. And what is shift from protocolized to personalized management, understanding metabolic changes of the patient, and early initiation of nutrition. And very, very important thing is no protein restriction this. Now protein restriction is gone now, absolute, except for very specific indications managed by pediatric nephrologist. Sedation, analgesia, gone are those days when we're trying to keep the child banded with bandage to the bed. So what is targets are early arousability, no synchrony with ventilator, generally appears comfortable. Lot of scales have come, comfort scale, RAS scale, SBS, so many scales have come. So you now are monitoring the sedation level also. So what this has built, bundle investigation, minimizing benzodiazepines, screening delirium frequently, disrupting the PICU culture of immobility and drug cycling. All these things have come. So very judicious use of opioid and non-opioid analgesics, intermittent rather than continuous. And dexmedetomidine is coming up a big, though cost is a constraint for majority of us, and outcomes are fantastic. Reduced length of stay, ventilator stay, delirium, and all these things have improved. What has changed about transfusion? Current consensus transfusion medicine 2020 has kept, will not go in previous things, because restricted transfusion therapy has already been established practice in last maybe 5-6 years. But age of RBC product also has come, and it says that it doesn't affect the incidence of new or progressive multiple organ dysfunction. Liberal transfusion also in less than 24 months of corrected age also. And platelet transfusion has come to now lower guideline of 25,000. So from 50,000 has come to 25,000. Now coming to the most important part is modern technology, HFNCS, already we have started newer modes of NIVS come like adaptive servo ventilation, volume assured pressure guarantee, and lot of new modes. Now is not that common, but not that new, but proportional assist ventilation and adaptive support ventilations is coming. So lot of modes have come. ECMO has become, Shubdeep is here. So we have seen the pictures of big ECMO machine compacting, almost occupying the whole room. Now see the compact new machine has compact design, improved pumps. Now extracorporeal circuits have come. Focus. Lot of things have been. So we are doing it for resuscitative. We are doing it for diagnostic procedures, therapeutics. So procedures become part and parcel of our life, and it has also advanced in technology, elastography, advanced color Doppler, artificial intelligence, smart glasses have come, cloud-based focus. So many things are coming into the modern technology. As far as CT and MRI, now we have dark field CT, we have photon counting CT. Things is happening, we are more becoming less injury to the patient, and we are getting more focused, more idea from the patient. So compress sensing, chemical exchange, saturation transport, hyperpolarized. So these are now coming all of us, and these are not available also. Microbiology has come a big way. PCR now, biofires are available, they were tier 2. So we are hitting, rather than giving a empirical, we are directly within 24 hours, we are getting the results and we are hitting the bugs. So MALDI-TOF and by lot of biomarkers about almost all the things. So this molecular diagnosis also has come in a big way in last 24 years. So we are more focused now about that organism, and we are trying to hit that at early and trying to control that thing so that outcomes to be better. So just to conclude now, so what has changing trends of PICU care, we have to go with it. We have to learn new things, unlearn the old things, and again we are going to go for relearning. And what is basic, our aim should be, should be more patient-centered, we should be more evidence-based, and here is the word of caution about maximizing utilizing technology. How much to use it is up to us. How much it is going to, we should not dominate over us like AI and all those things. And what last but not least is minimizing the harm. So we are who is a stakeholder of our country is this for critical care is our small sick child sitting in the periphery. We are going to use whatever knowledge and changing trends of PICU to improve his outcome. So last thing I would like to say, learning is just an experience and everything is just an information. Thank you very much for inviting and giving me this opportunity.
Thank you, sir. Thank you, sir. I'll request sir to please collect your mementos from the felicitation center. This is the last talk, pre-lunch, critical illness scoring system. For this, I would like to invite the chairperson, Dr. Moshmi Nandi. She is the Professor Pediatrics, ex-HOD and Dean of Midnapur Medical College, and presently, ma'am is the principal of Midnapur Medical College. Our speaker, Dr. Manish Sharma. I would request ma'am to kindly introduce the speaker. Thank you.
Good morning. Okay, good afternoon. And I would like to thank the organizers for inviting me to be the chairperson in this session. So our speaker today is Dr. Manish Sharma. He's a senior consultant in pediatrics and in charge of PICU of SMS Medical College, Jaipur. He's the chairperson of IIP Intensive Care Chapter 2024 and the chancellor of the College of Pediatric Critical Care, IIP. He has several publications on brain death certification for IIP, as well as vascular access guidelines in NNF. So today, Dr. Manish Sharma will speak on critical illness scoring system, which is a very important adjunct to the treatment in ICU, and in order to predict as well as to come to the prognosis, this critical illness scoring is important. So now it is over to Dr. Sharma for his deliberation. Thank you.
Thank you so much. Good afternoon, Society of Pediatric Intensive Care, Kolkata. IIP Intensive Care, a part of IIP Intensive Care. Thank you so much, Mihir, Prabhas, and all my friends from West Bengal whom we were meeting in the conferences and who have come to Jaipur to attend the 2 national conferences which we have done. As a chairperson of the chapter and a wonderful talk given by Vinayak, the purpose of these 2 talks were to initiate and start something in the residents which they are going to face. This particular topic, why I have chosen is that being the registrar of Rajasthan Medical Council, I see day in, day out so many medical legal cases against the doctors, and then the system comes, when the ticket comes, and especially, madam, with the government medical college, because I am also a professor in government medical college, and the government medical college we don't have, we solely depend on the residents for the completion of the ticket. But I must tell you that when the ticket goes to the court of law and to the councils in the cases, we hardly see any relevant notes over there. And the patient these days, what they are do is they are just clicking every day the photographs of the ticket, the bed end tickets, the nursing staff notes, and they have a beautiful whole arena of evidences in which they claim and they say that my child was not looked after. See, so these scoring systems, I just want to tell the young pediatricians, the budding pediatrician, may look like that it is something, I mean, why in India we should use scoring systems or why there is any utility of such scoring systems. But let me tell you, when the child comes in your ICU and you have done a scoring system, a scoring index of any of these which I am going to just enumerate, I am not going to go into the details in 20 minutes. It will give you a leverage and it will state in black and white that when the child entered into the ICU, his scoring index, his severity scoring index was good or bad. And that is going to save your skin. That is going to state that yes, we examined and we were knowing that the child is in a very bad state. And simultaneously, our resident level, if the scoring index is pretty poor, he can always tell to the attendants that your child is very sick, the chances of survival are probably this much, we are trying our level best, but this is the actual situation. So this is how you avoid confrontations. Just enumerated few, they are all, no scoring system has till this date come from our country or our part of the world. They are all Western scoring systems. They have been validated in European countries, northern countries, even in other Asian countries, but nothing comes from this part of the world. So Dr. Ivor is there. Sir, good afternoon. He is the Vice Chancellor of the College of Pediatric Critical Care. So this is high time that we also develop a scoring system which we will validate in our own country and which is basically based on our type of patient which we see day in and day out. So the scoring systems are basically of 3 types: prognostic scores, descriptive scores, and diagnostic criteria, which is MODS. So the prognostic score, they are basically including the PRISM score, the PIM score, and the P-load score. I will tell you just a slide on all these scores. They maximize the outcome prediction. They will say what and how the child is going to behave in the future days of his ICU stay. The descriptive scores, which includes MODS, P-load score, P-SOFA, they maximize the description of clinical course and severity of the illness. And then there are the diagnostic criteria, which is covered by the MODS scoring. So what my resident will know, they only know MODS and SOFA, if anybody knows. Rest all probably our resident do not know and we are not using them at all. SOFA is something that the external examiner will come if he is from a background of critical care, and the only thing is that the definition, and that's all. So I think this is high time we start using these scores. The predictive score predicts the risk of death at the time of entry into the PICU. The descriptive scores, they describe the course of illness based on the attributes at the time of ICU admissions. So this is the basic difference between the two types of scores. What is the utility of these scores? They do a risk stratification, very important. They help you in arranging a triage tools, because whenever in government system, the state government or the system asks you to allot the triage tools or to develop the triage area both in emergency and other different part of your medical college. So these tools will assign whether the child, how to handle that child in the triage area. So this will help in deciding the resource allocation, goal settings and treatment intensity decisions, end of life decision making, clinical monitoring and adjustment in the treatment, communication amongst healthcare workers, and guidance for the discharge planning. So basically they will give you a clear picture of the patient, which part of the ICU, which consultant, a third year is going to see this patient or a second year is going to see this patient, what is your resource allocation. This all depends on the score which you have calculated when the child gets admitted in your ICU. We start with few of the scoring system. PRISM, Pediatric Risk of Mortality Score. PRISMs are generally used in sick neonates, children and adolescents, so that covers the whole pediatrics. There are 3 versions of PRISM score. Physiological Stability Index, that was number 1, then came the PRISM 2, then came the PRISM 3. Components, it basically deals with heart rate, systolic blood pressure, respiratory rate, pupillary reflexes, neurological status, and few of the laboratory parameters. Parameters are measured in first 24 hours of ICU, and score is calculated using a formula which gives a numbering. So first 24 hours on these parameters, we calculate the PRISM score. Interpretation is from up to 30, it increases as the severity of the illness increases. The higher the total score, the worse is the prognosis. Now what is the difference between PRISM 2 and PRISM 3? If it is done within first 12 hours of ICU admission, it is called as PRISM 12. If it is done within first 24 hours of admission, it is called as PRISM 24. And it gives a very good prognostic calculation of the patient getting admitted in your ICU. This is the detailed scoring system. I will not go into the details. It has a parameters. It is available on net. You can download it. You can get it printed in ICU sheets, your continuation sheets, and you just have to tick it. It's an habit. Like in the neonatology, NNF, everything, APGAR calculation. Now no residents require a rectification of APGAR. We all know when we were doing our neonatology that APGAR is this. We used to calculate it. So this is the way you master on one scoring system and you develop a whole practice of using it. And if you see, if a PRISM score is 30, then the mortality risk is around 90%. So this is a very sensitive tool in predicting the mortality of the child admitted in your ICU. PRISM 3 has an excellent discrimination capacity because the area under the curve, AUROC, is pretty good and it is highly sensitive. The only thing which is limiting in this score is it is slightly time consuming in calculating the whole score, and it has not been validated outside North America. So as I said in the starting, that no score has been validated. They are developed by their own countries and they are been using those scores within their country. Then Pediatric Index of Mortality, the first version came in 1997 and then PIM3 came in 2013. It uses 8 physiological variables within 1 hour of PICU admission. It is rather easy as compared to the PRISM score. It is well calibrated and has a good discriminatory power. That is, the sensitivity is good. This is a detailed pediatric index of mortality. If you see, it has only 9 parameters to measure. And they are rather more simple than calculation through the PRISM scores. So this is another option which we can use. It has to be used as early as possible when the child gets admitted. PRISM gives you advance rate that it can be calculated within 12 hours or within 24 hours. But this has to be done as early as possible. The advantage of PIM2 is that it avoids the problem of early treatment bias, as it includes only the data entry into the PICU. So whatever are the parameters at the time of ICU entry, this score is basically based on these data. So it is not affected by the previous treatment which the child has received before coming to your ICU. Its main weakness is that it has not been tried in many of the countries, but it has a well discrimination power. That is, the sensitivity is very good again for this score. Then the pediatric logistic organ dysfunction score, that is PLOD. It is a descriptive score, uses the presence and degree of MODS. It includes 6 organ dysfunction, 12 variables. PLODs 2 came in, which also uses, in addition to PLOD 1, mean arterial pressure and lactemia. These 2 things were added in PLODs 2, and hepatic dysfunction was removed from PLOD 2, because what they found is that as a descriptive score, hepatic dysfunction was not giving enough information about the general condition of the child or his future prognostication in the ICU, that what would be the outcome and how the child will be after he is discharged from the ICU. So hepatic dysfunction was removed. This is again the table. You can take a photograph, or it is freely available on the net, which you can download. So the advantage is it has a good discrimination power, good calibration, validated in multiple countries and large ICUs. It suffers from certain treatment bias, and again not tried in Southeast Asian countries. Then the SOFA. I think we all have been slightly knowing what is actually the SOFA score, and thus third international consensus definition of sepsis and septic shock. Basically, SOFA is scoring system to predict the early organ dysfunction. It was developed only for this thing, and it is basically measuring the degree of MODS and how much MODS is affecting the different organs in the child admitted in your ICU. So this was the SOFA score. Attempts were made to incorporate existing pediatric severity score into the definition of sepsis, but the range, scale, and coverage of these scores are significantly different from those of the SOFA score, which makes their concurrent use problematic. It was not possible. And then came the P-SOFA, that is the pediatric SOFA score. Now we have a Q-SOFA, which is a quick SOFA score. So SOFA has another 3 stratifications. So for us, it is P-SOFA or Q-SOFA, which we can use in our ICUs, which initially we tried to use when we opened our ICU. I come from a medical college which has a 250 bedded ICU. My own ICU is 40 bedded ICU, where we provide everything. You name a medicine, you name a type of ventilation, you name a single procedure happening anywhere in the country, we are giving free of cost in government setup. So I don't have to look that any antibiotic, do I have to think twice before writing it, or any procedure, do I have to think twice? Because if you talk about ABG, I have 2 ABG machines in my ICU. I have 3 ultrasound machines, all Sonosite higher end versions. I have a CRRT in my ICU, again all in government setup. And the planning was done by us, our medical college. And it is doing so well that my ICU is the #1 earning component of my medical college. And in last 1 year, we have given 34 crores of rupees to my college fund while giving free treatment to the patient. So this is what I mean. I just deviated from my main topic. So it is actually possible, and we have been doing it. So nothing is impossible, you just decide it. Again, coming back to the SOFA, it can be used in the presence of sepsis in ED, emergency, as well as ICU. Patient with sepsis, those with confirmed or suspected infection who had an acute rise in P-SOFA score of 2 points or more from up to 48 hours, from admission to 48 hours, then they have more chances of succumbing. And a P-SOFA score of 11 predicts almost 100% mortality in a child admitted in your ICU. So actually that is the sensitivity of P-SOFA score. We never imagined it, but SOFA is actually very sensitive. And we have been using SOFA. We stopped because, see, medical college all depends on the zeal of the resident coming on rotation to your ICU. If you have a good subset of resident coming, they start using it. If the resident is slightly comfortable, happy, jolly, then all scoring systems goes to the background. So this is a big disadvantage which I face, and almost everybody in a medical college would be facing. Now MODS, we all know, all these scores are basically calculating MODS, a degree of MODS, the severity of MODS through different parameters which they are measuring. So because of time constraints, I will not go into MODS in detail, we all know. It is defining the degree of sepsis and the number of systems involved as sepsis. So if you see all these scores, these I think, because I have only 3 minutes, if you see this particular slide, you can take a photograph of it. It was very difficult to get this slide because it is comparing all the scores which I have given to you till this time. It compares everything. So you can decide for your ICU that how much time your resident has in using these scores and what he can use. So this is a comparative slide. Again, this is a comparison of all these 5 scores on organ system and everything. Now coming to the limitations of scoring system. There is an age-related variability. Yes, number one thing. They have not been tested in our country, not made for our country. It has been made for the country which has a different subset of diseases. Here we are dealing with the tropical infections. The country where it was developed, they don't have any tropical infection. So the validation in our country requires a lot of hard work. There is a lack of functional outcome measures. Scoring system in pediatric critical care focus on mortality predictions and not account for long-term functional outcome, neurodevelopmental outcome, and quality of life after the discharge. So this is one part which is lagging, at least in mortality predicting scores. In descriptive scores, you have some amount of these predictions. Incorporation of subjective assessment and parameters. There is a lot of individual bias while you are calculating these scoring systems. And the most important is risk of self-fulfilling prophecy. I may utilize the scoring system for a better care of that particular patient, that his scoring system is high, I will give him the best of the best possible pediatric critical care. Whereas my colleague will give a verdict to that patient. Iska sofa kitna aaya? Itna aaya. He will go. So once the consultant say he will go, the resident also starts thinking he will go. And then finally the patient goes, and we don't have any affiliation towards why we didn't try to save that patient. So that limitation, because we think that this score has given the future of this patient. But actually it is just a diagnostic tool. So this is a major limitation while using these scores. What is the future development in these scoring systems? There is an integration of biomarkers and genomics. As Dr. Vinayak already has given in his presentation, that with the inclusion of biomarkers, and let me tell you, before we pediatricians, the oncology people are using these biomarkers very well. And they have actually incorporated biomarkers while initiating their therapy. All we treat all of us are treating leukemias and blood malignancies. The oncology fellow comes in, he will always write for the biomarkers. When the report comes in, then he will start the treatment. He will not give any kind of treatment for initial 3-4 days. He will wait, conservative. Packed RBC laga do, FFP de do, platelet de do, everything. But he will wait. We are not using in intensive care any of the biomarkers. So the future is using the biomarkers for predicting the severity. Computer learning and AI, use of AI, yes, it is coming every time. And AI, now the tools are coming where the scoring systems are coming on your mobile in the form of app. You just have to fill it and the scoring system will come. So no hard work required. And the interpretation also comes in. Real-time monitoring and predictive analysis is there. Telemedicine and remote monitoring based on scoring system. It is a wonderful tool for people who are into telemedicine or trying to develop telemedicine or tele-ICUs. Because if the score is there for a person who is sitting down 200, 300 kilometers, it becomes relatively easy for him to decide the therapy. Incorporation of patient-reported outcomes. Future severity scores may incorporate patient-reported outcomes, providing a more holistic view and a better outcomes. So they will see how the patient behaved after the discharge, and every time the patient is discharged, the feedback will come to the system and they will continuously, dynamically try to improve the scoring system. Ethical and cultural consideration. Future severity score may aim to incorporate ethical considerations and cultural factors that influence decision making in ICU. I'm sorry, this slide was there in Sholapur also, but I am again happy to be in Calcutta. I'm always happy to be. I'm always happy to be in Calcutta. Calcutta people are. I came in Pedicon, and after Pedicon, this is the second time I'm coming to the Calcutta. So you people have done it very well. Mihir has done it excellently well. This whole on organization and everything. And Mihir is one of the very dedicated soldier of pediatric critical care, supported by all you young people. I mean, I have seen you in all Pedicriticons, and it is an honor for me to head this chapter for a year and develop new things. Whenever you feel like developing a ICU in a government setup or even a private setup, I really tell you that my ICU is probably at par with any of the best corporate ICUs. So you want to come, you want to see how to develop a ICU in resource limited. See, people say government medical college resource limited, how to develop ICU in resource limited. So no, we are not resource limited. The resources are there. It is only the zeal to perform, and you can do it. Thank you so much.
Thank you, sir.
You have dealt in details with the predictive analysis, how to do the prognostic diagnosis, everything. So, as well as also you've discussed the limitations. So, I can only ask 1 or 2 questions.
Thank you, Manish. Fantastic. And when you talked about the resource limited thing, Mihir possibly have more toys, more gadgets than any of us who are working in the so-called corporates, right? He has cardiac output monitoring. He has. So they are resource-wise, gadget-wise, they are well more equipped than us. Absolutely. One question about this PIM PRISM thing. PRIM has got no patent and it's free. Yeah. And PRISM has got a patent and it is not free. Yeah. So my question is a very practical question. Can you, you can use PIM for a study, you can quote it, you can use it in your unit. can you use, is there a legal issue? Suppose you are using it in your unit, and you are using PRISM and you are not paying them. Can that lead to some legal thing?
Yes, a very good question. I mean, excellent question you have asked. Yes, it is a patented scoring system. You can use it in your ICU, no problem. अब हिंदुस्तानी आदमी कुछ भी कहीं भी कर सकता है. Zantac, ranitidine was discovered in USA. Rantac came in India, and then Rantac was exporting salt to USA for making the ranitidine. So we are the boss. That is the thing. But the question is, if you are publishing a paper, then it might create you a problem.
Or if it goes to a court.
Yes.
Then, so if it goes to a court, then you cannot really quote a PRISM score because you are not paying.
Yes. Yeah. That is why all my, Dr. Ivor is there, everybody, Vinayak is there. So, the IAP intensive care chapter should develop a severity scoring system.
Without a patent.
Without any patent. That is intensive IAP property. So, I think we should.
Okay, so if we don't have any questions, we will move into the inauguration session. Thank you.
Thank you, sir. Thank you. I'll request ma'am and sir to please collect the mementos from the felicitation area outside.
Just a mini presentation from in between chair gulo sajiye.
Sir.
On behalf of the intensive care chapter, we would all like to invite you for the 26th Pedicriticon, the national conference of the intensive care chapter, which has been hosted by the IAP intensive care chapter Tamil Nadu and Puducherry in Chennai. The dates for the conference are 13, 14, 15 December 2024, and the workshop dates are 11, 12 December 2024. There will be more than 100 national faculty and more than 22 international faculty. There are going to be 14 workshops on pediatric critical care, and first time new workshop, PICU liberation and transplant critical care will be held. At the same time, we would also like to reiterate the fact that this time is the first time we are having the conference in Chennai after 22 years. Also, there is a separate track for PGs, postgraduates, fellows and pediatricians, and this is going to be on all 3 days of the conference, so that you don't have to deal with it is for those pediatricians and postgraduates who deal with sick children. So this is going to be very, very basic and very, very important for you guys. Also for all the PGs and the fellows, the rate for the registration rate for the conference is going to be at around 10,000 throughout the year till the conference, so that they can attend the conference. The conference is being held at ITC Grand Chola. These are the workshops, both POCUS and SONIC workshop, which is with ultrasound. The pediatric critical care nursing workshops are going to be held on 2 days, one at Vellore, one at Chennai. The RESUS workshop, the SIMS BPICC workshop, the SLED and CRRT, ECMO and pediatric bronchoscopy and NIV workshops are going to be held. If you register for 2 workshops, you'll get a discount of 1,000 rupees. So please encourage your fellows, PGs and your postgraduates to attend this conference. There is the first time the IAP is also hosting the nursing CNE on 13th of December at Ramada Gindi. This is where the conference is going to be held, and we invite one and all for this conference. It's situated at center of Chennai, and it will be very easy for you to travel from anywhere to the conference. The current slab rate has been extended till this month's end, and it's going to be 13,500, which will continue till this month end. Thank you so much. And we invite one and all for this conference from all of us at IAP Intensive Care Chapter. Thank you.
See, the Chennai people, they have an excellent scientific content. I have been sitting, it's almost every week or by every 15 days we are having a meeting. I must say, and I promise you that the conference is going to have excellent scientific content and very good speakers. And secondly, they all are doing it from their heart. It is not easy for intensive care people to do a conference in ITC Chola. So I have done 2 national conferences. I know, one I did in a medical college and another was a different. So what they are doing is an excellent venue with a very good scientific content. So we all should come, enjoy 3 days over there, a scientific fiesta. And again, this would be a great help to the organizers and for the intensive care chapter that we are doing such a wonderful activity. And I also request that now you have a state chapter. Yeah. So anybody who else, they have a city branches of the IAP intensive care. So if they have a city branches, as per IAP regulations, now you should have a state branch. And the city branch would be merged into a state branch. So communicate it to your friends that now stop developing city branches and all of you should develop your state branch of IAP intensive care, which any activity you can do under the umbrella of your state branch. Thank you.
We are so happy to have a full hall with so many discussions since morning. Now we are proceeding towards the lunch, but I'd like to request you all to stay back for the inauguration. Now I'd like to call upon Dr. Manish Sharma sir, the National Chairperson, as the chief guest for our inauguration session today. I'd like to request you, sir, to kindly come up on the stage and take a seat. Side. Now, I'd like to request Dr. Vinayak Patki sir, the National Secretary, to join us as the special guest to honor our inauguration session. Thank you, sir. Kindly come up on the stage and take a seat. I'd like to request Dr. Eber Jacob James sir, our Vice Chancellor, College of Pediatric Critical Care, as a special guest for today. I'd like to request you, sir, to please come up on the stage. Now we feel so humbled to request Dr. Trideep Banerjee sir, our Chief Patron, Society of Pediatric Intensive Care, Kolkata, as the guest of honor to kindly come up on the dais and take a seat. We feel so privileged to have amongst us Dr. Shukanto Chatterjee sir, our patron, Society Pediatric Intensive Care, Kolkata, as the guest of honor for today's session. I'd like to request you, sir, to kindly take a seat on the dais. Now we welcome Dr. Santosh Agarwal sir, our patron, Society of Pediatric Intensive Care, Kolkata, as a guest of honor. I'd request you, sir, to please come up on the stage and take a seat. Now I request none other than Dr. Mihi Sarkar, Chairperson, Society of Pediatric Intensive Care, Kolkata, the organizing chairperson for this conference, and the Secretary, West Bengal Academy of Pediatrics, to kindly join us and take a seat on the dais. Next, we call upon Dr. Abhishek Poddar, the Secretary, Society of Pediatric Intensive Care, Kolkata, to kindly come up on the stage and take a seat. Now I call upon Dr. Prabhash Proshungiri, the organizing secretary for this conference. Kindly join us and take a seat on the dais. Next, I'd like to request Dr. Dipendu Rai Chaudhuri, the co-organizing secretary of this conference. Welcome you to the dais and kindly take a seat. I'd like to thank all the dignitaries on the dais and off the dais for making some time from your busy schedule and joining us, and so that we can make this program successful. Now, I'd like to hand over the mic to our organizing chairperson, Dr. Mihi Sarkar, to give the welcome address.
Thank you, Nandini. So very good afternoon to one and all. So I welcome you all on behalf of the Society of Pediatric Intensive Care, Kolkata, and West Bengal Academy of Pediatrics and IIP Intensive Care chapter for this East Zone Pedicriticon 2024. The second time in a consecutively we are doing this conference for East Zone. Since 2018, we started our state conferences in Monsoon CME, and then now in a row we are doing this. Now we are doing the East Zone Pedicriticon. Our chapter has started in 2013, and now it has grown in leaps and bounds with the very active members. So I want to welcome you with this very nice video on. Please start the video. Thank you.
Now I'd like to request you all to join us to inaugurate this conference. And we have a new way, like always we stand up and light the candle. Here will be floating candles. Yeah. I'd like to request all the dignitaries to kindly join us. We have many candles. We'll be happy if you join us. And this flute has been played by none other than Rohit Mukherjee from our events team, and he's the son of Shomnath Mukherjee. Yeah. He has played and recorded this for this session. Thank you all. Let the ray of light spread hope and happiness and keep you all happy, healthy and safe. And we can have such conferences every year and have you all join us. And we can gather here with so fantastic academic sessions together with this kind of sessions and activities. Thank you so much. Now we continue with our inauguration. Continuing with the proceedings, I'd like to request our chief guest, Dr. Manish Sharma sir, to kindly give the inaugural speech.
I was thinking that this is the best part. Mihir has not done no speech, no bhashan baji, but and finally Mihir also kept it. Again, thank you so much, all the invitees, delegates, senior pediatricians, colleagues, and my fellows of pediatric intensive care, both college as well as doing pediatric critical care. It has been a hectic day for me and Vinayak. We have been traveling since last 2 days, and the whole night we have come from Solapur in the train, and the flight got delayed for more than 2.5 hours. So we have been traveling, and we'll be traveling in the evening right now after this ceremony. But anyhow, it's a beautiful experience, and couldn't say no to Mihir when he requested, and he has organized it so well, supported ably by all the senior pediatricians and the colleagues. My only carry home message is that there is no as such a defined pediatric intensivist. Everybody is a pediatric intensivist, because whether it's a bronchopneumonia or diarrhea vomiting, every critical care, every illness, initial few hours is intensive care. So please circulate basic critical care amongst your fellows, your state members. It really hurts when your PG student come and during the Viva, he does not know MD Viva, the basic steps of CPR or pulse or anything. So we may be talking pretty high, I may be talking blah, blah, blah about my ICU, but the moral of the story is what my candidate is carrying, what he is learning since last 3 years. So we should at least train them in basic pediatric critical care, and a beautiful program has been developed by Dr. Ibor in the Essential of Pediatric Intensive Care, which has been upgraded. So both workshops are being conducted in Chennai. That's why I request all the young MD candidates to do these 2 workshops, because they are the certificate workshops. So in case of any problem, you have a IEP intensive care chapters certificate along with you. So please percolate pediatric critical care amongst all general pediatrician also. And yes, we need to have dedicated intensivists who take care of your ICUs, like me, Vinayak, Dr. Ibor. I think it's 2008 onwards, I have not seen any general pediatric outdoor patient in my hospital, only ICU, ICU, ICU. So that much of dedication is to be there to become an intensivist. Thank you so much, Mihir, once again for calling me. Thank you so much, Ibor sir, for giving me opportunity to speak in front of you. He has been a stalwart which we have been looking when we joined the chapter. And Vinayak, I mean, he's my brother. I mean, there's no, I can't say. He's such a wonderful person. Thank you so much.
Thank you so much, sir, for your encouraging words. Next, I'd like to request our special guest, Dr. Binayak Patki, sir, to kindly say a few words.
Good afternoon, everybody. Respected dais and all senior pediatrician and pediatric intensivist and my colleagues. It gives immense pleasure to be in Kolkata, and this is, I think, 4th or 5th time. Mihir has called maybe 2017. I am coming for different activities. Always been a very enthusiastic and learning crowd, and would be very happy to interact in last 4 or 5 times. This was very short visit of maybe coming at just 1 hour, half an hour back and leaving. But this is maybe in last 5 years we are seeing this, following this scientific program of East Zone, and this we labeled this time as East Zone because from this year onward we have started, intensive care chapter has started regional conferences. We had the North Zone in Amritsar, then we have Maharashtra has come, then Kerala has one, then this is East Zone, and we are having maybe West Zone also, and South Zone is coming, our big national conference as Pedicriticon 2024. So chapter has grown in last 25 years in an immense way. We have created more than, I think, 500 pediatric intensivists, and they are doing excellent service here in India and abroad also. Flagship IIP's intensive care chapter is a very dynamic and vibrant chapter of Central IIP. We are always on front foot of putting the academics into the society and helping all peripheral pediatricians to improve their skills, like Manish sir has told about basic pediatric intensive care program where we developed in way back in 2007. Then essential pediatric intensive course was developed in 2017. Lot of ventilation workshops, simulation workshops. We have our webinar programs every Wednesday, where there is something for nurses also. From last 2-3 years, we started incorporating and giving knowledge to the nurses because they are backbone of our ICUs. So chapter is doing lot of things for the intensivists, nurses, as educational wise also as for the in the society wise also awareness program and all that. This is very good to have in from every year we are getting this scientific quality of program is getting upgraded in West Zone, especially in Kolkata. Just keep it up. All the best from Central IP Intensive Care Chapter about growth and whatever things are required for growth and academics related thing, faculty related thing for West Bengal chapter of IP Intensive Care Chapter. From again, I thank all of you for giving this opportunity to be here and the dais and keeping me as a special guest to be. We are very close to Mihir and Shubdeep, all Somen, everybody is Pravas, all are very close to us, close to the heart. Siba is there, Mukesh is there. Last year, few years back, they have conducted a nice conference. So thank you again, all of you, and best luck for next scientific programs which you had. Thank you very much.
Now I'd like to request Dr. Eber Jacob sir to kindly say a few words.
Good afternoon, everyone, and respected National Chairperson Dr. Manish Sharma and our Secretary Dr. Vinayak and all the dignitaries on the dais. And once again, thank you all for inviting us, especially the organizing team, Dr. Mihir and the team, for organizing a wonderful East Zone conference. And yesterday you had successful workshops as well. And Dr. Vinayak Bhakti has alluded upon about intensive care chapter activities. We have a separate college as such, but now we are merging with the Indian College of Pediatrics. But we have been one of the oldest to conduct these sort of academic courses, fellowships from the year 2003 onwards, and 21 years we have been conducting medical diploma in pediatric critical care and a fellowship. And for nursing as well as for technicians. So we are running these courses very well, and we have many fellows here who have passed out of this college, and we are going to the next step of merging with Indian College of Pediatrics and keeping the academics going on. So as Dr. Vinayak was saying, we are very active intensive care chapter in academic wise, and a lot of academic sessions has been done, and here I'm very happy to be here in this East Zone with a lot of academic scientific programs as we can see, and the enthusiastic participants. Thank you very much once again, and wish you all the best. Thank you.
Thank you so much. Now I'd like to request Dr. Tridi Banerjee sir. Sir, kindly few words of encouragement for us. Hello, hello.
Good afternoon, everybody. Dignitaries of the dais, I remember a few names, Dr. Patki, Dr. Manish Sharma, Dr. Ibo, forgive me if I've forgotten, and my very, very bright young friends. We had a dream, West Bengal had a dream in 2013 to convert a state with non-existing PICU facilities to a model one. Those who witnessed that story, they would remember. Now we are 120 plus PICUs. We started with, I think, a membership of 100 plus. And it went on and on. And this was mainly because of the very passionate youngsters, very bright, very hardworking, dedicated, and the able support of the seniors. And above all, the blessings of our Chief Minister, who provided the funds to convert a resource-deficient, depleted state to a model state. All I did to start with was to spot the raw diamonds, polish them, and turn them into Kohinoors. Mihir, Shubhadeep, Abhishek, Taposh Shabu, who is not here, Moitreyi, I can't name everybody, Devdatta. So this is what West Bengal has achieved and has been a model for transforming, and this transformation so rapid and so spectacular, so it's unbelievable, and we wish the chapter all success. I think every year will be a grander success, and wish them all success. Thank you.
Thank you so much, sir. Now I'd like to request Dr. Manish Sharma, sir, to kindly release the e-souvenir.
You just click here, okay? 1 minute.
This one, sir. This one. Yeah. Should I do this? No. Yes. Yes.
Everybody gives a young photograph while giving for a souvenir. I'm just looking at the photographs. Very good, yeah. Wonderful.
130 pages, I think.
Very good.
133 pages. Almost like a textbook.
So they have become, souvenirs have become almost extinct in the major conferences because nobody writes an article.
So, with more than 30 articles.
So I think it's wonderful.
All contributed by... Next, I'd like to request Dr. Vinayak Patki, sir, to release the second issue of Child and Newborn of our state.
The child is newborn is the...
I'd like to request Ibor, sir, to kindly join Vinayak Patki, sir.
The Child is Newborn is the official journal of West Bengal Academy of Pediatrics. So this is the, we publish it in the quarterly. So this is the second issue. Okay.
Thank you so much. We can have a photo with the journal. Can we please have a photo with the journal? Thank you so much. Now, kindly take your seats. Now we'd like to felicitate immediate past President, West Bengal Academy of Pediatrics, Dr. Kalpana Datto Madam. Okay. Next, I'd like to request Dr. Mihi Sharkar to felicitate Dr. Dhiren Gupta, the past President, IAP Intensive Care Chapter, and the past Vice Chancellor. Next, we'll be felicitating Dr. Prabhavati Banerjee Madam, one of the senior faculties and our teachers. Next, I'd like to request Dr. Abhishek Poddar to kindly felicitate Dr. Ranjana Chatterjee Madam. I'd like to request Dr. Prabhash Prashungiri to kindly felicitate Dr. Shati Chakraborty, Madam. I'd like to request Dr. Dibyendu Roy Chaudhuri to kindly felicitate Dr. Shopna Chakraborty, Madam. Now I'd like to request Dr. Shukanto Chatterjee sir to kindly felicitate Dr. Dilip Pal sir, the Principal, B.C. Roy Memorial Hospital. Next, I'd like to request Dr. Shantosh Agarwal sir to kindly felicitate Dr. Shomen Meur sir, the Chief Advisor, Society of Pediatric Intensive Care, Kolkata. Now I'd request Dr. Tridip Banerjee sir to kindly felicitate Dr. Moshumi Nondi Madam, the Principal, Midnapur Medical College. Now, I'd like to request Dr. Manish Sharma sir to felicitate Dr. Shubhodip Das, the scientific chairperson for this conference. A big round of applause for him. I'd like to request Dr. Vinayak Patki sir to kindly felicitate Dr. Joydev Roy sir, the Principal, Institute of Child Health, Kolkata. I'd like to request Dr. Eba Jacob sir to kindly felicitate Dr. Arun Mangalik sir. He's a very senior consultant pediatrician and our teacher. Next, I'd like to call upon the stage two young hearts, Dr. Rohit Bhomik and Dr. Kaushik Molik, the members of the scientific committee for the conference. Kindly accept our felicitation from Mihda. a big round of applause for them, for everybody, for working so hard for months and spending sleepless nights to make this day possible. I'd like to request Dr. Tidip Banerjee sir to kindly felicitate.
Who is the treasurer and very enthusiastic with conducting the whole management of the two halls tirelessly. একদম
Now, I'd like to request the organizing secretary for this conference, Dr. Prabhash Prashungiri, to deliver the vote of thanks.
Thank you, Nandini.
Now we are going to felicitate the immediate past president, West Bengal Academy of Pediatrics, and a teacher of us all. Kindly, ma'am, come up on the dais. I'd like to request Dr. Tidip Banerjee, sir, to kindly felicitate Kalpana, madam.
Thank you all. So at the last of this inaugural program, I'm here to say a few things. As Tridip Banerjee sir already mentioned that our journey of Pediatric Intensive Care Society of Kolkata has started almost 11 years back. And then now we have established a lot. And after almost 3 to 4 years of monsoon CME, for the last 3 consecutive years, we are doing East Zone Pedicriticon. I can remember that we have started the planning for this program almost 7 to 8 months ago with a Zoom meeting. And even 3 days ago, we have done the last Zoom meeting for this program. And this time we had a maximum numbers of delegates, almost 280 delegates have been registered. We have done the 6 successful workshops parallelly in the 6 different centers. We have done 2 workshops for the focus. And the workshops had been attended very well by all the delegates. This time the maximum number of abstracts have been submitted, almost 90 abstracts have been submitted. It was a very difficult task to choose few abstracts so that we can present it in the main conference. So all of this conference would have not been possible, and this hard work would have been possible without the constant encouragement of our patrons, Shukanto sir, Santosh sir and Tridip Banerjee sir, with the help of our IAP, ICC dignitaries like Vinayak Patki sir, Manish Sharma sir and Jacob sir. And for the last 1 month, we have worked hard to make everything perfect for this conference, but still we know that we are not finally perfect. I also express my sincere thanks to the co-organizing secretary, Dr. Dibyendu Rai Chaudhary. I also express my thanks to all the main part of the hall management of the program is going smoothly, to Monidipadi, Madiha, Nandini, Sayantika, Pooja, everyone, and especially to mention about Nandini. She did a wonderful job for the last couple of months. And definitely I want to mention the names of 2 persons present over here, Somenda and Ognishakar Saha. From both of them I learned the ABC of Pediatric Intensive Care. They have mentored me for the last 10 years and still mentoring me. And I also express my thanks to Abhishek Da, Shubhadeep Da for giving us the guidance. And I also specially mention the name of the two persons. My friend, Dr. Rohit Bhomik is there. He worked very hard for choosing all the abstracts and doing the smooth growing of this poster presentation and everything. And again, my big brother, my guide, my friend, everyone, Mihir Da is there. So without the constant help of the Mihir Da, this would have been not possible to organize this program. By this, I am concluding this inaugural program. Now we'll start the post-lunch sessions. And definitely we'll try to make it bigger in the next year as well. Long Link Pediatric Intensive Care, Long Live Society of Pediatric Intensive Care, Kolkata. Thank you.
So one person that I have to mention is the Mr. Rohit Mukherjee and his team. They have done wonderful job doing the all back's work, and my job and my headache and all the organizing team's headache, they have reduced so drastically that we have gone give some time to the other works. Last time I was so much overburdened, so much anxiousness in the last moment, but that this time we better very smooth work only because of this Rohit Mukherjee and his team. Big round of applause to them.
Thank you.
We'll start the post-lunch session at 3 p.m. Okay, we'll be proceeding with the scientific sessions. Sessions, we are having a panel discussion on monitoring a child in shock, old tools versus the newer fancy gadgets. We have with us Dr. Shubhendu Mondol, sir, to kindly chair this session. I'd like to request you, sir, to come up on the dais and take a seat. Sir is consultant pediatric cardiology, BM Birla Heart Research Center. He is a member of Indian Academy of Pediatrics, Royal College of Pediatrics, and Institute of Child Health Pediatric Cardiology Society of India. Has many national and international publications, and we are so happy to have you, sir, amongst us to chair this session. I'd like to request the moderator for this session, Dr. Shubhadeep Dash, to kindly come up on the dais. I'd also like to call the panelists. Dr. Priyavartini B, Dr. Nisha Toteja, Dr. Mukesh Jain, and Dr. Devdatta Mukhopadhyay, to kindly take your seat. I'd like to request the moderator, Dr. Shubhadeep Dash, to introduce the panelists. Before that, I'd request Dr. Shubhendu Mondal sir to give an introduction, a kind introduction. Dr. Shubhodip Das.
Hello, good afternoon. I think everybody is bright and fresh after your lunch. So it's nice. Shubhodip actually doesn't need any introduction. I know him for a quite long time. Very excellent pediatric intensivist. Now he's going to talk on monitoring a child in shock. We compare with the old tools and the special new gadgets. Thank you, Shubhodip.
Thank you, sir. I was hoping the participation would be thinner after the lunch, but it's quite heartening to see that the hall is quite full. So this session will be on how we monitor a child in shock. We have so many old tools that we know of, and now we have these modern gadgets coming in. So we will try to see a sort of comparative overview, and I have got an excellent and experienced panelist on my left. So Dr. Priyavartini, she's a senior consultant of PICU Apollo Chennai. Dr. Mukesh Jain, he is an associate professor of the Department of Pediatrics, KIMS, Orissa. Dr. Devadatta Mukhopadhyay, she's an associate professor of pediatrics at BC Roy Children's Hospital. And Dr. Nisha Toteja, who is an assistant professor and consultant pediatric intensivist at AIMS Guwahati. So welcome you all. So we'll start with a case scenario, so which goes like this. A 13-year-old boy who has a background of relapsed BALL and had a post-allogenic bone marrow transplant, now presents with fever for 4 days, along with vomiting, abdominal pain, and decreased urine output. The child is more or less alert and awake, and the heart rate is in 120s, capillary refill time slightly prolonged, blood pressure is maintained, respiratory rate, he's slightly tachypneic, and SATs of 93% in room air. He's got a pancytopenia, as you can see, got some bit of metabolic acidosis with a lactate of 5. He's got raised inflammatory markers, chest X-ray showing bilateral patchy opacities, and USG abdomen has been done at this point, which shows moderate ascites. So with this background, we can say that this child has got a short febrile illness with a compensated shock, because remember the blood pressure was normal, with multi-organ dysfunction. So likely with his background, probably has got febrile neutropenia and is in a septic shock, and there is some evidence of third spacing. So Dr. Nisha, you have this child in your ICU. I would like to ask you, how would you initiate your hemodynamic assessment, and at this point of time, what will be all the bedside tools that you would like to have in order to corroborate your findings?
So first and foremost is your bedside clinical assessment.
Right.
As we all know, even with the fancy gadgets, it cannot outweigh your clinical assessment. So heart rate is one of the most important parameters. You look at the child's heart rate, if there is any tachycardia. You look at the core and periphery temperature gradient. You go ahead and, like Ivor sir had said, you touch the feet of the child. You assess the dorsalis pedis, assess the peripheral pulse volume. You look at all these clinical parameters to have a basic idea about the hemodynamic status of the child. In addition, you should also never forget about urine output. Look for evidence of fluid overload in the form of crepitations, hepatomegaly, and also you can, obviously blood pressure is one of the most important features that help you decide whether the child is having compensated shock or an uncompensated or decompensated state. And gases, especially the lactate, can really help you in assessment of the tissue perfusion. And similarly, chest X-ray, POCUS, and echo, a basic assessment can give you a lot of idea about the various components of the hemodynamic status of the child.
Right. So we have so many newer tools, but we should not forget about our basic clinical examination. We should be very thorough and meticulous with that. And the important thing is that we should not be fixated on a particular number or sign. We should put everything into clinical context and then interpret our findings. So as you rightly suggested, at this point of time, we would get an X-ray. So X-ray, as I had already mentioned, was showing some bilateral patchy opacities, and POCUS was also done. So you would like to comment on
So
this?
just on eyeballing, this 4-chamber view, we can see that the chambers are grossly dilated and there is also impaired cardiac contractility.
Yes.
So these features are suggestive of LV dysfunction.
Yeah.
So the child may be having some component of myocardial dysfunction at this point.
At this point of time. So there is moderate amount of MR also what we can see,
Yes.
but some very enthusiastic PICU resident was pushing in at 10 ml per kilo fluid bolus at this point of time, as you could see. Lung ultrasound was done, which could where we can see a lot of B lines, and IVC was distended. So probably, as you said, yes, it could be a sepsis-related myocardial dysfunction, or there may be an element of drug-induced myocardial dysfunction because this child must have been on a lot of immunomodulators, immunosuppressants. So at this point of time, we just saw how we can globally assess myocardial function. Dr. Devdatta, can you briefly tell the audience how can you do a quick assessment of myocardial function on POCUS?
So conventionally, we do the ejection fraction and the fractional shortening in the parasternal views, long axis and short axis, and also in the 4-chamber view, you can see over there, there's a dilated globular LV and a dilated LA also, and it's not contra. We take the M mode across it, and this is the comparison between the severe dysfunction and the normal function. But one thing that is important to the recent research has come up is that it's not only the systolic function, but other areas of myocardial function that is affected. Namely, initially there may be a hyperdynamic action of the ventricular myocardium in response to the cytokines, toxins, etc., which is liberated in the sepsis. And there may be some dynamic LVOT obstruction as well. And that we need to think about adding fluids or inotropes, taking into account all these parameters. There may be also a component of diastolic dysfunction, and also we should not forget the RV. That is, the RV dysfunction is an important factor, especially when the components like mechanical ventilation or ARDS, when that comes into play, then it increases an afterload on the RV. So that also is affecting. Because the systemic vascular resistance, the SVR is low in a vasodilated septic shock state, initially the assessment of the ejection fraction may be normal also, but that does not exclude like a dysfunction state.
Yeah.
So
of course, if the units are fortunate enough to have a pediatric cardiologist at this point, we can get a lot more ideas, but then at least POCUS can give you some sort of basic idea as to what is your ejection fraction like, and looking at the heart, you can comment about the global function. So Dr. Priyavarthini, we have been using POCUS for the last many years now, and it has almost become like one of our third eyes in this sort of scenarios. So do you use POCUS as a hemodynamic monitoring tool in your unit, and how would you apply that in your clinical practice?
Yeah, so in a sick patient like this, invariably it is like, an extended clinical examination nowadays, we do POCUS, so it becomes a part of your routine actually. So we do use that, and very often, and we use it for repeated reassessments as well. And see, basically when we use POCUS, at least in the initial stages, we are looking at three things. Basically the IVC, the cardiac contractility, and lung ultrasound. So these are the things. So when you look at IVC, either you're looking at the absolute diameter and also the collapsibility in a spontaneously breathing individual and distensibility in a mechanically ventilated individual. There are adult cutoffs, which is 50% and 18%, and but we all, pediatric cutoffs are variable. But I would like to say more than these numbers, just look at, you can eyeball whether it is really collapsing or not. The only caveat I would tell is, if in a child like this will have significant respiratory distress, you can have a false positive collapsibility index even in the context of a significant myocardial dysfunction. So you need to be aware of that. If it is not collapsing, it's more valuable. If it's collapsing, you have to take it with a pinch of salt. So, and with regard to lung ultrasound, you need to look at look at B lines and effusions. And even though if the IVC is collapsing, but the lung ultrasound has B lines, I'll be very cautious about giving more and more fluids, especially in this child.
Yeah, exactly. So while it's a very essential tool, at the same time, we kind of have to be aware about the limitations also. This was, I don't know whether it's going to play, but yeah, I was just trying to show you how a collapsible IVC and a normal IVC would look like. But anyways, it's not playing, so I'm not going to. Anyways, So yeah, as you rightly said, that use as an adjunct and serial assessments, because these are like point of care tests. So serial assessments coming back to the patient again and again. After any intervention you have made, whether you have given a fluid bolus, started any inotropes, it's important to come back to the patient. Now check your cardiac function, check the IVC. So all these things have to be done again and again. So as we were doing POCUS, and as I had already mentioned that somebody was giving again some fluid bolus, see what now the status of the patient has become. Remember that he was initially alert and awake, but now the child has become more drowsy, with more tachypneic. There is a worsening of respiratory distress, there is a fall in saturation. FiO2 now increased to 80% on high flow. Remember his initial heart rate was 120, which has now become 150. His pulses are more feeble, capillary refill time has become more prolonged, and NIBP is like reading lower. So overall the child's hemodynamic condition has deteriorated, that's what we can say. So the child at this point was intubated, put on mechanical ventilation, and the heart rate remained tachycardic, his pulses were still feeble, he was on some adrenaline through a peripheral line, his blood pressure was still reading low, and he was oliguric. So at this point of time, Dr. Devdatta, we can see that the child is in shock. We have been able to start some adrenaline peripherally, but at this point of time, just with some adrenaline, just with the child being on mechanical ventilation, would you be happy, would you be sitting tight with these clinical parameters, or would you want other tools or gadgets at this point of time?
I think this is the time that we go all aggressive. We put in the invasive lines, because the invasive BP would be definitely a better marker of the actual blood pressure. And also we have to monitor the CVP for the volume responsiveness, and also the RA pressures and all. And depending on, we get a comprehensive view of all this, and then we decide on the fluids and the inotropes or pressures or vasodilators. Also there are some surrogate markers, or rather indicators of the low cardiac output state, such as the lactate levels if more than 2, and the difference between the arterial and the mixed venous saturations if more than 40%, and of course bicarb base excess, base deficit of more than 4. So those will definitely indicate a very low cardiac output state. And as is mentioned here, that we should not forget chloride, because we are keeping on giving sodium chloride as fluid. So also hyperchloremia may affect the interpretation of the ABGs.
Yeah, so definitely with the child having clear-cut deterioration at this point of time, putting in lines, starting inotropes, your choice might vary, but these are very important things, and then continuing with the higher modalities of monitoring. So Dr. Mukesh, we are used to assessing hemodynamic status. We have been doing this since many years by interpreting the arterial traces. Now I just want to briefly tell us about how would I assess our overall cardiac output by invasive blood pressure monitoring, what is the utility. And we know, like whenever we are monitoring invasive blood pressure, if you could go back to the picture, you can see like we are monitoring 3 numbers, right? Do you see all these numbers, or would you see just one number in invasive blood pressure?
So what will happen, like when you deal with such a sick patient with shock, hypotension and all these things, it is very important that we should put an arterial line. And invasive BP monitoring is the most important thing in such a sick child. So NIBP is very unreliable in such conditions. So all the 3 parameters, whether it is systolic, diastolic or mean BP, everyone is important. Suppose the systolic BP is very important during resuscitation. When the child came in ER, suppose you are resuscitating, we are giving fluid bolus, so to target is systolic blood pressure always. 70 plus 2 into age, we target many times. Similarly, in hypertension also the systolic BP is very important. Similarly, if you come to the diastolic BP, in septic shock patient, always diastolic BP is very low because of this systemic vasodilatation. So that's why the diastolic BP is very important. And similarly, diastolic BP is very important for coronary perfusion. So that's why diastolic BP should be given always very important to address this diastolic BP. Similarly, mean BP is, why mean BP is important, because every organ is perfused according to the mean arterial blood pressure. So you have to maintain your mean arterial blood pressure according to the age group, and that's why it is very important. Similarly, if you see the pulse pressure, so pulse pressure, once you resuscitate, you have started giving fluid bolus or inotropes, your pulse pressure should be normalized. So all the parameters, systolic, diastolic, mean BP and pulse pressure, everyone is important. And always it is important to put an arterial line to monitor the invasive BP, not NIBP.
Yeah. Very well said, very well said. Because I have seen many fellows who are just starting their ICU career, like not paying much attention to the diastolic blood pressure, but it's so very important for, especially in these circumstances where your myocardial function is already down, then your poor coronary perfusion, because that is what drives your coronary perfusion, diastolic pressure minus your CVP. So it's very important to be mindful about your diastolic blood pressure. So another important thing which Dr. Devdatta mentioned was CVP, your central venous pressure. But is it at all a good hemodynamic marker? And if at all you use it, what would be the fallacies, Dr. Nisha?
Yeah, so I would say CVP is not yet out, even though there are studies which question the reliability of CVP, especially in pediatrics. But I would say instead of again fixating on a number, we should focus on trends in CVP which give us much more valuable information about the fluid status of the child rather than a fixed number. The number, if you look at, maybe in a single digit number is considered normal, and anything crossing a double digit would really raise some red flags as to what is happening and whether the child is really requiring fluids or not. So I would say that one of the component of hemodynamic status is CVP, but then you should interpret it with caution. It tends to be a static marker of intravascular volume. So if your child is on the rising phase of the Frank-Sterling curve, you give a fluid bolus and you will see there will be a transient increase in CVP and there will be an improvement in the blood pressure as well. So those are fluid responders. But then there will be others where you see a sustained rise in CVP, which does not really translate into improvement in the hemodynamic status. Rather, they would be worsening. So those will be the ones which are not fluid responsive, and then there would be others who have a marked rise with clinical deterioration. Those will be the ones which are fluid intolerant or fluid unresponsive. So the fallacies would be CVP is very prone to lots of pressure changes occurring in the thoracic cavity. So high CVP may be observed in conditions like right heart failure, high PEEP settings. If your child is having ARDS, is requiring a lot of PEEP, then CVP may not be that much reliable. Then there would be other conditions like cardiac tamponade, constrictive pericarditis. All these things will tend to give fallacious readings in these settings. Similarly, low CVP can be observed in hypovolemic states. They can also be observed in any condition which leads to hemorrhage and decreased intravascular volume status.
Yeah, exactly. And of course, mechanical ventilation, especially in the setting of a very bad lung, that also can translate to having a very high CVP. So that is also something we have to keep in mind. And this would probably apply to your both arterial blood pressure as well as CVP. Zeroing the transducer and keeping the transducer at the appropriate level, like phlebostatic axis is what we say, that is also very important. So, so far what we have been discussing has been sort of more indirect assessment of cardiac output, and but then more important I feel is to really judge whether our cardiac output meets the demands of the body, because ultimately the management of shock is adequate oxygen delivery, right? So do you have any ways of measuring, of having an idea about your oxygen delivery to the tissues? Is there a way at all?
So SCVO2 is one of the markers which can help us assess the regional perfusion or how much of an oxygen demand.
Venous oxygen saturation.
Yeah, how much of oxygen is really reaching at the tissue levels. So in normal conditions, body utilizes about 20 to 25% of oxygen. So the arteriovenous difference would be around 70 to 75%. So the veins will be having oxygen saturation, especially the superior vena cava, SCVO2, which can also be used as a surrogate marker of SVO2, which is what we get as a mixed venous saturation when we measure it in the pulmonary artery. So which is not feasible in most conditions. We use the central venous lines, and through that we take the SCVO2, and that is used to assess the oxygen delivery status, the oxygen balance status, I would say. So as the oxygen delivery decreases in shock states, the tissues now are deprived or hungry for oxygen, so they tend to extract more. So the oxygen level returning in the venous circulation will be much lower. So SCVO2 will be less than 70%. So that can give us an indirect idea about the imbalance that is happening at the level of oxygen status to the tissues.
Exactly. So SCVO2, like a mixed venous oxygen saturation or central venous oxygen saturation, what we measure actually in clinical practice, can be a very important surrogate marker to your adequacy of hemodynamic function, adequacy of cardiac output. As you rightly said, as the oxygen delivery decreases, your body gradually goes into anaerobic metabolism. So in that context, I'll just like to add a couple of lines about lactate. So why this trend of mixed venous is important? Because your mixed venous saturation, if you start measuring it, say in somebody who has got an arterial oxygen saturation of, let's say, 97%, you are getting a mixed venous oxygen saturation of 50%, let's say. Your lactate might still be normal, might still be less than 3, but what you have to be aware of is that this child, if allowed to go in this way, will gradually go into anaerobic metabolism, and your child might start to have high lactate. So it's important to intervene at this point of time. And there are some ways of continuous SCVO2 measurement. We do not routinely use it, but in some of the very sick patients, like some of the children on ECMO or some of the post-cardiac surgery patients, heart transplant patients, we can use this. So this is just to show you the monitor picture of such devices. Those devices are existent where we can have a continuous idea of our mixed venous saturation. So this was what I was trying to make a point on lactate. So lactate is another surrogate marker of your cardiac output which we can use, and we just have to make sure that we obtain it from a reliable site like a central vein or an arterial line. We, as a beginning, we can use peripheral lactate, but we have to make sure it's a free-flowing sample, and your tourniquet time is typically less than 60 seconds. And usually what we try is for a lactate of less than 3 or less than 2. And we have to be aware about some of the other conditions other than anaerobic metabolism which can cause hyperlactatemia, like body can have other mechanisms, catecholamine excess, there can be type B lactic acidosis. I'm not going to go into details, but it always does not mean inadequacy of oxygen delivery. We just have to be aware of that. So again, reiterating the same point that you have to put everything into a clinical context. Just because your lactate is high does not mean that oxygen delivery is poor. I just wanted to show you this picture of cerebral near. Some of you may be acquainted with this device. So it's a measure of your tissue oxygenation, because I also work in a cardiac unit. So in some of our patients we use this device. So basically what this device measures is a tissue oxygenation of wherever this probe is put on. So in this child, the probe has been put on the around the brain area. So basically what it is measuring your cerebral oxygen saturation, tissue oxygen saturation. So there are some evidence that it kind of closely is a surrogate marker of your, I would say a surrogate of your mixed venous saturation. So NIRS stands for near infrared spectroscopy. As you can see that your cerebral near here is reading 61%. So it could be that mixed venous oxygen saturation is probably 61%. So there is some evidence that it closely correlates mixed venous saturation. So coming back to this child is now quite sick, is now on adrenaline of 0.1, noradrenaline of 0.1, still tachycardic, still hypotensive, cool extremities, CVP slightly on the higher side, urine output still low, and is having a positive fluid balance. Still you can see that has got a metabolic acidosis with a lactate of 6.5. The mixed venous saturation is of course 48%, so there is a wide arteriovenous oxygen saturation difference. So, so far, Dr. Priyavarthini, we have been using different surrogates of hemodynamic adequacy, but now this child we know is quite sick. Do you want to have a more direct idea of your cardiac output? Are those devices really existent, and do you think those are really helpful?
Okay, so with regard to, so far we have had a lot of monitoring devices, and this child is still in shock, so it may be okay to consider cardiac output monitoring device. So there's a whole list of monitoring devices available on the market, and there are some of them are invasive, some non-invasive. Some measures cardiac output intermittently and some continuously it measures. And so echocardiography, transthoracic, transesophageal, and you have dilution techniques, lithium dilution, then transpulmonary thermodilution, bioimpedance, bioreactants, transthoracic Doppler methods, esophageal Doppler. There's a whole list. But to be honest, each has its advantages and disadvantages. What I would think is, whatever tool is available in your setting, it's best to have an idea of that particular tool's advantages and limitations because each comes with its own problems. And especially when you have this kind of devices, you have a whole lot of numbers which which you get in the bedside. As such, we are confused about how to interpret all the other numbers which are already available. And on top of it, we have some more numbers, and it is very difficult to interpret at times. Having said that, if I'm stuck to the corner in a patient with refractory shock like this, if I have a tool, I would put it on. I would monitor all the numbers, but I would try to put it all into, kind of how you do a puzzle. So like that I would do, and I would look at the trends rather than looking at the absolute numbers. So my personal choice would be to do ultrasound based methods, because POCUS is usually available, so we can measure cardiac output through our normal echo machine or your bedside ultrasound machine, and it also gives structural, functional, and information, and also you can repeatedly measure whatever you want to do. So that would be my first choice. It is non-invasive, easily available. The rest of it depends on the center and expertise that is available.
Yeah. So yes, as rightly said, it's totally your choice, but you have to be familiar with the device, whatever you are using, and you have to know like how to interpret the numbers. And there are some devices that like the cardiac centers may use, like invasive cardiac output monitoring, typically not recommended even in such a sick patient, but of course it has its role for post-op cardiac scenarios, trauma, burn patients. So those are the typical patients. We talk a lot about this method, transpulmonary thermodilution technique, LITCO would be a typical technology, but again we need to know that for rapid cardiac output changes, this is not quite appropriate, and you have to keep calibrating this with your pulse control analysis. So every device comes with its own disadvantages. So however much these companies come to us with different devices, ASCOM, bioreactants and whatnot, we have to know about the limitations. Dr. Priyavartini mentioned about we could have an idea about a cardiac output with this ultrasound. Could you recommend one of the methods, describe one of the methods, how can we do that?
Yes, it
Dr.
is
Devdatta?
a very, though it sounds complex, looks complex, but when we
Yes.
do it, it's actually quite easy. And we take a few views. Can we go to the views? Then it will be easier to demonstrate. These are the views that we take. The LVOT view, as we were discussing in the POCUS, and we are finding out the area of the aorta. That is,
So
the
this is
aortic
what-
annulus
yeah.
is there. And how do we remember the class 7 pi r square is the area of a circle. So correctly or incorrectly, assuming the aortic annulus to be a circle, we say that pi r square with the aortic radius of, that is half the
This is what,
diameter,
we want
aortic
to
annulus is the
determine,
area,
yeah.
and that multiplied by the flow across it will give us the the stroke volume. The flow will be the VTI that is traced in the pulse Doppler. We have put the pulse Doppler point at the level of the aortic valve in the 5-chamber view, and we have got this droplet tracings over here, and this shows the velocity time integral, which is actually, it is showing the flow of any point across that annulus. So this multiplied by the VTI multiplied by the area of the aortic annulus will give us the flow across the aortic annulus, which is nothing but the stroke volume.
Yeah. And then you multiply it by heart
Then
rate,
we
you get your
multiply by
cardiac
heart
output.
rate and we get the
Yeah,
cardiac
again,
rate.
however much complex it sounds, the only point that I wanted to drive in was it is doable. It does not require a pediatric cardiologist or a cardiologist. It is doable if you are well trained in POCUS. But yes, it has its own fallacies. We are not going to talk about that. But in these 6 scenarios, you can try and have an idea of your direct cardiac output. But again, it only gives you a snapshot. So again, after any intervention, intermittently you have to come back and recheck. All right, so another important concept which I wanted to talk about in this context was about fluid responsiveness. So we are just going to leave back the previous scenario, talk about a different scenario. So this is a 5-year-old child with septic shock and mild respiratory distress, and we gave a 5 ml per kilo fluid bolus, and his initial BP was 70 on 40, which increased to 80 on 60. The heart rate actually went up from 160, it went up to 180. Cap ripple time remained the same, and there was some worsening of respiratory distress. Ultimately, the child needed intubation. So the question is, in this scenario, is this fluid responsiveness? We see the BP going up, but the child became tachycardic. So what are the tests for fluid responsiveness, Dr. Mukesh?
So in in ICU, when you see such patient, now always like many times we are confused whether to give fluid or not, whether this child actually require fluid or not, and whether after giving fluid how is the response. So either there are two ways. Either you can give a small fluid bolus and see the response, how is the heart rate, how is the BP is moving. Suppose you have given a bolus of 5 ml per kilo and you see that the heart rate is decreasing from 160 to 150. So you might interpret as that like the child is maybe fluid responsive. And the other way, you cannot give fluid, you just do some maneuver like passive leg raising test. You do the maneuver and you see the response. So what will happen, like after passive leg raising test, there is some amount of blood is moving to the heart, and it might be like the child heart rate may come down from 160 to 150 or little bit reduced from the baseline. So you interpret that child may be volume responsiveness. It is not 100% confirmed. And again, you have to see this pulse pressure variation. If the pulse pressure variation is more than 13%, again that indicates that the child may require fluid and fluid responsive. So this is the way to actually tackle whether this fluid is required or not in sick child.
So this is not entirely related to cardiac output monitoring, but this is one of the very important concepts which I wanted to drive home. So that is why we brought this context up, how to actually judge whether this child needs fluid. So what we saw in the entire journey of discussion so far, so many modern gadgets that we are having every day, and every day some company or the other would come to you coaxing that no, we have got a new method and it will give a better idea of cardiac output than the other device whatever you are using. But the point is that it's important to blend your tradition and innovation. So however many you have in your hand as new cardiac output monitoring devices, you cannot forget your clinical examination. Simple things like invasive blood pressure monitoring in such a sick child, simple things like monitoring your systolic blood pressure, diastolic blood pressure, MAP, perfusion pressure, simple things like your clinical examination and CVP, lactate, mixed venous saturation, they can give you a whole lot of idea. Using your POCUS, using your echocardiography can give you a lot of idea. There will be newer devices like the non-invasive ones, ASCOM, bioreactants. There will be invasive devices, pulmonary arterial catheters where you can measure your cardiac output directly. But you will have to blend you cannot forget your old traditional methods, and you cannot just jump onto newer methods. And remember, like whatever newer devices you are using, you have to master your tools. You have to remember about what are the limitations they come with, and you have to know how to interpret the data that they give you. What are the numbers? What are the numbers that this monitor gives me? Do I know the meaning of these numbers? It's also important that you monitor the trends. There are many cardiac output devices which will give you intermittent snapshot numbers. But we always try to see the trends, continuous trends of these children. And ultimately, what I would like to say is hemodynamic monitoring is like a puzzle. And you have to put in so many pieces of puzzle together, then only you will get the entire clinical picture. With that, I would thank my panelists. I think we finished before time. Thank you very much, and thank you for your patient hearing.
Thank you, Shubhadeep. So, do we have any questions from the audience, or to our panelists or Shubhadeep? No questions?
I think we saved
your time which we had lost, we had saved here. Okay. Thank you, sir. Thank you, sir. Thank you all the panelists. I request you all to please go to the felicitation center and get your mementos. Now, after the panel discussion, let's go into the debate session, restrictive fluid versus liberal fluid. I would like to invite the chairperson, Dr. Pravati Banerjee. She is the former president of West Bengal Academy of Pediatrics. She is a former professor of Pediatrics, Medical College, Kolkata. And she is the president of Juvenile Diabetes Research Association. And Dr. Rohit Bhaumik, Dr. Krishanu Mondal. Dr. Rohit Bhaumik will speak pro, and Dr. Krishanu Mondal will speak against it. I would request ma'am to kindly introduce the speakers.
I first thank the organizers to be invited in this important session. As a senior pediatrician, I can share my experience that I was present as a teacher when there was no concept of critical care. Then actually the critical care concept has come. A revolutionary change, I can say, occurred in this era, and today I can say that this evolution or evolutionary change for this critical care has started when there is a concept of PICU and NICU. And now today we can see that how we are saving the life of children, and each and every emergency admitted children require a intensive care therapy, of which this session is very important, because this fluid therapy, which is the mainstay of life-saving measure in a critical care, is changed also, and this is really requires a discussion about its advantages, disadvantages, many things. So this is a debate session where we can learn this. In our time, we know that only replacement of fluid is necessary. What is lost, that is to be replaced. And now the concept is totally changed, because we have to continue IV fluid for a long time. It is not only replacement, it is the resuscitation, routine maintenance, then replacement, then redistribution and reassessment. We require so many long process, and every moment we has to monitor the patient. And every step there are some different types of fluids, different amount of fluid, everything is. So I think that this debate is based on these advantages and disadvantages. It is not a debate, rather a discussion. So first of all, I invite Dr. Rohit Bhaumik. He has done his qualification from NRS Medical College, as I know him from that period, and MD from PGI Chandigarh, DM Pediatric Critical Care from JIPMAR, and NB Pediatric Critical Care. Present designation, he is in Assistant Professor in AIMS Kolkata, and his major achievements: PCCM Award for Trainees and Early Investigators, World Federation of Pediatric Intensive and Critical Care Societies 2020, World Congress Award for Best Presentation at the Critical Care 2020, Indian Society of Critical Care Medicine. And he has got a publications grant at the WFPICCS, I don't know the whole, okay, 2020 World Congress, more than 20 publications in international and national journals in this young period. So I invite Dr. Rohit Bhaumik, please start your, and he will tell the in favor of the debate. Okay.
So thank you. Thank you, ma'am. It is my privilege to get introduction from my teacher of MBBS time. And since morning we have a friendly atmosphere, friendly academics who are going on. And the first time we are in a fighting mode. It is a debate, a fight. Obviously it is an academic fight, not the physical one. So we have nothing to disclose. We will have time for discussion also. So why this topic is important? I always believer of liberty, but not in the topic of fluid, because remember, liberty is good, but we have to be very, very aware in that area where we are liberal. Similarly, in this hall, though it is post-lunch session, many people left. So how many of you actually practicing or you believe that restrictive fluid is important? Please raise hand. Please raise hand. Please raise hand. So see the response. The hall, everybody is in the belief of restrictive fluid. So I think the slide should be finished here. I can save 8 more minutes because no question of debate comes. It is restrictive fluid. Yeah, so if sir has saved 9 minutes, I can save 8 minutes of my talk. But let's see, because we are in the era of evidence, era of the guidance based. As all of you agreed, similar survey happened and published in 2024 by Intensive Care Journal, and it is one of the best journal in intensive care medicine. And they found a survey what the people globally is doing, And the same as the audience of our experts of this room, they found that almost 80 to 90% are people in belief of fluid restriction. And restriction they did mainly during maintenance fluid. And also they practice aggressive fluid removal after the stabilization phase is over. So a few basics where we do use fluids in day-to-day practice in PICU. As a maintenance fluid, if the patient is NPO, patient is not able to take orally because of multiple issues, perioperative period, in a mechanically ventilated patient, and in resuscitation of septic shock. These are the areas where still dilemmas are there. What we won't discuss or we won't debate is the top fluid therapies in these four diseases where it is already article based and established. There is no need of any further discussion because these are already established. So we will discuss on resuscitation and maintenance fluid and the controversies related to this. Regarding the basics of these indications, we need fluid in resuscitation phase, replacement phase, maintenance, and nutritional fluid. Dr. Vinayak sir has discussed this rose concept. But in this photo, if you see, as the time progresses, the rose is drying. But remember, a dry rose is not in this a dying rose. It is a lively rose. So if a rose is fully watered, won't be live one. Though it may be beautiful like that, but a dry and beautiful rose is actually the lower one. So what is this rose concept? It starts with resuscitation. If you see, even if resuscitation, we have to be a bit of restrictive. If hypotension is there, if ICU is there, you give 40 to 60 ml per kg. In our older days, push, push, push. Now push concept is lost. So if ICU is there, you have to give 40 to 60 ml per kg. If no, 40 ml per kg of bolus, even in resuscitation of septic shock in 1 hour. So this is R for resuscitation phase. Then your optimization phase where you are rescuing the organ, maintenance fluid, your target is avoid fluid overload, maintain a neutral balance. S for stabilization, here your focus is organ support, late conservative fluid management. And the last E for evacuation. Once your organ is fine, organ support is over, you start late goal directed fluid removal. So the concept of ROSE. Remember, since beginning of our career, we always in the concept of hypovolemia is bad, but hypervolemia even worse. It causes disturbation in oxygenation, it causes pulmonary edema, intra-abdominal pressure increases, disturbed wound healing, so on and so forth. So much bad things are there with hypervolemia. So, concept we discussed. Now, in the era of evidence-based medicine, all of you ask, where are the evidence? Yes, plenty of evidence. Recently, last year, published by our PGI seniors, restricted fluid versus liberal fluid in a mechanically ventilated child. What they found? The crux, restrictive group has significantly lower amount of fluid in the first 5 days, significantly higher ventilate free day, PICU free day. So everything is fine in this group in a mechanically ventilated patient. More evidence? Obviously, we are interested on meta-analysis, systematic review. So this is published in just last year. They observed almost, they have taken 9 studies, though the studies are observational studies because it is difficult to do RCT in this topic. So children with fluid overload had higher mortality, children with fluid overload require more mechanical ventilation more often. So in conclusion, more than equal to 20% fluid overload are associated with bad prognosis. So multiple evidences are there. Again, you may debate, my colleague may debate, these are observational study. Exactly, these are observational study, but this gave us the future steps of RCT. And already it came, the protocol of that RCT is published, and they are doing the same thing. They are combining, they are checking this in the RCT, restrictive group versus liberal group. So soon you will get, maybe the next year, this topic I will include the result of this one, the RCT. So in summary, fluid is a drug and has to be used judiciously. We can't be liberal in this. Excessive fluid is detrimental. Enough evidence, physiology is there. Enough evidence suggests fluid overload increases mortality. Worldwide, As in our group also in this hall, everybody agrees that restrictive fluid is the choice, not liberal. So I have finished my agenda. So now I think my colleague will come, and if something is there, again I will come for rebuttal. Thank you very much.
Dr. Krishanu Mondol. He is the at present consultant pediatric intensivist in the Mission Hospital, Durgapur, and he has done his MD from Lady Hardinge Medical College, New Delhi, and FNB Pediatric Critical Care, Monipal Hospital, Bangalore, and he is also from National Board Affiliated Pediatric Teacher, published many articles and study in
physiological way to increase the cardiac output is to increase the venous return. How to increase the venous return? By increasing the systemic filling pressures. So if you can increase the venous filling pressures, you can increase the venous return and you can increase the cardiac output. And the most logical way to increase the venous pressure is by giving fluids. Okay? So there is no doubt about that you have to give fluid to this child to increase your mean systemic filling pressures. Okay, is there any evidence of it? Ample of evidence is there. This is a landmark trial, EGDT trial. It is published in 2001. It has recruited thousands of patients with septic shock. And what they have found, in treatment group, they have followed a strategy. They have followed a protocol. In this protocol, they have given 500 ml bolus in adult patients every 30 minutes until they reach a CVP value of 8 to 12 millimeter of mercury. And what they have found, in treatment group, they have a 16% less mortality. So the treatment group, they have received 5,000 ml of fluid bolus compared to this control group who has not received too much boluses. So the treatment group who has received boluses, they have got 16% lower mortality compared to the control group. There are other evidences. This is observational studies from adults. This is pediatric observational study. All they have found that in septic shock children or any shocky low perfusion kind of scenario, if you don't give boluses, adequate boluses in first few hours, first 1 hour, then this child is going to die, his mortality will be increased. Okay, so then why so much doubt? Why so many people are in favor of restrictive fluid, and why there is so much talk about restrictions and less fluid boluses? Because of this trial. This is FEAST trial. This is published in 2011 in the patients are from the East African areas, and what they have found that the patients who have received boluses, they have got a higher mortality compared to the patients who have not received boluses. This is a very famous trial, FEAST trial, and all this understanding of restricting fluid has come from this study. But look at the population of this study. 57% had malaria. Do our patients, 57% patients have malaria in our cases? 32% had moderate anemia, and 41% children, they have a CFT less than 3 seconds. So we don't know whom they have included in this study. So based on this study, and the hypotensive children, they are not included in this study. So based on this study, from the finding and informations of this study, we cannot conclude that the fluid bolus is not needed. We cannot extrapolate this thing in our patients. So that's why our Surviving Sepsis campaign still endorses without any doubt that within 1 hour, if a child comes with you with septic shock, you have to give boluses, and that is up to 60 ml per kg. There is no doubt about that. Okay. Now, come to the next point. This Hasim is now, after 3 hours of getting resuscitation, he is in PICU now, intubated, he is having dopamine. He is still having low perfusions kind of scenarios. So he has received resuscitations with 40 to 60 ml per kg. Now he is in PICU. He is still having some low perfusions. So will you give boluses now, or will you follow a restrictive strategy? Let's come to some landmark trial that is published in adult actually. In pediatric there is no literature, but in adults. See this classic trial. This is published in 2021. What they have found, this post-resuscitation patient, after they have got resuscitations, they have randomized these patients in 2 groups. One group liberal, one group restrictive. several, this is a multinational European trials, not a small single center trial. This is a multinational European trial, okay? And in liberal group and multiple, 1,000 patients they have included. So 3,800 ml in liberal group and 1,700 ml in restricted group. And there is no difference in mortality or any other secondary outcomes. And not only this study, this is Clover's trial. They have taken septic shock with hypotensive patients. And as you can see, there is a difference between these two groups, but there is no difference in mortality or any other outcomes. So where is the evidence? Exit poll is there, but where is the evidence of restricting fluid? There is no evidence. So that's why in surviving sepsis guidelines also they have recommended in this stage probably you have to use advanced hemodynamic monitor, as Dr. Shobhadi was discussing. Probably after this post-resuscitation phase, in first 24 to 48 hours after that, after they have got a resuscitative bolus, probably at this time to give fluid, you have to do advanced hemodynamic measures. But restricting fluid at this stage, not recommended. If the child requires bolus, if he is having low perfusions, you do hemodynamic monitoring, you do advanced hemodynamic monitoring, and see whether the child requires bolus or not. If he requires bolus, if he requires more fluid, you have to give it. Okay, come to another scenario. 8 years old child presented with abdominal pain and appendicitis. He is going to be operated. So this is a perioperative kind of scenario in appendicitis, abdominal surgery. Will you give fluid boluses? Will you have a restrictive policy or liberal policy? Again, come to this, there are a lot of controversies in abdominal surgery, liberal versus restrictive. As you can see that there are theories, hypotheses that if you give more fluid, there is a loss of glycocalyx layer, endothelial layer damage and all these things. So it may lead to abdominal compartment syndrome and all these things. But look at this meta-analysis. They have included 18 studies, 6,000 patients, major abdominal surgery, 18 studies, 6,000 patients. It's not a small study. What they have found, there is no difference between restrictive approach and liberal approach. Absolutely no difference. And a subgroup analysis you can see. In subgroup analysis, in restrictive patients, restrictive fluid patients, they have got more kidney injury. Major renal adverse events, that is more in the restrictive fluid group. In operations, they are losing fluid and you are not replacing that fluid. That's why these patients have got kidney injury. So restricting fluid in these scenarios are not only not have any effect, but it may cause injury, it may cause problem. And look at this plasma biomarker. So they have taken endothelial glycocalyx samples and injury markers, and everything is similar between these two groups. Is there any other harm of fluid restrictions? Everybody we can restrict fluid. We can give 25% maintenance, 50% maintenance. Any other problem with that? Nutrition. How will you maintain nutrition? There are a lot of debate and kind of discussions going on how to give nutrition to the critically ill children. If you restrict fluid, how will you give nutrition? Okay, there are many studies they have come out, and they have concluded that the major barrier to provide nutrition to these critically ill children is restrictions of fluid. Okay, even in cardiac ICUs, where there historically we restrict fluid to 25% or 50% of the maintenance, and lot of data are coming up that in these cardiac patients, post-operative cardiac patients, they have a severe nutritional issues. And most of the units now are thinking of liberalizing fluid, 75 to 100 ml per kg in 3 or 4 days. They are trying to give to provide adequate nutrition. As you can see, we all agree that fluid overload is a problem. There are evidences, I will not disagree with that if the child is fluid overloaded in 4th day or 5th day of ICU stay, there is increased mortality and morbidity. There is no doubt about that. But the cause of fluid overload is not extra fluid he has received. Cause of fluid overload because his kidney is not working. He's got sepsis. He has got a lot of inflammations. His endothelium is damaged. That's why the fluid is retained in his body. It's not because I have given too much fluid. If you give small amount of fluid also, he will go into the fluid overload because of other pathologies. So you have to address these inflammations, you have to address these sepsis, you have to address these kidney problems. Then only you will get rid of this fluid overload. Only restricting fluid, that will cause nutritional issue, that is called your perfusion issue, and that is cause all the problems. To conclude, while there are many hypotheses and physiological rationales behind fluid restrictions, evidence supporting these restrictions remains insufficient. Fluid restrictions, especially in first few days, can lead to inadequate perfusions and sometimes lead to decreased survival. Overly stringent fluid restrictions can result in a state of low nutrition, depriving the body of necessary sustenance for optimal health and functioning. Thank you.
I thank both the speakers. They have given their opinion. Now what I can say in one sentence, that when a child admitted in a shock stage, I think it is the first thing to resuscitation of that child. After that, you have to think about the etiology and then the pathology of fluid collection and everything, and you have to decide. So it should be individualized, what I can feel. Both of you have given a very good idea about this. So any question from the audience?
Rebuttal.
Rebuttal, 5 minutes for rebuttal.
Not 5 minutes, I won't take.
Okay.
Yes, ma'am. Ma'am, as you highlighted that we have to be careful regarding the situation, which patient and which phase we are dealing, and in that way we have to be careful. Not we should not be restrictive also, we should not be liberal also, we have to optimize. So we started as a fight, but let's end in a friendship way. And let's take message. I think both of us will agree that you use the fluid carefully. Keep it as a fluid stewardship. You discuss antibiotic stewardship. We are very cautious about antibiotic. But take home a point of fluid stewardship also. Remember, fluid is a drug. You have to identify why you are using, how much dose you are using, how long you want to give that dose. Then once your target is achieved, like your therapeutic goal is achieved, you start de-resuscitation. You think about optimization. So my point will conclude like that. Okay, we'll take it as a ideal or a case-oriented or situation-oriented fluid therapy, not purely restrictive or purely liberal. Thank you.
I completely agree with him. The fluid as a drug we have to use, and whenever a patient needs a drug, we have to give it. Okay? If the patient needs fluids for the nutritions, for their perfusions, we have to give it, and we have to keep in mind about the fluid overload. We can restrict fluid in case of in drug dilutions and all these things. We have to be very mindful about what amount of fluid we are giving in medicines and in other measures. And obviously, what we have to think of, if the child is fluid overloaded, that is bad, and we have to take care of that by renal replacement therapy, by whatever diuretics. We have to de-resuscitate, and you have to, whatever fluid is accumulated in the body, we have to kind of come out of that. But the fluid management should be individualized, and if your patient requires fluid, do not hesitate to give that. Okay? Thank you.
Thank you, ma'am. Thank you, sir. I request the speakers and the chairperson to kindly collect the mementos from the felicitation area. Now coming to the end of our day-long academic feast, this is the last session, Pediatric Toxicology in a PICU, a case-based approach. For this, I would like to invite the chairperson, Dr. Shukanto Chatterjee. I would like to invite our chairperson for the session, Dr. Shukanto Chatterjee. He is the chairperson for Adolescent Health Academy, organizing chairperson of the Adolescon AHA, IIP 2022. And he was a former professor and HOD of Pediatrics, Kolkata Medical College. I would like to invite the moderator, Dr. Mihir Sarkar, the panelists, Dr. Guru Prasad, Dr. Shivaprato Patnaik, Dr. Govinda Mondal, and Dr. Pradeep Kumar Jana. I would request our chairperson to kindly introduce our moderator.
Good afternoon. Well, it's a privilege for me to introduce Dr. Professor Mihir Sarkar. I have seen Mihir from his postgraduate days. He did his MD under me. And I have seen from the very first year, Mihir was very polite and also sincere. And subsequently, I have seen Mihir acquiring many skills, professional skills, and also a skill of communication. What I understand now from the different forms of reports that's coming, inputs, that he is a very good organizer and a very popular, I should say, amongst the colleagues also. I am very proud of you, Mihir. You please start this session. Thank you.
Thank you so much, sir. So it is my honor, I feel honored that I get the introduction from you. As my guide, my teacher, my all the aspects, you have been my guide and the driving force. Going to the pediatric toxicology in PICO case-based approach. So I'm Dr. Mihir Sarkar. And I must thank our hall management team, Nandini, Madhya, and Monidipa, because this is the last session, but we are maintaining almost the time. So we're dot in time. So thank you for maintaining the time. And we have the esteemed panelist, Dr. Gobindo Mondol, who is the PISU in charge of one of the busiest PISU in West Bengal, that is Dr. B.C. Rai PGIPS. And we have Dr. Pradeep Kumar Jena, who is one of the pioneers of the pediatric intensive care in Odisha, and the professor and the of pediatrics at SLN Medical College, Koraput. We have Dr. Guru Prasad, very young and energetic intensivist, and who has started the PISU and single-handedly managing there at the VIMS and the Institute of Kolkata. And also we have Dr. Shivobroto Patnaik, my good friend from Odisha. He is the PICU consultant of KIMS Bhubaneswar. Now he is busy in managing a patient with acute liver failure in another hall. So he will be joining very shortly after managing this patient with acute liver failure. Okay, so let's start with this thing. So what is not a poison? Because everything that's just now we have heard about the debate on fluid. So if you get the fluid in excessive amount, that can also lead to toxicity, that can a lot of side effect. Any drug that we use in ward or maybe in ICU, if we do give in appropriate dose, inappropriate, and give it excessively, that will lead to various health-related effect and correlates to the toxicity. So everything around us, if given inappropriately, then it can go to the poisoning. So let's start with a case, as has been, a topic has been case-based approach. So this is our institute, this patient was admitted. 8-year-old Muslim boy attended a marriage ceremony and sudden episode of vomiting, and for several times he had the GTCS 3 episodes and presented with the labored breathing. In the ER, in the primary assessment, EROA was not maintainable. Breathing, he was tachypneic, tachycardic, and the desaturating at 85% with NRBM 10 liter. Circulation-wise, he is a tachycardic, but the blood pressure is maintained at that moment. And the disability-wise, he has a poor GCS. You can see there's a 5/15 only, and pupils are sluggishly reacting to light. On exposure, there was no petechiae, no skin rash, no bleeding. So this child was very sick. You can see physiologically the not maintainable airway with the respiratory distress and poor GCS of this patient. So we started the patient on the ventilatory support because patient requires the intubation and ventilatory support, required the IV bolus, required antibiotic, anticonvulsant was started on the levetiracetam and midazolam. We started giving a patient on the ventilator support. Even with the optimum support, what we found is that the saturation is still at the range of 85%, and the blood drawn in the EVG shows the color was brownish. So this is an odd, very normal, healthy child presented in a very sudden episode of deterioration while attending a marriage ceremony. So going to this history, so I'll ask to know from the Dr. Gobindo Mondol, can it be a case of poisoning, and how do we approach in this sick child?
As there is many symptoms and complex, there is no specific disease entity where we can say that this is that. So when it is unexplained, so we can think that this may be a case of poisoning where appropriate history and other things is not available, and the patient presented with a juggling or the complex of different symptoms and signs which is not easily explained by any specific disease process. We might think that this may be a case of poisoning.
Yes, excellent. So this is a puzzling complex of signs and symptoms not explainable by the other disorders. We always think about the poisoning in a patient. Now, how we like to approach this child?
Actually, we must treat the patient and not, so according to the presentation, we must resuscitate first the patient. So resuscitation first, then you assess what is the risk of that, and then you supportive treatment should be given. After that, you can do with the suspect that this may be a case of poisoning, so a decontamination and enhanced elimination and other thing is to be done. If available antidotes is there, so you can apply antidotes.
Yes.
So that
Thank you. So for as any sick child, resuscitation is always the priority. So antidote, don't jump about the run behind the antidote, because they will not do any magic if the patient is sick and the organ dysfunction has already started. You have not resuscitation. So resuscitation is the first approach they have to go. So airway, breathing, circulation, disability, we have to go ahead with. So, and the ABCD approach, we all say about these things, that we should go for the ABCD approach. So, how does this differ in patient with suspected poisoning? Because they all know the ABCDE, but it is bit different, I'm telling. So, it bit different in patient with the poisoning. So, what are the differences? If you look at it, with the airway, breathing, circulation part is similar. In the disability, D is similar, but the other two Ds are added. D3 is the decontamination, and D3 is the drug antidote. And the E along with the exposure. Now, how we have to think about the elimination, how we can eliminate the toxin, how we can absorb the toxin. So, the ABCDE approach is expanded in patient with the case of poisoning, and we have to think in mind. And with the managing the airway in this patient is very important in case of you are suspecting the corrosive ingestion, and requiring the prophylactic and intubation is required, because the airway will be compromised very soon in this patient, because there may be edema, maybe hemorrhage, or maybe perforation even. So that's the things we have to keep in mind. So my friend Dr. Shiva has joined from managing a patient with acute liver failure. So welcome, Shiva. So I have tell your first question. I'll move forward. Okay. So now going to the circulation part, shock. Is there any difference, Dr. Guru Prasad? We are giving the fluid bolus, inotrope. Is there any difference in patient managing with shock in suspected poisoning?
Yeah, so there may be 4 mechanisms by which hemodynamic instability can occur in a poisoned patient. One is it can be decrease in systemic vascular resistance, depressed myocardial contractility, reduction in intravascular volume, and very importantly in this context, arrhythmias. So the first line of resuscitation remains the same. So fluid resuscitation has to be done with isotonic crystalloids using normal saline. As far as inotropic supports is concerned, there are a few points to note. First is that the dosage requirement of inotropes in a poisoned patient may be much higher than what we would normally use in other etiologies of shock. So considering this, epinephrine generally is not considered as the first line. There are several reasons for this. One is that epinephrine, especially at higher doses, predisposes to arrhythmias, and a lot of children with poisoning they already have a risk of developing arrhythmias. Second thing is some of the poisons cause beta blockade. In such a situation, if we give epinephrine, there will be unopposed alpha action, and that is an issue. So some psychotropic drugs, for example, they are associated with alpha blockade. So in those situations, we may end up with a unopposed beta action, and which leads to a paradoxical phenomenon of catecholamine-induced hypotension. So several concerns are there with epinephrine. In the same note, we may also remember that if there are poisons which lead to sympathomimetic type of presentation, beta blockers should be avoided. And if there are arrhythmias, if there are sodium channel blocker ingestion, the most common is tricyclic antidepressant. For example, sodium bicarbonate is the first line for the treatment of arrhythmias. Potassium channel blockers tend to prolong QT and lead to torsides. So in these kind of situation, magnesium sulfate. We should also remember that the response to defibrillation is not as good.
Yeah, so excellent. So point well taken. You have nicely summarized what is the difference, and you have to keep in mind while the circulatory support in patient with the suspected poisoning. Now moving forward, these are the drugs of sodium channel blockers. They commonly used as a tricyclic antidepressant, antiarrhythmic drugs, antimalarials like chloroquine, propranolol, and carbamazepine. These are the potassium channel blockers, amiodarone, and the oral hyperglycemic drugs. So going to the disability and the seizure control, yes, that is the important, because many of patients with poisoning present with the seizure like this our patient. Is there any difference or the deviation from the usual management? Dr. Pradeep Kumar Jena is what to like from you.
Yes, seizure is one of the important manifestation in poisoning, and as part the different management protocol in seizures, same thing we do first, the resuscitations, the electrolytes, the sugars, we take care first, oxygenations. And the difference in poisoning is that many of the conditions we treat the drug of choice is midazolam. That is, in the benzodiazepines groups of drugs are the drug of choice rather than phenytoins, because we want a mechanism where that GABAergic actions is needed here. Many of the poisoning conditions, why phenytoin is not given, because that increases the sodium channel blocking effect, where in majority of the poisoning that causes cardiac issues, shocks and cardiac failure. These are precipitated. That is why that should be avoided in case of poisoning, and all benzodiazepines groups should be the first of choice. Midazolam is good drugs, followed by phenytoins, phenobarbitons can also be used.
So excellent point. So the phenytoin should not be used or avoided, because if it is an unknown poisoning and suspected sodium channel blockade, that may potentiate the seizure potentiality, that may aggravate the side effect. Also, you have to think about the hypoglycemia and maintain normothermia, because you know that the many poisons leads to hyperthermia. So we have to give the physical cooling, may require intubation and even paralysis, because it will be the central hypothermia that will not respond to your paracetamol. So the cooling and the intubation and paralysis will be required. So going to the other D's, that is D2, decontamination, you need to know some facts and those and don'ts. So regarding the very common decontamination, the skin and eye, what your take, Dr. Govindo Mondol?
First of all, we must resuscitate the patient. After that, if after proper resuscitation and the supportive care, we then go for a decontamination. For the skin decontamination, we can wash the patient body by plain water or soap water, wherever is available. Sometimes we can use liquid paraffin to block the area. And for eye decontamination, we must wash the eyes with normal saline till the pH become around less than 8. And we can also use the local anesthetic to the eye, like paracaine, tetracaine, like those drugs we can use, and also sedative sometimes.
Yes, so the skin and the eyes are important, because it may poison may remain for a prolonged time. If it is the source is not removed, that may go on absorption. See, few of them get absorbed through skin also. So that is very important point. Then GI decontamination, we are all fascinated about these gastric lavas in any patient of poisoning. So what are the do's and don'ts? Dr. Shiba.
So GI contamination is one of the cornerstones in management of any poisoning. But definitely we should, there are many things we should look into, like spontaneous emesis. Like sometimes we give drugs to stimulate emesis. It can be dangerous sometimes. So it's better not to give emetic agents, or maybe we should not induce emesis in those type of patients, which can lead to bleeding from the malarial syndrome type thing can also occur. Similarly, many other complications, aspiration can also occur. So it's always better to put a Ryle's tube and remove the poison and make decontamination. Similarly, many cases like suppose it's a corrosive poisoning, or maybe in case of hydrocarbon poisoning, we normally avoid putting a feeding tube in those cases. So it is definitely not blindly that in all cases we'll have to do either induced vomiting, or maybe we have to put Ryle's tube. So depending on the scenario, we'll have to do. But definitely, induction of emesis is completely no in those cases.
Yes. So this is the excellent point. So the bottom line is that if the presentation within the 2 hours and the patient's CNS is intact, airway is patent, only then you can go ahead with the gastric lavage or activated charcoal. In between 2 to 4 hours, there will be no benefit, and beyond that there will be 2 to 4 hours is doubtful benefit, beyond 4 hours no benefit. And always in a sick child, be sure that the patient airway is patent or patient is not going to deteriorate his consciousness level within the few minutes. And also already have mentioned, so these are the things, poisons that they should not be go for the gastric lavage and activated charcoals like the hydrocarbons, alkali, ethanol, metals like lithium and the iron components. So going to this whole bowel irrigation, that is another method of decontamination. So Dr. Guru Prasad, what is your take? When you will do that whole bowel irrigation?
On the whole, there is a very limited role for whole bowel irrigation. It is very rarely performed. So there are some specific situations where we may consider to do that. One is if there is ingestion, there is a large ingestion of slow release or extended release or enteric coated type of tablets. Second is presentation still has to be early, we cannot delay doing this. Third is ingestion, this method is very poorly tolerated and it is very cumbersome to do also. So if the ingestion is likely to result in significant toxicity in spite of treatment, then we may assume that it may make a significant clinical difference and then consider it. The method is to give polyethylene glycol electrolyte solution 30 ml per kg per hour until the rectal effluent is clear. So it is very difficult to do this orally. So we will generally have to insert an NG tube. So considering, and there are a lot of adverse effects also. One of the things is that it is poorly tolerated. It causes a lot of nausea, it can cause vomiting, it can cause bloating and abdominal cramps and so on. So second thing is that it can also reduce the efficacy of activated charcoal. So yes, considering all of these things, it is very rarely used. Some of the indications where we may consider is if a huge amount of iron, more than 60 mg per kg of elemental iron is ingested, in sustained release diltiazem and verapamil poisonings and slow release potassium chloride tablet poisoning.
Yes, so point well taken, but you have to keep in mind that the patient have signs of obstructions, like in iron, if it is taken in large amount, that itself can cause the gut obstruction, or already the hemorrhage has started, then the U is contraindicated. You should not go for the whole bowel irrigation. So the last point is the antidote. So we know that is not available for many of the poisons, they are available for few. So these are the pharmacological agents. So Dr. Pradeep Jena, so when you will use, what are the antidotes that are available for common poisons?
Yes, when there is a toxic effect, we always want a drugs. But antidotes, as per its definition, it either neutralizes or counteract the actions, pharmacological actions of the poisons. It sounds very good, but in majority of the drugs or majority of the toxins or poisons, we do not get an antidote. So it is very rarely available in poisons, but wherever it is present, it should be used judiciously again, because the antidote itself is a drug. It is not without any side effect. So you have to choose the drugs when the benefits outweighs the risks. And very good antidotes for certain things are definitely available, like in case of paracetamol, N-acetyl-16s, then dizivind in case of digoxins, that sodium channel blocking agents when used.
So the list is there, will not go to one by one, because that is the ready, you can go through the literature, and if some patients is coming, then you can, the help of the textbook or the apps are available now. So antidote, but first the resuscitation is very important, then you think about the antidote. So management is poisoning is not equal to antidote. There are a lot of things to do on the resuscitation and the decontamination, then go for the antidote if it is available, then go for management. Now resuscitating the child, now we'll go to our case again. So back to our patient. Can you remember our patient? Okay, fine. So now this patient has this condition, okay? So lung, you can see that the pulmonary opacity is bilateral, and in EBG you can see that is the acidosis, and the PCO2 is normal, whether metabolic acidosis, and the lactate is 2, and but patient is on PRVC mode with optimum ventilatory setting, but the still patient have desaturation, and this is the ABG shown. So there has been very peculiar finding in this ABG. Can Dr. Govinda Mondal, can you just elaborate what is the wrong in the ABG and what we'll do here?
Here in this ABG, we can see that there is a acidosis. Along with that, there is a remarkable increase in the methemoglobin level, which is about 28.2%, which is significantly high. And that methemoglobin or methemoglobinemia might be the cause of this presentation of the patient who has presented in such a way. Might be that the patient has taken something which can
yes, so there is something, a patient was in marriage ceremony, so have something.
As there is a clear high methemoglobin, so we must treat the patient for methemoglobinemia.
Yes, now how will go? Because now it is due to methemoglobinemia, due to something that has been taken in the marriage ceremony that leads to this methemoglobinemia. So how do we manage in this patient, because in your ICU?
So we can manage this patient with methylene blue, 1% methylene blue, 1 milligram per kg. Rapidly we can use this along with vitamin C, in high dose vitamin C every 8 hourly in IV. Okay, so that the methemoglobinemia can be corrected as early as possible. Right
yes,
now.
so here now you can see that the methemoglobinemia, this methylene blue could be a life-saving for this patient, but it is not available in all the centers at all the time. So, but use is very limited, but if it is available and you can give that, will be get the dramatic result. So the methemoglobinemia, after this giving the methylene blue to this patient with the 1 gram per kg, this patient, the ABG changed dramatically, and also the patient got the vitamin C injection, because the patient, if they are not patient is sick, then you have to give both the 2 drugs. If the patient have G6, known G6PD deficiency, then methylene blue is contraindicated. So only weapon in your hand is the vitamin C. And you can see the ABG, there is a drastic improvement. After a few hours, the methemoglobin level reduced to 1.3%. So there is a huge improvement in this patient.
Yes.
And you can see these are the causes of maybe congenital or the acquired. This patient has acquired due to some dietary content of the nitrate foods in the diet, and that is not known till now, because the patient could not say what, because some unknown person gave some food to the child, and after that these symptoms started. Okay, so this child was extubated after 2 days and got improved and discharged home. And after that, he gave the history that some unknown person gave some chocolate like food, and after that he started these issues and the problems. So this is the diagnosed case of acute methemoglobinemia, probably due to some unknown poison in that nitrate products in the food that lead to ultimately leading to this issue. So you may not diagnose all the time, but the science the toxidrome and the clinical laboratory parameters you can corroborate, and you can give the antidote and manage the child. So going to the second patient, as the 2-year, 8-month-old presented with history of paraquat poisoning 7 days ago, and being referred for another medical college for hemodialysis, for the child has AKI. His another sibling had ingested paraquat and expired next day after the poisoning. And the history and substantial evidence suggests that the ingested amount is nearly 40 gram per kg. So that is the huge amount ingested. And this on examination, there was a child has pallor, ulcers in the lip, tachypnea, subcostal, intercostal retraction. Initially put on non-invasive ventilation, but not tolerated. Child was put on intubated and required high frequency oscillatory ventilator. Patient required a hemodialysis. You can look at the X-ray of this patient, very bad and angry looking X-ray. There are a lot of ear leak. The patient has pneumothorax, for which the drain was given. You can see that the mediastinal emphysema and the interstitial emphysema as well. So this is a very bad lung. And this patient was able to extubate, but again re-intubated you can see that the patient's lung condition is very poor. These are the lab parameters of urea creatinine. The patient has AKI, but refractory hypoxemia and multi-organ dysfunction, and child expired on the day 11. So the paraquat is very toxic because, and the outcome, whatever you do, if it is the lethal dose is taken, then nothing to do in the midst of the situation. Now, how we can get awareness among ourselves, what we can do little bit for this child. So how does the severity of paraquat vary with this amount ingested? Is there any correlation, Dr. Shiva?
Paraquat, as you told, it's one of the worst poisons that is available, and actually everybody is now, most of the, even IAP has given letter to the government to ban paraquat from the market. So it's a really dangerous poison in the sense that there is no treatment for this. When somebody suffers, then it's almost the case is over. So from our experience, we have seen, like you told here, in this case, the patient has come after 7 days or 8 days from another hospital, then definitely these type of scenarios, the mortality is almost 100%. We have also dialyzed patients for few days. We have used ventilation for 10 days, 15 days. Then finally the patient, 2-3 adolescents we have lost. But a few months back, we had one case, you must have seen, I posted in the group also. So that child actually came very early, and we did charcoal hemoadsorption for that patient, and the patient surprisingly has survived. So I don't know whether the survival is because of the charcoal hemoadsorption or what you are saying is the amount of the poison. That is also very important. If somebody has taken a large amount of poison, then survival is very difficult in those cases. Like you said, 20 to 30 milligram per kg is very mild, but if the dose is more than 50 milligram per kg, then it's a really toxic dose. But sometimes it is very difficult to know how much is the 5 gram or 6 gram or 10 gram like that. But overall, once the symptoms develop, then only you will know. And mostly it's very difficult to, because of the final injury to the cells directly. So it's and fibrosis of the lung and multi-organ involvement, kidney involvement. So mostly they die of respiratory failure only.
Yes. So sometimes you will not able to, if the bottle is not taken with the and the how much, because in the pediatrics you cannot never judge the what is the amount ingested. So the lethal dose, if it is taken or not, is very difficult, but we have to be very aggressive from the beginning for the paraquat, otherwise we'll lose the patient. If it is taken in a lethal dose, fulminant, then the death is imminent within 1 to 4 days. So this is very toxic and very lethal. There is anything hardly you can do. So why does the paraquat is so toxic? Dr.
Yes,
Jena.
Paraquat is such a drug, once introduced through injections into the body, it undergoes productions of multiple, in a cyclic envelope, huge amount of toxic reactive oxygen species are produced, which can produce lipid peroxidations, which can produce cellular death almost everywhere, and mitochondrial damage can happen. If you see the different organs involvement, lungs is the chief organs, where immediately it causes severe epithelial damage and can give rise to ARDS like things. Even if the patient survive, if you take great cares, then ultimately it will produce lung fibrosis, which will need again the lungs must be implanted or something like, which is not possible in our country.
Yes.
So that means the patient will ultimately die because of severe lung induced damage. In addition to lung, different other organs like kidneys, acute tubular necrosis can give rise to AKIs. It can affect the CNS also. If it affects the liver also, liver damage can happen. Lipid peroxidations can give rise to several multi-organ damage.
Because we cannot go through the all, because it has many mechanisms to the organ damage. It from lungs to kidney to heart to liver, everything can be affected. Now moving forward will be a bit brief, because we have to only 17 minutes left. So is there any role of elimination, like we talk about the elimination, and also the Shiva talk about the charcoal hemoperfusion. So what is the literature says? What is the role of the early hemodialysis and heme absorption? Guru, what is your take on that?
Yeah, so hemoperfusion is said to be better than hemodialysis. Charcoal hemoperfusion filter, so availability is not common. Second thing is, we should also remember that it can only be useful when the plasma concentration is very high. Once it gets, once the uptake happens into the cells, it is not of much use. So there are studies which have indicated that there may be improvement in mortality if charcoal hemoperfusion has been performed less than 6 hours after ingestion. Ideally, it is done less than 2 hours after ingestion, which is practically very difficult. Second thing is there is also some evidence that if you are able to measure serum paraquat concentration, if it is more than 3 milligram per liter, these modalities may also not be very helpful. There is also a phenomenon of rebound increase in paraquat levels once the hemoperfusion is done for 4 hours. So there have been some research doing that is continuous veno-venous hemofiltration after doing the hemoperfusion, but unfortunately it has only shown that it prolongs time to mortality, does not improve survival.
Yes, thank you, Guru, for summarizing this. So because you have, the bottom line is that if you start within 2 hours, then it can have some benefit. But if it is between 2 to 4, there is no benefit, and beyond that there is absolutely no benefit. And there also the results are controversial. So some of this first study, the Karnataka pre-retrospective study in adults, they have shown some benefit within the started with the 6 hours, but 6 hours is too late. But the main drawback is the availability, and it should be tried with the time critical. So 2 hours is very fast. So the patient, when appearing in the emergency, the most of the cases the 2 hours will be gone. So that's the issue with the paraquat. So that charcoal hemoperfusion filter is not readily available in all the centers, and it had been started very early. So these are the issues. So there are some studies and the case reports that role of ECMO as a paraquat poisoning. So what is your take, Dr. Shiva?
See, again, ECMO is mainly for the conditions which are reversible. Usually, it's as a bridging therapy. Suppose, like we know, the final outcome in paraquat is lung fibrosis and lung failure. So we should have, if we are planning for lung transplantation, maybe at that time you can have ECMO as a bridging therapy. But only to prolong life for few days by putting the child on ECMO has no value if you do not have a lung ready for the child for transplantation.
Yeah, so that's the point. So it is just a bridging therapy. So if the lung transplantation you could not do, there is no point of going for the ECMO for just prolonging the life. So there is the controversy. There is no such as recommendation of if the lung transplant facility is not there, so should not go for this modality. Is there any antioxidant and immunosuppressant sometimes been used, like the N-acetylcysteine, methylprednisolone? What is the evidence, Dr. Govinda Mondo?
As there is a inflammation, hyperinflammatory problem, so immunosuppressive drug may help, but there is no concrete randomized control trial which favors the use of these drugs like cyclophosphamide, methylprednisolone and dexamethasone. And also there is a study in Sri Lanka, they shows that there is no evidence that the high dose of immunosuppressive improves the survival of the patient. As well as these other drugs like N-acetylcysteine and the salicylate, those who are antioxidant, they also don't give any much benefit as there is no randomized control trial in the use of these antioxidant, although hypothetically they may be useful as there is a more oxidant.
So evidence is totally split in both the way. So this is you can see the Sri Lankan study, the cyclophosphamide, methylprednisolone, they have shown no evidence of improvement or survival. But there is another Cochrane meta-analysis which included the 3 RCT in adults. They have shown some beneficial effect. So if your patient is very sick and you have excluded the infection, then you can try of this patient with the cyclophosphamide and the methylprednisolone. This patient, the index case was started, but we got not, but already the patient was very late. So there is no benefit of this patient after getting late. So within the first day, the patient is infection, no infection, you can try, but the evidence is not so robust, and it is split totally in both the ways. So this is another patient of paraquat in our center. So this lethal dose was less. This patient required only hemodialysis, and this patient lung is spared fortunately, and this patient has also complicated of hematochezia, and the patient was survived after discharge on the 15 days of hospital stay. So it all depends upon the age, the amount of ingested, and the lethal dose. If it is there, then you cannot do much for these patients. Now going to another patient, this is the 16-year adolescent girl presented with abdominal pain, bloody vomiting for last 3 hours. She had fought with her elder sister and father. Post that, he had consumed nearly 100 tablets of iron. Okay, and now he has acidotic breathing, features of shock, and compensated shock, and there is a abdominal tenderness, significant epigastric and hypochondrial tenderness. So how will resuscitate? Because this patient with the iron poisoning and the shock, and this patient with the hepatomegaly, Dr. Pradeep Kumar Jena, what will do in this patient?
Yeah, from our previous discussion already emphasized the role of resuscitation in each case of poisoning. So in this case, if the child is already hypovolemic, compensative shock, first bolus 20 ml per kg should be given, followed by you reassess the child whether he needs rebolus or any inotropic drugs. At the same time, you must know that the electrolyte imbalance is very important in case of iron poisoning, that is hypokalemia occurs. You must be monitor that, and if needed, potassium supplementation can be given. And as per decontaminations, as this child has taken already more than 100 tablets, and each iron tablet current around 60 to 100 milligram. So that means the dose is more than 60 milligram per kg he has taken. Already emphasized in the WBI sequence that this child will benefit if you will do whole bowel irrigations. Whole bowel irrigation can also be emphasized from the thing that the X-ray abdomen, if the X-ray abdomen showing the stresses of metals presence, because iron is a metals, if you see the metals are present, then that is also an indication for whole bowel irrigation. So here we use PEG, that is polyethylene glycol electrolyte solutions at a dose of 30 ml per kg per hour till a effluent which is clear coming out.
Yes, so
that
fluid resuscitation, and the patient, if the patient have presented early and the X-ray abdomen shows the metals, the opacities, then you can go for the whole bowel irrigations. And if the case continues, ABG shows the metabolic acidosis with high lactate, receive the fluid bolus and the polyethylene glycol. But in this patient, what are the unique features in the iron poisoning? Some overdose, because in sometimes it may just confuse us or deceive us.
Here is the irony of iron poisoning, because sometimes the child presented with nausea, vomiting, diarrhea, pain abdomen, and after few hours the symptoms may be subsided and the child absolutely become asymptomatic, and we thought that there is no such big problem with this child, and we can, if we discharge the child after sometimes, then again toxicity develop. Actually, by that time, child may remain asymptomatic after initial few symptoms for even up to 24 hours. Then the other symptoms of different organ toxicity may develop. So we should not, we think of that this child should not be discharged, and this, there may be later on the other symptoms may develop like other organ failure.
Yes, so there's some improvement in the signs of symptoms of abdominal pain and vomiting. We should not discharge the child, because there's a latent phase when the iron will absorb systematically, and it will have the systemic effect like the cardiogenic shock, then hepatic necrosis, and even the bowel obstruction and perforation. So we have to be very cautious before discharging the child to the home. So that is the take-home message. And what are the specific information you will try to elicit from the history, and what investigation will help really in the management, Dr. Shiva?
See, specific information means, as we know, the toxic and the lethal dose is more than 60 milligram per kg. So that's why we have to first assess how much amount of the drug that the patient has taken or child has taken. So sometimes in children it may be difficult, especially when what happens when the small baby takes an adult dose, like you, for example, tonoferin syrup. Adult tonoferin contains very high amount, 250 milligram per 5 ml, while our neonatal dropper maybe syrup contains 80. So sometimes these drugs, if taken in large amount, we have to calculate how much amount of the medicine the child has taken. That is very important to know first, whether it is a really dangerous amount to touch or just a normal dose. So once you know the dose is definitely toxic dose, even if it is you are not sure of that, then you will have to go for lab test, and like basic lab test we will be doing, where you will be finding the like LFTs and KFTs, and you can find all those reports. Along with that, serum iron level will be helpful to know the prognosis of the patient.
So the preparation is very important, because all the iron salts, the bioavailability of the iron may not be the same. So which salt has been taken and what dose, and also have some different pediatric preparation, like we have mentioned one drug, the tonoferon is the high concentration. So if it is taken, so exact dose you have to calculate, and the blood investigations like LFT, coagulation factor, and serum iron level you have to do. But if it is not even available, but if based on the signs of symptoms, even the serum iron level is not available, we have have to start treatment of this patient. So is there any antidote? Then when we should start considering antidote in this patient, Dr. Guru?
Yeah, so the antidote is deferoxamine. It converts ferric iron to ferrioxamine, which is water soluble and excreted by the kidneys. So the point is it should be started early because again, when the plasma concentration is high, it can be chelated. Once the uptake happens into the cells, it cannot be chelated anymore. So when will it be indicated? Generally, the recommendation says you have to look at serum iron levels, but it may take a long time for us to get that report. So we should not wait for serum iron levels if the child is sick. So if the child is in a state of altered consciousness, there is high anion gap metabolic acidosis, and the child has presented in shock, these kind of situations, we need not wait. We can start off with deferoxamine. So generally we start at 15 mg per kg per hour. If iron chelation is happening, then the urine will change color. It will become a win rose color. So that is an indication that iron chelation is actually going on. If there is continued worsening, we can even increase the dose gradually over a few hours period up to a maximum of 35 mg per kg per hour. But we should remember that the total 24-hour dose should not exceed 80 mg per kg per hour. And generally, deferoxamine should not be given beyond 24 hours because prolonged infusion is associated with significant pulmonary toxicity, including development of ARDS.
Yes, excellent, Guru. So we have pointed everything. So desferoxamine, again, Dr. Pradeep has highlighted, antidote can have itself side effect. Like desferoxamine, I think from National Medical College, one case was presented last year. So after 24 hours, desferoxamine was continuing. This patient developed sudden respiratory distress, intubated, and developed ARDS. So that can happen. So we have to also, antidote may have side effect and toxicity. We have to think about that. So thank you, but this child has a very fatal and a very bad course in the ICU, and in spite of all, suppose the child succumbs, so there is very high dose, and if it is presenting late, then the started desferoxamine late, that can have a very detrimental effect and the bad outcome, this patient. Okay, so we have, because we don't have a time much, so now we'll go to the very common day-to-day practice or day-to-day in a household things that the child may ingest and and the toxin effect and how can manage. I will go to the rapid fire to our panelists. Okay, so first rapid fire is the mosquito repellent. Okay, so this is one of the common poison that we encountered in emergency. Dr. Govindo Mondol, what is the chemical, what is the sign symptom, and how will manage? Very brief point.
This mosquito repellent usually contain pyrethroid group of compound, which is actually herbicides and used in the field. And also this can cause, usually they are rapidly metabolized from the body. Usually they do not cause much toxicity unless you take a larger amount of that. And if you are taking the larger amount of that after absorption, it can causes a sodium channel blocking as well as the chloride channel blocking, and that leads to some symptoms of paresthesias like symptoms, and sometimes they may present it like convulsion because of this GABA-gated chloride channel blockage. So that can cause some coma and convulsion in some patient if they have taken a larger amount of, but usually they do not cause any problem, and only the symptomatic management and decontamination if possible, if the child came earlier, and it can do that, and otherwise you have to give the supportive care because there is no specific antidote of that pyrethroid group of compound. Okay.
So there's the point well taken. So and sometimes the mosquito repellent, they do contain kerosene as well.
Yes.
And so there may be cross contamination, and you have to think in the mind. Okay. So the kerosene may be sometimes co-ingested or maybe the component of the mosquito repellent. So rat killers is another notorious. The patient usually the children come with this ingestion of this poison. Dr. Pradeep Kumar Jena, your rapid fire. What is the ingredient, signs and symptoms? How will manage?
Yes, red killer is very common. Here the active principle is yellow phosphorus, zinc phosphide, aluminum phosphide, multiple components which can cause bleeding manifestations, diarrhea, pain abdomens. These are the common symptoms. There can be hypotensions, and usually we manage by decontaminations, activated charcoal, stomach wash. But the specific antidote here available is vitamin K. so that bleeding can be controlled.
Yes, so the coumarin and the phosphide are the components, so that you can vitamin K can be helpful if there is bleeding. So there is the another common that a patient will come, because we are not able to detail discuss this itself. Is a detailed discussion. This alkali and the acids. So these are this corrosive poisons. Dr. Shivabrata, what is your take? What are the main dangers? Because they are maybe become very dangerous and can have a very dreaded side effects.
So you have already mentioned everything, so I'm not going to read all those things, time is only 50 seconds. So I would say that the corrosives are very dangerous, and as we told previously also, the corrosive poisoning later on sometimes, if you compare between some alkaline poisons mainly, immediately they may not have any symptoms, but later on after 48 hours you may find there will be obstruction to the intestine also. This type of presentation can be there, but as you have told that different signs and management like securing airway very important, because they are corrosives. Not only they can damage the esophagus, they can also go forward and damage the, your airway. So airway protection, sometimes maybe requirement of tracheostomy can be there. So, and otherwise all supportive measures of what we all do can be done for those patients.
Yes, so there may be the all side effects, pulmonary edema, edema, and the ARDS, laryngeal edema, and also the gut perforation. So patient needs resuscitation, may sometimes surgical intervention. The prophylactic sequelae, airway sequelae you have to do sometimes, and if endoscopy can be done between 6 to 24 hours. So just 1 minute. So that is the patient, one child. Okay. So then we can discuss later on. So levothyroxine, the child has get the grandmother was taking this thyronorm, and the child has come with the several tablet ingested with the levothyroxine. This is another common scene we encountered in our emergency. So how when we hospitalize this patient who has taken with the levothyroxine, what are the main signs, symptoms, and how we'll manage? Dr. Guru.
Yeah, so the levothyroxine accidental ingestions are very common. So, but fortunately, serious toxicity is rare. So the dose that is concerning is if it is more than 100 microgram per kilo. And what we should remember is these symptoms may not manifest for several days. So because it takes time for peripheral conversion of T4 to T3 and then for symptoms to come. So symptoms are generally like CNS related and cardiovascular. So restlessness, irritability, tremors, etc. can happen. And cardiovascular, that is tachycardia, hypertension, and so on. So hyperthermia, of course, can happen, and high output cardiac failures can happen. So less common will be dysrhythmias and seizures and multi-organ involvement. So if the child presents very early, less than 4 hours, we can consider activated charcoal. And if there are any cardiovascular side effects that are present, propranolol is the drug of choice. Thyroid storm in this particular situation is very rare, but one clinical point we should remember is generally we say that the effects of levothyroxine on the CNS will be more of hyperexcitation rather than anything else. But in thyroid storm, CNS depression can occur. So if there is a presentation with thyroid storm, then we can consider corticosteroids and antithyroid medications like methimazole, propylthiouracil, and so on.
Yes, so and sometimes the plasmapheresis and dialysis may be required if the thyroid storm is the high dose. Because of want of time, we didn't discuss about the two common things, that is the OP poisoning and the kerosene. We tried to cover very more toxic ones because that, if you look at the data for our center retrospective data, there is hardly any OP poisoning in last 3-4 years. So in pediatric. So that's why I have not mentioned it, because maybe it is now decreasing, or maybe some awareness for that not keeping in the home. And the kerosene also after this change, because initially the blue color, this Pepsi, that there was a high incidence of the kerosene poisoning. Now it has been decreased to some extent. So these are the few data that we got our center, one of our PGTs present with this data. So these are the things. And if we get the take-home messages are that we need a high index of suspicion, because in a healthy child with puzzling sign symptoms, you have to think about it. Treat the patient, not just the poisoning. So antidote is not the answer everywhere. Additional D and E's in resuscitation on the poison patient is very important. GI decontamination with lavas and activated charcoal, we should think about that within 2 hours of injection, and if the airway is patent, and toxidrome recognition is helpful. But even after this, all the things, we are many of the times are confused in our emergency if a child with the poisoning is coming, because we don't know the composition most of the time. If the bottle is not brought with the parents, the unknown poison, it is very difficult. If it is taken with that, then it is sometimes we can search it. But even with that, because it is rarity, it is not that is we look a patient like pneumonia, shock, or patient with convulsion every day, so they are prone to mistake. Even the senior consultant also can mistake because of this rarity or not doing the encountering the patient every day. So how we can help ourselves? So there are some links, and the helplines are there. So this is the government helpline of the government of West Bengal. That is conducted by the community. This is taken care forensic and the medicine and the community medicine of the Arjikar Medical College, and this is the from All India Institute of Medical Science, the pharmacology department. They have a toll-free number. There is an app also from the government of West Bengal Health Department on the snake bite and the poisoning, but the snake bite is very well delineated there. Poisoning is not so much robust, so needs more data and the feedback. So because of priority, we need some help. So these centers can, if you get, I think we got response even in the it is a 24 hours helpline, 24/7, so we get some information with that. With this, I will conclude. If there is any question, we can take. Sir, your comment, you will not take question from you, we will take comment from you, because you are one of the experts on that.
Yes,
hello.
One thing, you have not mentioned that naphthalene poisoning is not that much uncommon. We are getting it, and that associated methemoglobinemia and also hemolysis and hematuria. And a very simple bedside test of methemoglobin is that before going for this ABG, that take one filter paper and one drop of or few drop of blood and just wave in the air. The color will not change. It is dark bound. So that is a very bedside clinical test. And another is that rat poison. Rat poison only anticoagulant vitamin K is for
Humoral group.
But the zinc phosphate is dangerous, no antidote, and high mortality.
Yes.
And another is not poisoning, but ingestion is a very dangerous, is alkaline or button battery. This associated of many complications from esophageal perforation to the gastric perforation.
I have all the cases prepared, but want of time I am not able to show because we need another, because poisoning is a huge, because we can say that every drug can be poison if it's taken in an abnormal amount. So this is a no end of it.
Yes. Any comments? Any comments, Father? Well, then I must say that's a very nice session conducted by Professor Mihir Sarkar and our learned panelists, and we have all enjoyed, and it's a very tight and rapidly passing, and finally the rapid fire session. That's very interesting. Thank you very much.
Thank you, sir. Thank you, everybody. I'd like to request you to kindly proceed to the felicitation area, and we'll take a short tea break for 10 minutes. Then we all gather in this hall for the quiz. Good evening, everybody. Please settle down. Now we'll be proceeding to the most exciting session of the day. It will be the quiz by none other than Dr. Rohit Bhomik. A big round of applause for him. Over to you.
So all of you got the link now. So don't click. If somebody is there, they will lose the opportunity. Yeah, fact. So, so faculties, please don't participate. So don't, just you click on that, don't do anything. Anyone? বাইরে কেউ আছে আর? Students, like delegates, everybody came. এখন কিছু করো না। না এখন থাক, এটা এরকমই থাক। Please click on the link, but don't do put your name. Please click on the link. So shall we start now? পেছনে কিন্তু অনেকে বাইরে ঘোরাঘুরি করছে। Link has been shared to your WhatsApp. Yes, yes, yes. So you just wait, don't click the link. So we got it. So we are starting now. Yes, please click on the link and kill it. It will come, it will come. বন্ধ রাখো এখন, বন্ধ রাখো। Don't worry, 2 questions won't do anything. And anyway, it will be neutralized only. Rules, you have to be very fast. It is fastest finger fast. না না এখন আসবে না, এখন লাগবে না। It is fastest finger fast. Link, nothing is coming, right? হ্যাঁ, load দেখাচ্ছে। So sometimes if it is showing here, means it is question has been delivered to your side. If your network is not very faster, then it is difficult for you. So now is it came? কি error? এখনো করবে না। Just click on that, don't do anything. Mentimeter, no need to download anything, you have to just on click. App download করতে লাগবে না। Oh, it is okay, fine. So one link has been shared. If you click on the link, what is showing now? It is loading, and your name they are asking, right? So after that, name will come. Once I start the quiz, they will ask that show your name. Okay, then you just put your name, reload, it will come, don't worry. এখানে কানেকশন ঠিক আছে। Just hold on, now something came, right? So now something came, don't do anything, your name came, they are asking for your name. Yes, the quiz is not open. Everybody got this? Quiz is not open. Everybody are okay now? Don't do anything. Yeah, yeah. So it is like this quiz is not open. Please wait for the presenter to activate it. So same link I am also doing. All are you okay now? The last link I shared. Don't click reload, don't do anything. তুমি আমি করে নিচ্ছি এখানেই করে নিচ্ছি Now you put your name. Just put your name. তুমি দিয়েছো টম করে দাও হ্যাঁ জয়েন কুইজ করো bas so you got get ready to play your name done all of you are okay get ready to play because we are also playing sir is Tom I am with some name okay first question leaked out question but now you answer properly don't worry it's the era of leaking so answer the question fast देखो that is the leaked question the era of leak don't worry so dengue which of the following not a criteria for severe dengue fastest finger fast even two people gave same answer correct the fastest will get the highest marks so the answer is mucosal bleed is not criteria for severe dengue the others are correct second leaked question I don't know why it is happening don't worry don't these are demo version don't worry block rakho হ্যাঁ হ্যাঁ এটা না এবার হবে চলো so you are getting the second we have enough question demo versions are going on so intracranial pressure monitoring has been shown to be most useful in therapy in traumatic brain injury আবার স্টিকটা ব্লক রাখো so the real game starting now sure. 86 huh? Which of the following is not a strong recommendation as per pandem guidelines so remember strong use of passive eye closure and eye lubrication in patient with neuromuscular blocking agent use of withdrawal assessment tool for assessing level of sedation minimizing benzodiazepine routine screening of for ICU delirium using a validated tool the correct answer is use of withdrawal assessment tool for assessing level of sedation. It is for assessment of withdrawal symptoms. See now nothing is coming. Which of the following has a definitive role in management of hepatic failure? N-acetylcysteine in all cases, rifaximin in all cases, 3% NaCl infusion to maintain sodium more than 145, continuous infusion of high dose flumazenil in all cases. We have a session on hepatic failure. So majority correct, it is 3% saline to maintain sodium more than 145. So everybody is ready? Least likely to be associated with an acute rise of intracranial pressure, altered sensorium, bradycardia, restriction of eye movement, hypotension. So almost everyone it is hypertension, right? Good. No, the correct, this is least likely. So raised ICP is associated with hypertension. The answer is correct only. So everybody joined. Which of the following is false with respect to the Rose concept of fluid therapy? R is for restriction, O for optimization, S for stabilization, E for evacuation. Fast. So R is for resuscitation. The others are correct. See, people are not attentive in that time. Two times it is discussed by Binayak sir as well as me. Best describe the breaths in pressure support ventilation. Yesterday ventilation workshop was there. Patient triggered, flow limited, pressure cycled. Pressure triggered, flow limited, patient cycled. Pressure triggered, patient limited, flow cycle. Patient triggered, pressure limited, flow cycle. It is patient triggered, pressure limited, flow cycled. The last one. Don't discuss, time will go. False regarding pulse oximetry. You had a session on pulse oximetry. Requires pulsatile blood flow. Not reliable in presence of deep jaundice. More than 70 torr PaO2 are not readily identified. Not a good monitoring modality in child with neuromuscular weakness. Oh, it is not reliable in presence of phototherapy, not in deep jaundice. Even it is there in Nelson. Hyperoxia, it is not reliable. It won't detect. In GBS like that, it is more of CO2 retention, not hypoxia. So even you start oxygen, SpO2 will show 100%, but child will go to type 2 respiratory failure. Palissy 2 in compared to Palissy old one. PO2 by FR2 criteria is added for patients on NIV. Mild and moderate PRDS has been clubbed together. Diagnosis of PRDS on NIV, like NIV PRDS, requires nasal mask interface. Oxygenation index and oxygen saturation index values were changed compared to old criteria. So again, so diagnosis of PRDS on NIV is not nasal mask. It is nasal mask you not record. At least full face mask. So tricky. Today only we discussed Palissy 2. Prognostic score, again just few hours back. Which is the following is not a prognostic scoring system. PRISM 3, PIM 2, PSOFA, Candida score. It's not. So good. So you attended the session. Sir is there, I think. Sorry. So Candida score is just to predict that Candida hoga or nahi. Expiratory hold maneuver is used to calculate. Fast you have to answer. Time is less here. Peak pressure, plateau pressure, auto PEEP, difference between peak pressure and plateau pressure. Yesterday's ventilation workshop. So yes, so all of are very good in ventilation. So the other three can be detected by inspiratory hold maneuver. Meropenem is not a good agent of choice against Pseudomonas, MSSA, anaerobic organism, ESBL producing Escherichia coli. Oh, so no doubt. Actually, ESBL it is one of the very important drug. MSS it is not a good drug. So last year, sir has we are in the panel, me sir and we in this panel. So we thought, okay, how much retention is there over the last? But anyway, meropenem is very common drug. So it is not a good drug. It is a drug for ESBL. So yes, this splitting is dangerous. So PD fluid contains all of the following except RRT session was there, RRT lots of paper, dextrose, sodium acetate, sodium chloride, potassium chloride. क्या नहीं है उसमें? Good. So potassium, इसमें potassium, it is no potassium is there in this. So PD fluid does not contain any potassium. Signs and symptoms of withdrawal from sedation and analgesic may include all of the following except agitation, bradycardia, feed intolerance, dilated pupils. Again our sedation withdrawal class today, pandem class. So be careful on withdrawal symptoms. Good, very nice. So people are now realizing withdrawal symptoms. Initially it was very neglected. So it is tachycardia. The others are common. Following successful resuscitation from cardiac arrest, which of the following represent an optimal set of goal? You will have time, you read it. We had a class on CPR and post-resuscitation management. Why he so BP more than 5th centile, core body temperature 35 to 37 is okay, but PO2 less than 30, the last one, dangerous. So much you did after CPR, but patient. So you have to read, the extra times are there on those questions. In a child with status, phenytoin must be infused slowly to avoid. Over 20 minutes आप देते हो ना? To avoid what? Metabolic acidosis, laryngospasm, malignant hyperthermia, arrhythmia. Rapid push नहीं करना है phenytoin. We had good, very good. बीच-बीच में easy रह रहा है थोड़ा सा, so that to you be attentive. Which of the following toxin causes metabolic acidosis through generation of a substance other than lactic acid? Cyanide poisoning, ethylene glycol, mushroom, carbon monoxide. We had a class on just now on poisoning. Very good. The cyanide as well as carbon monoxide cause tissue anoxia. Mushroom also can cause tissue anoxia. So ethylene glycol poisoning causes glycolic acid, not lactic acid. So it is high anion gap acidosis but not lactate related. Procedure class was there. Initial management of limb ischemia due to arterial catheterization. During arterial line limb ischemia start हो गया, क्या करना है immediately? Catheter removal, aspirin and local application of nitroglycerin, local infusion of altiplase, thrombectomy. So good. So if you are there, catheter removal करना है. Very good. क्या? सही answer. What happened? No controversy. So which of the following falls with respect to hyperosmolar therapy? Arun Bansal sir का class था. Avoid 3% saline if serum osmolarity goes more than 360. Avoid mannitol if serum osmolarity more than 320. Prolonged use of 3% saline may lead to AKI. No role of bolus dose of mannitol or 3% NaCl in severe TBI. Bansal sir's class was there. So I don't know why it is so much separated. So 3% NaCl you have to target sodium 160 to 165 or 360. Beyond that, no role. Mannitol 320. Prolonged use of 3% can cause AKI. बोलस तो देना है. नो रोल तो नहीं है ना. Which of the following condition is expected to be associated with increase in EtCO2? Air embolism, cardiac arrest, complete obstruction of ET tube, hypoventilation. So hypoventilation will gradually build up CO2. Complete obstruction, you won't detect, it won't increase it, nothing will come. CO2 आ ही नहीं रहा है तो क्या detect होगा? SIADH, which of the following is correct? Except serum osmolarity is high, urine osmolarity is more than serum osmolarity, urine sodium more than 330, urine osmolarity more than 100. Which of the following is wrong? So easy question, majority correct, serum osmolarity won't be high. Na? It is water retention is happening, so serum osmolarity will come down. Few more questions only. Phoenix sepsis score. Which of the following is false? Take time. So septic shock is equal to sepsis with more than equal to 1 cardiovascular point. Sepsis is equal to suspected infection and Phoenix sepsis score more than equal to 2. TLC more than 18,000 is equal to 2 points. Fixed pupils bilaterally is a component of neurological score, which is not correct. TLC is not there, though it is looking like sepsis. Until unless you know Phoenix score, you can't. You will trap in that only. Ke sepsis hai to TLC hai. It is not there. It is INR is there. So the trap was appropriately put. So today we discussed sepsis. What's new in sepsis? Again, procedure related class yesterday happened. Which of the following is the most common complication of intraosseous infusion? Very important modality, intraosseous route. On egg yesterday it was demonstrated. Very nice. Infiltration into the surrounding tissue, extravasation. Okay? Osteomyelitis is not common. It is contraindication अगर osteomyelitis है उस bone में नहीं करना है. Because you will use for only small time. You won't keep it for prolonged. So chances are there. Autoimmune encephalitis. We had a class. Which of the following is false? We had a session on autoimmune encephalitis. NMDR is the most common antibody target in pediatric autoimmune encephalitis. MOG antibody related disease is associated with optic neuritis. Prolonged spindle or delta brush pattern EG is seen in MOG antibody disease. Temporal lobe epilepsy may be seen in anti-GAT65 related disease. I thought it was a very tough question. Very nice. So prolonged spindle and delta brush pattern is associated with NMDR related disease. It is not MOG. Very nice. So people are very aware of autoimmune encephalitis. Seriously, it is unexpectedly. Again, yeah. So death by neurological criteria. Slowly read. Ensure that systolic and mean arterial blood pressure for more than 5th centile is there. Exclude pharmacological paralysis if administration. Ensure blood and drug screen, urine screen if negative. One examiner is enough to declare brain death in children. Excellent. So the class, very nice session was there. So at least 2 examiners. The others, BP you have to keep correct. So all our sessions were very useful for you, I guess. Immunomodulation in PICU, which of the following is correct? IVIG, in your mobile it will be bigger, don't worry. IVIG and methylprednisolone has a definitive role. Therapeutic plasma exchange is recommended in all cases of MODS. IVIG has a role in toxic shock syndrome. High volume hemofiltration recommended for all cases of MODS. IVIG has role in toxic syndrome. Very many people want CVVH for all cases. Just now CVVH session happened. Kaushik will be very happy. Okay, that's of course UVH. Kaushik is there. Toxic shock syndrome is very common. EEG, morning neuromonitoring. Which of the following is false? So it helps in identifying non-convulsive status, helps to monitor the effect of neuromuscular blocking agent, helps while using barbiturated coma for raised ICP, helps to identify brain death patient. Hall B's program. So good for neuromuscular blocking agent. How can you see the in EEG? But others are correct. So please please use bedside EEG if you have in your unit. Very useful tool, underused. Poison antidote combination is incorrect. Just last session, iron antidote desperoxamine, opium antidote naloxone, isoniazide antidote pyridoxine, benzodiazepine, fomepizole. Expect 100% correct answer in this. Isoniazide is the antidote is pyridoxine. So, unexpected. Just now we had a class on antidote. हाँ, उटा fomepizole, not flumazenil. पढ़ना है. Which of the following is false regarding CRRT? Just now, read it. Adsorption, diffusion, convection, ultrafiltration. आपके मोबाइल में पूरा दिखेगा. Slide time भी ज़्यादा दिया गया है. Basic mechanism of CRRT. Mobile you can see, madam. In mobile देखते पावे. Excellent. CRRT very nicely learned. In convection, it is not pushed by pressure, right? It is solvent dragged. वो ही खींच लेता है. Excellent. Excellent answer on CRRT. CRRT questions people are answering very nicely. Last question. Easy question will come. Hemodynamic monitoring. We had a session in the morning. Which of the following is incorrect? CBP values may be unreliable if right ventricular dysfunction is there. A pulse pressure variation more than 30%, 13% indicates volume responsiveness. IVC collapsibility index of 18% or more suggests volume responsiveness. A rise in SCVO2, that means superior vena cava oxygen saturation, with a rise in lactate indicates improvement in shock. SCVO2 improve हो रहा है? Excellent. Hemodynamic monitoring people learned nicely. So, बंद कर दो. Incorrect. Rise in lactate with rise in SCVO2. Chalo. So you means rise in lactate is correct? That is improvement suggested. It is correct. We will discuss. Just hold on. So sir, sir will declare the result. Can declare the result? Sir will declare. देखाओ मैडम. না এখন খুলো না হ্যাঁ 5 সেকেন্ড টাইম এর মধ্যে এরা সব আছে তো এটা ডাউনলোড করে দিচ্ছি রেজাল্ট এই এখানে আছে না ওটা ডাউনলোড হয়ে যাবে এখন না পরে রেজাল্ট directly it will come to you na you are first you are second chalo display kore dao
so in the quiz the first prize goes to Vivek Mohapatro. Who is Vivek? Congratulations. Vivek, please come on the stage. Vivek, come here. In which college you are coming from? SCB Katok. So Vivek Mohapatra is the owner of the First prize in the quiz. I request Dr. Rohit to please hand over the first prize. Vivek. Second prize goes to Dr. Amrita Roy. কুইজগুলো রোহিত দিয়ে দিক সব কুইজগুলো রোহিত দিয়ে দিক ডাকবো ডাকবো Amrita is from IPGMER. And very nice. Third year. And the third prize goes to Nikhil Gupta. Nikhil is from ICH. Now I request Kalpana Datta ma'am to please come on the stage and give the prizes for the presentations. So we had a very interesting sessions of oral presentations as well as poster presentations. So we have lots of prizes, showers of prizes. So in the oral paper presentation, Hall A, we had first, second and third. So the first prize goes to Sarwar Hussain. Hall A, first prize Sarwar Hussain. Sarwar presented diaphragm and lung ultrasound indices in prediction of outcome of weaning from ventilation in intensive care unit. From Hall A, oral paper. Second prize goes to Dr. Ritika Bhakat. Ritika presented coronary artery involvement in children with prolonged fever admitted in PICU at Medical College, Kolkata, a prospective observational study. Congratulations, Ritika. Oral paper, Hall A, third prize goes to Dr. Abhijit Roy. Congratulations, Abhijit. Abhijit presented role of magnesium sulfate injection in acute severe bronchiolitis, NAR City. Medical College. Now I request Subhasis sir to please the next set of prizes. So now coming to oral paper presentation, Hall B. The first prize goes to Dr. Agrani Panda. Evaluation of real-time neutrophil gelatinase associated lipocalin directed খুব কঠিন renoprotective strategy in critically ill children in pediatric intensive care unit. Congratulations, Agrani. Oral paper, Hall B. Second prize goes to Dr. Aditya Haldar. Congratulations, Aditya. He presented transcranial Doppler and ONSD measurement and its correlation with clinical outcome in suspected REST ICT among children in a tertiary care center. Aditya, which college? National Medical College. Excellent. Oral paper, Hall B, third prize goes to Dr. Amrita Roy. Amrita presented a study on clinical epidemiological profile and predictors of VAP in a PICU. Amrita from SS came. Amrita from SS came. Now I request Prabha ma'am to please come on the stage. So next group is original article e-poster. We have very tough competition in that group. The first prize goes to Dr. Vivek Mohapatro from SCB Katok. Vivek presented outcome of renal replacement therapy modalities in critically ill children with acute kidney injury. Originally poster. Original article e-poster group A, second prize goes to Dr. Aheli Kundu. Aheli presented clinical predictor of scrap meningoencephalitis in pediatric patients with scrap typhus. Aheli is not there. না না আগেই বলে দেওয়া ছিল ওর বৃহৎ প্রাইজগুলো আমি পাবো কোন কলেজ লেখা নেই ওকে ওকে original article e-poster group A, third prize goes to Dr. Trisha Raychaudhuri. Trisha presented to determine the efficacy of ONSD measurement in monitoring the clinical improvement of patient with receiving hypertonic saline therapy for symptomatic hyponatremia. Which college? National Medical College. Fantastic. Congratulations. Now I request Sukanta Chatterjee sir to please come on the stage. So next category is original article e-poster group B. The first prize goes to Dr. Onurupa Mondol. Onurupa presented assessment of psychological status of children after discharge from pediatric intensive care unit. Onurupa? Very novel study. Onurupa Mondal? Is Onurupa is there? Okay. NRS. Onurupa's friend is collecting the prize. Okay. So original article e-poster group B, second prize goes to Dr. Keka Das from ICH. Trends of adenoviral illness is recent 3 years. Congratulations, Keka. Original article e-poster group B. The third prize goes to Dr. Akanksha Mishra from Apollo. She presented continuous renal replacement therapy data from a tertiary care hospital in eastern India. Now I request Ranjana ma'am to please come on the stage. The next category is, now we are coming to case report category. Group C. Case report category, Group C. The first prize goes to Dr. Ambati Karthik. Ambati presented congenital long QT syndrome. From which medical college? Apollo. Oh, Ambati from Apollo. Yes. Apollo Clinicals. So case report category, Group C, second prize goes to Dr. Somadip Bishwas from ICH. Congratulations, Somadip. So case report group C, third prize goes to Dr. Purbali Ghosh. Purbali presented a rare presentation of Bicasta encephalitis. Purbali from NRS. SSK. Purbali from SSK. Now I request Dr. Soman Mehu to please come on the stage and give the prizes. So next category is case report group D. The first prize goes to Dr. Saurabh Nandi. Saurabh presented a puzzling case of difficult to treat severe metabolic acidosis. Congratulations, Saurabh, from Medical College. Somendra is also from Medical College. Case report category, group D, second prize goes to বড় হলে সম্বন্ধে দেখতে হবে So the case report category, group D, second prize goes to Dr. Anup Chandran from ICH. Anup, where are you? আচ্ছা অনুপেরটা পরে আমি নেব আর কি করা যাবে So the case report group D, third prize goes to Dr. Riya Ghosh. Riya presented neuropathy in pediatric critical care. Riya is there? Which college? SSK. So Riya's senior is taking the prize. কিন্তু আগে বলা হয়েছিল যে আসতে পারবে না তাকে প্রাইজ দেওয়া হবে না Okay. For group E case report, I request Swapna madam to please come on stage. And so last category, group E case report. First prize goes to Dr. Rajdeep Saha. Rajdeep from Kolkata Medical College. Kolkata Medical College. Rajdeep presented suprarefractory status epilepticus, a formidable foe to physician. Second prize goes to Dr. Ritika Bhakat. একটা পেলে একটা ফ্রি buy one get two. Ritika Bhagat presented refractory Kawasaki, presented as Kawasaki shock syndrome. Congratulations, Ritika. Last prize, case report, group E, goes to Dr. Adhyasha Mishra from, I think she's from Tata Main Hospital. Adhyasha? I think Adhyasha from Tata Main Hospital. Tata Main Hospital. পার্টিসিপেন্ট সার্টিফিকেটের জন্য রাখবো নাকি দিয়ে দেবো those who are getting prize will not get the participation certificate. Those who are getting prize will not get participation certificate. So I think everybody is happy with the prize. Next year increase, like Lokkir Bhandar, every year increase.
I must congratulate Prabhas by donating the money and increasing the inspiration of youngsters. That's really inspirational. Thank you very much.
So thank you all the delegates for staying the day long with us and participating in various activities. I think you have all enjoyed the program. Next year, remember the date on the July 2025, we'll meet again. If any of the delegates want to say, now I want to call upon the stage Mr. Rohit Mukherjee. Please come on the stage. So Rohit is the backbone of this program, and this arrangement and meticulous thing would have not been possible without the help of Rohit. And delegates, please stay back for a group photo. All the delegates, please stay back 5 minutes for a group photo. Please stay back 5 minutes for a group photo. Please come on the stage for a group photo.